So good afternoon, respected faculties, delegates, and everyone present here. I, on behalf of Organizing Committee of Kolkata Pancreas Update 2026, invite you all to the fourth session of the KPU Update 2026. So welcome you all. We are delighted to invite you all to an exciting academic session with the most latest updates of the field. So to start with the introduction, may I request Dr. Sanjay Banerjee sir, Organizing Secretary, KPU 2026. He needs no introduction. So requesting our Organizing Secretary sir to start the session and give your welcome address.
Good afternoon, respected patrons, members of the faculty, delegates, colleagues, all my friends, ladies and gentlemen. On behalf of Kolkata Pancreas Club, we are delighted to invite you to the Kolkata Pancreas Update 2026 on this 13th of June 2026 at the Taj Talkuti, Rajarhat, Kolkata. Now we have faculties and delegates coming from different parts of the country and we are privileged to host them. This annual academic meeting is dedicated to advancing the knowledge, sharing recent developments and fostering collaboration in the field of pancreatic diseases. In this 2026 edition, which is season 4, after 3 previous successful seasons, it promises a dynamic scientific program featuring eminent national experts who are already here with us, who will present on the latest developments in the pancreatic diagnosis, interventions, and surgical practices. The event offers a valuable opportunity for all of us to engage in insightful discussions, network with the leading professionals in the field, and contribute to shaping the future of pancreatic care and in India and beyond. So we sincerely, on behalf of Kolkata Pancreas Club, hope that this conference matches up to its expectations and attendees are enriched by the deliberations and esteemed insights. So with this, I welcome all of you, those who have come from different parts of the country, our patrons, our teachers, our members of the medical faculty, my friends, colleagues in Kolkata, ladies and gentlemen, each and everyone who are present here, I welcome all of you in this conference. With this, we will start with the scientific program, and our first session is a panel discussion. Thank you.
So once again, welcome you all. We will start with an important panel discussion on predicting severity in acute pancreatitis. To moderate this session, may I request Dr. Mahesh Kumar Goenka sir. He needs no introduction. He is the Director of Gastroenterology, Apollo Institute of Medical Sciences and Multispeciality Hospital, Kolkata. Requesting sir to please come and kindly start the panel discussion by introducing the esteemed panelists.
Can you give me the list of the panelists? Yes. So, can I invite the panelists on the dais? Good morning, everybody. It's good to see all of you in the beginning of the day being here. Dr. Sudipto Ghosh, Dr. Debashish Mishra, Dr. Hemant Nayak, and Dr. Nadeem Parvez from Siliguri. Let me start while the panelists are settling down. So the topic which is given to me by Sanjay is predicting severity in acute pancreatitis, biomarkers, scores, or clinical intuition. Just on my way from my home now, I just looked at the PubMed and was surprised that there are 22,000 articles published on severity, predicting severity in acute pancreatitis in the last 5 years. So you can understand the importance as well as the controversy related to this subject because, of course, we do not have a unanimity. And that's why we have expert panel of 4 gastroenterologists from eastern part of India to help us in taking some take-home messages. And I can see some senior people sitting here. And of course, all of you can contribute to this panel discussion. So the first question is that why do we need to predict severity of acute pancreatitis? Before I address this to the panelists, I think we all know that there are 4 important regions for predicting the disease severity in any illnesses, more so in acute pancreatitis. The most important is triaging, where to keep the patient in the ICU or in the ward, whether we should refer the patient from a primary or secondary tertiary center to tertiary center. How do we prognosticate a patient's illness? How aggressive should be the therapy? And to conduct the trials, we always need to compare apple with apple, and so we should have a severity determined. Now, golden hours are there in medical emergencies. In cardiac and in cerebrovascular, it's 90 minutes and 6 hours. Fortunately for acute pancreatitis, it's 24 to 48 hours. So whatever you have to do to alter the natural history of acute pancreatitis, you must act in the first 24 to 48 hours. Otherwise, you have missed the bus. I would want all of you interested in the subject to go through this guideline, which is published last year in Pancreatology, in which Indian Pancreas Club plays an important role in association with some of the international societies. And you can get a lot of information from this particular paper. A prerequisite for predicting severity is that you should be sure that you are dealing with acute pancreatitis. In my practice, I find pancreatitis to be overdiagnosed as well as underdiagnosed, more overdiagnosed than underdiagnosed, slight increase in amylase and lipase, and people say it's acute pancreatitis. It is not. And so we have a very defined criteria for diagnosing. At least 2 of these 3 should be present: abdominal pain consistent with the disease, serum amylase and lipase more than 3 times, and characteristic findings from abdominal imaging. And we know that in 15% amylase may be normal. I think the life became easier with Atlanta classification in 2012, which divided pancreatitis into mild, moderate, and severe, and we all know about it, that moderately severe transient organ failure or systemic or local complication, where severe is persistent, and persistent means at least for 48 hours, single or multiple organ failure. And we know these are the organ failures we are talking about: systolic blood pressure, PaO2, creatinine, and GI bleed. And local complications, we know these are the terms. We now realize that organ failure can happen very early in the natural history of acute pancreatitis. And Marshall's score, which was modified subsequently, still holds true that anything in these parameters, which is 2 or more than 2, means that there is organ failure, whether it's respiratory, renal, or cardiovascular. And we usually calculate this in our day-to-day practice. So I think once you have an organ dysfunction already established, and if you establish in the early part of the natural history, you already are dealing with moderate to severe pancreatitis. But my question today, what we are discussing today with panelists, is how do you predict, in absence of organ failure, whether there is a possibility of developing organ failure? So the 4 terminology which are important is it clinical intuition and routine tests itself? Is it individual markers? And they are, every month we talk about a new marker which is coming up, composite scores, or it is imaging which will decide the severity of acute pancreatitis. So let me start with the case of a 45-year-old male, non-obese, who had severe epigastric pain, nausea and vomiting, obstipation. Blood pressure was normal, side tachycardia, temperature 38, abdominal was soft, but there was no guarding. And it was slightly tender, bowel sounds were absent, liver dullness was preserved, amylase lipase high, chest X-ray was normal. These were some of the initial tests which were done. Total count was high, hematocrit was 40, ALT 280, glucose 420, PaO2 65, creatinine on 1.4. So we are dealing with acute pancreatitis. The question now is clinical intuition important? Dr. Hemant, can you give us your opinion that when you see a patient like this in emergency, do you, by clinical examination or initial laboratory test, decide that are you going to deal with acute pancreatitis or severe type or mild type?
Hematocrit is within normal range.
Hematocrit is 40, so it's normal.
So in early phase,
Can you use the mic closer?
sir, in early phase, like harmless acute pancreatitis criteria, within 24 hours, if there is absence of abdominal signs like rebound tenderness, if hematocrit is within normal range, and if creatinine is within normal range, so that is qualifying the criteria of mild acute pancreatitis. If any one of the criteria is present, then it is not a case of mild acute pancreatitis. In future, this patient may develop a severe pancreatitis, and that patient need to be followed up properly.
So anyone else? Debashish, Sudipto, you want to add something?
I think this HAP score is very important when you decide that whether this patient you want to keep in the hospital where the ICU facility is there or not, or when you can discharge early this patient. If there is no rebound tenderness, if the hematocrit is 40 and if the creat is 1.4, then you are pretty sure that this patient probably has got no organ failure or unlikely to develop organ failure. But if the organ failure sets in, then HAP score will not have much importance.
So that's why I started my presentation by saying that the organ failure can happen on day one. And if the organ failure happens on day one, you don't talk about mild pancreatitis at all. So I think this is one score which is not very routinely used, but I think it's quite useful. And I was surprised to see that even in 2022, 23, 24, there are lots of articles on harmless acute pancreatitis score, or HAPS. And what is interesting is that these have used within 30 minutes of reaching the hospital. So you apply this score within 30 minutes of reaching the score. So these are only 3 parameters: peritonitis, creatinine of more than 2 milligram per deciliters, and hematocrit more than 43 for male and more than 39.6 for female. And if all 3 are present, this is not harmless acute pancreatitis score. And if all 3 are less than 3, then this may be a harmless acute pancreatitis score. I think this is a score which is underutilized. There's a medical calculator which is available for everybody to just use it, but it's very simple. So one can go by this score and decide whether we are dealing with harmless pancreatic score. And this is a meta-analysis of 20 studies published in 2021, which have found a positive predictive value of 97%. So if harmless pancreatic score is not present, with 97% accuracy, you can say that this patient is not going to have severe acute pancreatitis. And this is an Indian study which I looked at, and it found that if there's a harmless pancreatitis score which is not 3, then the chance of positivity of bicep is only 11%. Majority of them would have a very easy natural history. There's another score which is more clinical than biochemical, is PAN-C, which is as compared to the HAP score which I talked about, is within 30 minutes of arrival. This is within 24 hours. And this again depends on hematocrit. 44 and 40 is the cutoff value used. BMI, interestingly, so the BMI for this value has been taken as 30 kg per square meter, and presence of pleural effusion. And a score of 3 is highly specific for severe acute pancreatitis. So these are the 2 scores which I thought I'll talk about when we talk of clinical intuition combined with some initial laboratory tests. Now let's talk about individual markers. Dr. Mishra, every month there is an article which is published that this is a new marker which has come up and this may possibly solve all our issues. So do you believe in individual markers? And if yes, which are the individual markers you are looking at?
Not only the individual biomarkers, we look as a whole for the patient, but if biomarkers have to be dependent on, probably we would like to do which are easily available. One of them is CRP, C-reactive protein. The other individual biomarker which predict severity and compared to other biomarker which have fared better, maybe interleukin-6, but this is not widely available and maybe more costly. So for individual biomarker, CRP may be the better option to choose.
Nadeem, you want to add something to this? Okay. Nadeem, your mic, please. I know Siliguri has become very close to Calcutta, but still you need to use the mic. Yeah.
I think 48 hours, at 48 hours, if the CRP is more than 150, that definitely signifies there is poor prognosis and the presence of necrosis. So 48 hours CRP is very effective.
Nadeem, you wanted to say something.
But that CRP is done at 24 hours. So at presentation, I think there is no marker as such which can predict the severity of pancreatitis other than the usual like blood urea, nitrogen, and the bicep scores which can help.
So we'll come back to the scores later on, Nadeem. The single biomarkers, the number of them, as I said, every month we hear about a new single individual marker, and these are some of them which I've enumerated here. Elevated hematocrit, BUN, CRP, as we talked about, creatinine, IL-6, procalcitonin ratio of neutrophil to lymphocyte, triglyceride, calcium, and so on. But this is a study which I liked, and I went through this meta-analysis of 29 studies, which said that possibly out of all these, interleukin-6 is one which is very high sensitivity and specificity. Now, we have started using interleukin-6 through the COVID time. So, in all the laboratories, I think interleukin-6 is available. It's not so costly. And a cutoff value, people have used different cutoff value of 50 picograms per ml has a sensitivity of 87 and a specificity 88%. So this may be one individual markers, whether done at the admission or in 48 hours, can be useful. And the other one which has been recently used more and more is immune inflammatory response, where we have this systemic inflammatory response, which is, I've given the formula here, neutrophil into platelets by lymphocytes. Of course, NLR is being used many places, neutrophil lymphocyte ratio, and so on. And this study looked at various values and found SIII to be very specific and NRR to be very sensitive as individual markers. Now, let me move to the composite scores, and I would want Sudipto to look up this. Do you really use Sudipto's composite scores in your day-to-day life, or they're all theoretical?
I think it's very difficult to remember the very complicated scores. But with the score which we can use as a day-to-day life is the Bishop. But the Bishop is quite a good score when you use it in first 24 hours of admission, which involves the whether there is a presence of SARS is there, or age more than 60, or there is hematocrit and other values. And if the Bishop score is more than 2, then you know that the prognosis is guarded.
So anybody from the house wants to say that what is their practice in using the scores while you're dealing with acute pancreatitis? Ajay, do you use it? Composite scores? Can somebody, can somebody pass on the mic to Ajay? Or Manu can speak.
We have the access to all this and we do get it done, but the decision is ultimately based on the clinical sense. And there has been a studies to compare all the composite scores, individual biomarkers with the clinical assessment, and there's not much difference in that.
So in next 1 or 1.5 minutes, I'll just run through some of the scores for youngsters who are there. These are the list of the scores which are available. When I was doing my MD and DM, we mugged up Ranson scores which had 0 and 48 hours and 6 and 5 scores, and we thought that this is all we need to know. Nobody talks about Ranson score, nobody talks about Glasgow scores. People do talk about Apache too, particularly the critical care people, because they use it for all the illnesses and they talk about Apache score. But as was pointed out, for us, SIRS and BICEP is possibly one which we use more frequently. So Glasgow Emery score is no more used. This is about 8 parameters, more than 3 criteria. Apache is still being used in some of the critical care units because the critical care people are more used to use this for any disease which they are treating, and this has about 12 or 13 physiological parameters, age and Glasgow Coma score compounded together. But I think what we do most commonly is using SIRS criteria. I think this at 0 hours and 48 hours is one which we practice in our ICU regularly, and this has been recommended. I will just show you the data. Temperature more than 38 or less than 36, respiratory rate of more than 20 or a PSO2 of less than 32, pulse of more than 90 beats per minute, a WBC less than 4,000, more than 12,000, or more than 10% immature bands. And as was said, if it's persistent, that means lasts for 48 hours, then the mortality can go as high as 25%. And the guideline which I talked about has concluded, and I would say that SIRS at admission and at 48 hours after pain, with or without CRP or IL-6, may be the best practical marker or composite score to be used. So 2 or more SIRS criteria fulfilled at admission or at 48 hours after pain, combined with one of these individual scores, either CRP or IL-6, may be the one which can be very easily used, and we do it on a routine basis all the time. Biceps is a little addition of SIRS where we include age, pleural effusion, impaired mental status, and BUN, and possibly it's almost the same significance as SIRS is. Now, PASS score is hardly used, but this has a wider range, and these are 5 criteria or parameters: organ failure, for each organ failure 100 score, intolerance to solid food 40 scores, systemic SIRS is given 25 per criteria, abdominal pain from 0 to 2 and 5 per abdominal pain score, and the requirement of morphine, and then you classify that mild, moderate to severe and poor as per this. Now, as I said, there are thousands of papers looking at this, and this is a meta-analysis of 43 studies, 14,000 patients, and they found aperture to bicep and ransom to be almost 50% positive predictive value when it is positive, but a negative predictive value was very low. So if they are negative, that doesn't mean that the patient will not develop severe pancreatitis. Finally, what about imaging? Nadeem, what do you use imaging for scoring, and when do you use it, and what is your protocol?
So the most important imaging is the contrast enhanced CT scan, which should be done after at least 7 to 2 hours of the onset of the symptom to document. This is the most important tool to document the severity of the pancreatitis, whether it is necrotizing or non-necrotizing, whether there is local complications or not, whether you have fluid collections or you have vascular complications or not. So that is the contrast enhanced CT is the most important imaging which should be done. In most relevant settings, it should be done after 72 hours. But sometimes when the diagnosis is in dilemma or there is worsening of the patients, you can do early on. But to document, it's better to do it after 72 hours.
Hemant, Debashis, you want to add something to this?
Only just, I agree with him that in the initial phase we would require CT scan only for diagnostic dilemma. But as most of the acute pancreatitis are of mild severity, so probably we would not routinely do CT scan at 72 hours. If the patient have severe features of severe pancreatitis, only then maybe in our centers we prefer after 7 days, not routinely at the 3rd or 4th days. After 7 days, if the patient is having severity, then we will go for
I think
that.
one thing which we have failed in our day-to-day practice is that telling the emergency people that please don't do a CT scan if the diagnosis is very clear. Wait for the mileage and lipase value to come, and the mileage and lipase is abnormal, and the patient has characteristic pain. Please avoid doing a CT scan. May do an ultrasound just to rule out a gallstone. But we have failed. We often find that the patient is transferred to the ICU with a CT scan, which possibly underscores because it has been done very early. So I think a CT scan, it is important that when you do it, and how you do it is also important. Multi-detector, pancreatic and portal venous phases, 100 to 150 ml of non-ionic IV contrast. I personally strongly believe that doing a non-contrast CT is almost useless. I mean, it doesn't give you any information. Multiphasic should be predominantly done if you are thinking that there is a pseudoaneurysm. The definition of necrosis is that the CT attenuation value of less than 30 to 50, or after weak contrast, if the rise in Hounsfield unit is less than 15, then you think of necrosis. MRI we don't do routinely except when CT cannot be done. And this is the severity index which Nadeem talked about, that now modified index has pancreatic inflammation 0 to 4, pancreatic necrosis again 0 to 4, and extra pancreatic complication has been added in this modified, which includes pleural effusion, ascites, and vascular complication, which can be 0 to the highest score possibly is 10. And this is how a normal pancreatic outline looks like. This is inflammation around the pancreas, single peripancreatic collection, multiple peripancreatic collection, and gas and necrosis inside. And a necrosis of this degree will make a score of 4 for the necrosis. So the patient which appeared to be benign, except that the leukocyte count was high, actually his CT severity index after day 5 was 8 by 10. So you can see hardly any parenchymal seen. So all these scores may fail in a given case. And we know that CT severity index collaborates very well with the morbidity and mortality. But what has been pointed out, that is collaborates good with local complications. Whether necrosis will develop, walled-off necrosis will develop. It does not collaborate so well with the organ failure, because for the organ failure, there are many more factors. Ischemia is not the only factor, and that's why the CT severity index is more for local complication than anything else. MRI, as I said. Now, no discussion can be over nowadays without talking about artificial intelligence, and there are many, many platforms which have been developed, but one which attracted me is this Easy app, which is again, we'll just finish in 1 minute. Looks at mostly clinical components, respiratory, temperature, abdominal muscle guarding, gender, age, and glucose level with an accuracy of 89%. But I'm sure artificial intelligence is an ever-developing platform, and we'll hear more and more in the coming days. Any concluding remark by any of the panelists or from the audience, anybody?
I just wanted one comment regarding the scores, sir. Because basically scores has to be standardized. Because if you apply like MELD score for chronic liver disease, so clinical judgment is of course the best thing, but of course some scores should be taken into consideration, because it will be a standardized stratification. So that's what my comment was.
So, Hemant, you want to say something?
Hematocrit at presentation, first into hematocrit value, blood urea nitrogen value, or serum creatinine value, that is useful marker which will predict the severity.
So what I think everybody is saying is that we should go with clinical intuition, which it can include a HAP score, which is hardly being used and can be used more and more, very easy, just 3 pointers. Then in our practice, in our unit, and we have many patients with acute pancreatitis admitted anytime, we depend on SIRS more than anything else, SIRS at 0 and 48 hours. And nowadays we have added IL-6 as an additional parameter, which is easily available, not very costly even in our setting, to add on to the sensitivity and specificity. And the CT scan cannot be re-emphasized, should not be done in first 3 to 4 days, should be done only after 4 days to get the correct assessment, with the exception when there is a differential diagnosis problem and you're not sure whether you're dealing with ischemic heart disease, some form of non-pancreatitis disorders, then only you do the CT scan in the early days. So if there's no more questions or comments, we'll close this session. Thank you very much.
Now I request our esteemed panel moderator and panelists to kindly move toward the felicitation area for the felicitation. I request all of them to kindly move to the felicitation area for the felicitation. Meanwhile, we proceed to our next session, which is on early analgesia and nutrition in acute pancreatitis, evidence versus challenge. To chair this session, may I request Dr. Kingshuk Das sir, eminent gastroenterologist, Dr. Rupa Banerjee madam, Dr. Subroto Pal sir, Dr. Bashav Bijoy Sarkar sir, and Dr. Paramita Bhattacharya madam to please come on the stage and start the session by introducing our speaker.
I think we started the meeting in a very good way. And to start with, obviously, a session like acute pancreatitis and then which score you use. I think whatever Professor Goenka has said, that still a roll up. Today morning, I was discussing with Dr. Uday Ghoshal that where is clinics now? Are the clinics dying? So Dr. Goenka has raised a very important point that clinical intuition, when the patient reaches the emergency, possibly plays a huge role. But the other way I was thinking, sitting on the row, that as you put on going scores and your residents, the in charge people starts looking at these scores, we forget managing the severe pain these patients are having in the emergency and your GITU or intensive care unit. You forget about the nutrition of this patient over the next 72 hours or so. So to speak to us is no better person than Professor Ajay Kumar, who was our teachers. He is the teachers of teachers. And he started 40 years back from the GB Pant. And from there, he spent his life nearly there. And now he is there in Max and BLK. And he is the head and chairman over there, sir. And always we get something on pancreatitis in some insights every time we listen to you. It's all yours, sir.
Thank you, Dr. Kinsuk. It's always a pleasure to be here for this wonderful meeting, totally focused on pancreas. And thanks, Sanjay, for organizing this as a wonderful new place to be here. Well, friends, as rightly the stage has been set by Mahesh, talking about the severity, assessment of severity of acute pancreatitis. Once the patient comes to us in the emergency, in the triage, after doing the triaging, if you look at the various things which are matter in the initial phase of the management, after the fluid management, the most important thing which simultaneously starts working is the management of pain and then the nutrition, which are the only things which may change the natural history of acute pancreatitis. Other than that, so many modalities have come, drugs and other interventions, but none has actually changed the natural history. So my job is to talk about pain management in acute pancreatitis as well as the nutrition. When we look at the analgesics, obviously you have long list of NSAIDs and the opioids, and all of them have been tried from time to time. But when you scan the literature, the evidence for each is very poor. But when we select any analgesia, the two things which we basically concerned more about the safety, that when you have an acute kidney injury or you have a GI bleeding, then we tend to avoid NSAIDs. And if you have an ileus and respiratory depression, we cautiously use opioids. And of course, we all know which drugs are these. As I said earlier, that there is not much good data, but in the last decade, there have been about 5 or 6 trials on this, and out of which 3 have come from India, 1 from All India Institute, 2 from PGI Chandigarh. And surprisingly, in this era, people have compared pentazocine with diclofenac. And in fact, in our hospitals, pentazocine was blacklisted many years back and not being used. Anesthetists don't allow us to use that. And diclofenac, we are always skeptical because of the kidney injury. And so that's one has to see. One study from PGI which showed that buprenorphine is probably better than diclofenac. But then we come on to the meta-analysis or randomized controlled trials. If you look at this particular meta-analysis published in 2021, that the 12 studies, with 83% of these were mild pancreatitis. At the end of it, conclusion is NSAIDs and opioids are equally effective in decreasing the need for rescue analgesia in patients with the mild acute pancreatitis. And then came the talk about epidural anesthesia, because people postulated that probably it increases the pancreatic circulation and it may actually benefit the pancreas and cut down the severity in addition to the pain relief. And this particular review article, systemic review and meta-analysis, which showed that it may be effective in not only reducing pain, but increasing pancreatic perfusion and reducing mortality. Here, based on this, we did a study, our postgraduate thesis, yet to be published, but we did not find much difference in the two. Number 2, then we realized that if you go for epidural, you need a trained personnel to handle it. Number 2, it's an inconvenience for the patient, and it gets blocked in the middle of the night, then you have another problems to manage that. If you look at the World Society of Emergency Surgery guidelines published in 2019, and they said there's no much evidence or recommendation. It's only by negative things that NSAID should be avoided in acute kidney injury, and epidural can be alternative or agonist to IV analgesia. So, as usual, strong recommendation, but very low quality evidence. After going through all this, what is our current practice? This is our protocol. We preferred NSAIDs, and we are basically using paracetamol around the clock over the opioids. And next line is tramadol. We start with the SOS, and then we can change to 8-hourly. And if it doesn't work, we take the patient in for a fentanyl infusion. And that's the reason when, for that particular thing, we have to take all these patients to the ICU. And patient-controlled anesthesia is preferred. We reserve diclofenac for select group young patients without kidney injury and as SOS medication, not around the clock. And we do not use pentazocine at all. And this is our hospital's, our department's protocol. Now, after we've gone through the analgesia, let's look at the nutrition, which is the single most factor changing the natural history and complications after the fluid management. But question is, why is it important? There are a number of reasons for that. This is the inadequate intake because of number of reasons of food intolerance, poor appetite, vomiting, and so on. And there is a poor absorption and gut barrier dysfunction. And then there is an increased catabolism and complications in some patients like gastric outlet obstruction, ileus, and so on. And all this leads on to negative nitrogen balance, and this leads on to malnutrition in acute pancreatitis. When we were students, we were all taught the only treatment for acute pancreatitis is giving rest to the pancreas. And it was considered that the decrease in the pancreatic stimulation helps in reducing inflammation of the pancreas. And the way you decrease the pancreatic stimulation is by stopping oral food intake. So nil by mouth used to be the standard treatment that we practiced during our postgraduate days even. But this further increases the need for nutrition support. So if you look at the mild pancreatitis, let me tackle both the things separately. Now there is a significant number of studies available that in mild pancreatitis, we should be starting on oral feeds as early as possible, usually within 3 to 5 days. And there is a study from AIG, Manu is sitting here, published in way back in 2008, that the liquid diet versus low-fat semi-solid diet, there is no difference. You can give the soft diet right in the beginning. But there has been a study again which says even full solid diet can be started as the initial meal. I will leave it to basically patient's tolerance and preference and not to stick to the fact that you need to do that. And 80% are able to tolerate oral diet within first 1 week. And those who cannot be fed for some reason or the other because of the pain, patient's intolerance or nausea, vomiting, then of course you need the nutritional support. So the refeeding in mild pancreatitis is usually within 3 to 5 days. And these are the patients who are usually pain and vomiting free. They have a near normal amylase lipase and there is no ileus. But if the patients, the data shows that pain relapse is more common in patients who have a prolonged pain or lipase is more than 3 times or Balthazar score is higher. But the main challenge is the nutrition in severe acute pancreatitis. It's not only a challenge, it's the most important thing which we tend to ignore sometimes. We do get patients from the periphery who are coming after 5 to 7 days and all are nil orally, Ryle's tube and so on. And I think that's something which we need to educate our colleagues in the physicians and the peripheral centers that they need to take care of that. Let's handle these 4 questions one by one. Who needs nutrition support? Almost all of severe pancreatitis, which comprises 20% of acute pancreatitis, and it has been shown that the patients with positive nitrogen balance do better than those with negative nitrogen balance. If we say that, then how do we feed? Because the initial principle was that you need to give rest to the pancreas, so first thing that people tried is total parenteral nutrition. And this is what happened in the early 90s. And the rationale is the same which I talked about earlier, that to give rest to the pancreas and thinking that the patient will not be able to tolerate oral. But the point here against was that if you do not feed orally, enterally, not orally, I'm talking about enteral feeding, then there is a gut atrophy, gut wall edema, and there's more increased bacterial translocation, that is more chances of getting infected pancreatic necrosis and the risk of hyperglycemia. Then TPN is also more costly and has more metabolic complications. And that's where the concept of enteral nutrition came. And when the enteral nutrition, because patients are not able to tolerate orally, then the concept came of nasojejunal feeding, whether you put it under endoscopic or a radiological guidance. Please remember, when we talk about NJ feed, it's about 100 centimeter beyond DJ junction, not before that. That's what exactly it is. And this is a wonderful meta-analysis by Petrov et al. It actually published from New Zealand, and it showed that when the infection rate of the necrosis reduced by almost 60% when you are using enteral nutrition as compared to parenteral nutrition. So benefits of enteral nutrition is that it reduces the multi-organ failure, it reduces systemic infections, it reduces local septic complications, it reduces surgical interventions, and improves gut barrier dysfunction, and reduces mortality. So there's nothing could be more effective. This is the only thing which is really effective in the management of acute pancreatitis as we understand today. Then came this study in 2000 by Etok et al. They studied 26 patients with a nasogastric feed. But I like to highlight here that when you talk about nasogastric feed, it is not a bolus feed. It has to be a continuous infusion, because if you give in bolus, it doesn't work that way. And they have showed that it is also well tolerated in majority of the patients, and there is no evidence of clinical or biochemical deterioration on commencing NG feeding. After that, there have been 3 more trials, one from All India Institute of Medical Sciences, but there is apprehensions of nasogastric feed is increased aspiration or worsening pancreatitis. Apprehensions of nasojejunal feeding tube is only one that you need expertise to put that. For a specialized center is no challenge. It's a very simple, and it may be a bit more expensive, but it's not something like that. That cost is immaterial. So NG feeding, nasogastric feeding, severe acute pancreatitis appears safe, well tolerated, and possible. But I'll admit that in our center, even today, when we have to give enteral feeding in severe acute pancreatitis, majority of the time we are sticking to the nasojejunal feed, except for the patients who are coming late. So now the next question is when to start. I think that's very important for us to understand, because there is a systemic review again by the same Petrov et al. Published in 2009 that to be more effective in preventing multi-organ failure, pancreatic infection and mortality, it has to be started within first 48 hours. Though the Dutch group has shown that if you're starting at 72 hours, there's not much difference whether starting from 24 to 72 hours, and this is a NEJM study in 2014. But the basic message here, that when you have to start enteral nutrition, please start within first 24 to 48 hours, but as early as possible. And in severe acute pancreatitis, the carry-home message is enteral nutrition within 48 hours compared to late enteral nutrition shows a significant reduction in mortality, multi-organ failure, surgery, systemic infections, and localized septic complications. So friends, what are the current recommendations? That enteral feeding should be started within 48 to 72 hours, 72 hours as per the Dutch protocol. NG or NJ depends upon tolerability. Optimal feeding formula is unknown. I'll talk briefly about that. And monitor for hypertriglyceridemia and hyperglycemia. Only those patients where there is a contraindication like a gastric ileus or a ileus, then you go for a TPN, otherwise not. And what to feed? There are no specific advantage of any special feeds, and this also, all the nutrition meta-analyses have come from same group. It's a John Winsor's group actually, and polymeric compared with semi-elemental formulation does not lead to a significantly higher risk of feeding intolerance, infectious complications, or death. All these immune-enhancing enteral feeds have been tried in individual trials, but they have not shown any specific advantage in the patients of acute pancreatitis. So the carry-on message is, my second last slide, is that severe acute pancreatitis is helped by supplemental nutrition. Enteral nutrition is safer and better than parenteral. Enteral can be provided by NJ feeding tube. Last word on NJ versus NG is not out as yet. Early enteral feeding, rather I'll add another word, it should be subjective, but there's no contraindication to NG. Early enteral feeding within 48 hours of onset of acute pancreatitis is recommended, and special diets have no advantage over polymeric diets. And supplements are also not routinely recommended. So unanswered questions in this, that what is the nutrition guidelines in moderately severe, because this quantity was defined later on. We don't have a separate categorized data, and we maybe require more evidence on nasojejunal or nasogastric, and of course more evidence on supplement. Well friends, I close my presentation by showing you this particular slide, that no area in the medicine has shown such a dramatic change. Since we started, we had in the last 30 years, starting from fasting, that nil by mouth, to TPN is better, and then showing early jejunal feeding is safe and better, and then showing it is superior, and then showing gastric feeding is as good as jejunal feeding. And so that's it. Keep alarm. But do not underestimate the value of nutrition in acute pancreatitis. Thank you very much.
Sir, there is a paradigm shift in the understanding and the current management protocol regarding this management of acute pancreatitis. But the early analgesia, how does it help to prevent or to improve the outcome of acute pancreatitis?
Early analgesia is not there to improve the outcome of acute pancreatitis. It is basically to make the patient comfortable. Patient has come to you with a major complaint of pain. And that's the reason it becomes the most important thing to give relief to the patient. And if you're not able to relieve the pain, even other treatments you will not be able to institute, including nutrition and fluid management.
Thank you.
No, I think this was a crystal clear presentation, and more than questions, I'd just like to ask you, sir, that when a patient comes with pancreatitis to you, what is the sequence of events that you would do in your practice? Like the patient is complaining of pain, so which analgesia would you normally use? And do you change based on the severity of the pain, or how do you decide? Or is it just a protocol? Every patient who comes goes through the...
I think given that protocol that we follow, we are starting round the clock SOS, whatever you are giving SOS immediately. Then we are starting with a paracetamol round the clock injectable and tramadol SOS. And if the patient is requiring more often, then we give it round the clock. And only then within 24 to 48 hours, if we find that the patient pain is not coming under control, we'll take the patient to the ICU and start on fentanyl infusion.
What is
Epidural, we are not using routinely.
And what is your protocol on if patients are not really coming at 24 hours or 48 hours, you get so many patients, do you still just start enteral nutrition and add any antibiotics? And when do you add
nutrition has to be started, but the distinct advantages of preventing the complications, the best benefit is within 48 to 72 hours. But even after that, I mean, when we are talking about nutrition in acute pancreatitis, we are looking at changing the outcomes. But even after that, a lot of patients who are not able to tolerate, we need to supplement nutrition. Yeah.
We'll just ask Indojit just 1 minute, then Dr. Tiwari or critical care head of gastroenterology of Apollo Hospital will ask the question. But before that, sir, Dr. Ajay Kumar. See, this very interesting analgesia part you have already covered very well. I was thinking of nutritions that we are, one side we are saying don't do a CT before 72 to 96 hours, and you are deciding on necrosis. You are saying at 72 to 96 hours that this is severe, more than 30% necrosis, and you are asking that nutrition you start in 48 hours enteral nutritions. So is it dichotomy there, or your clinical intuition, as Professor Goenka says, is always important that this is the patient, possibly I'm going to get a severe pancreatitis at 72 to 96 hours on CT, but we start enteral nutrition before that at 48 hours.
See, the reason is that first thing, CT tells you about the necrosis, that most necrosis, they're likely to behave as severe. But that is not the only or the whole criteria to diagnose severity. We discussed, Mahesh discussed beautifully that in most of the time we'll take a decision on the clinical assessment or the scores, whichever system you want to follow. You are not waiting for the CT to diagnose it as severe, because CT's full development of necrosis may take 3 to 5 days, and that's the reason. And so it doesn't give you a clear picture. So that's the reason that argument that you wait for the CT to start nutrition doesn't matter. If your clinical assessment is predicted severity.
Yes, sir. That's the message I thought.
Yeah.
That's the message. Indojit, it's the last question. Indojit.
Sir, repeatedly I'm asking this question several times in the part of nutrition. Most of the studies suggesting nasojejunal versus nasogastric as the same outcome. But our observation that in subset of patient when gastric outlet obstruction or gastric aspirate is like more than 1 liter, 1.5, 2 liters, or patient requiring NIV support when we have to do the continuous RT aspirate. In that subset of patient, putting a triluminar tube, feeding jejunostomy triluminar tube versus the double lumen, what we usually put in the nasojejunal tube, it is far advantage in continuing the treatment. So, sir, what is
Absolutely
your
right. When you have a situation like that, you can't even think of a nasogastric, it has to be nasojejunal. And nasojejunal tubes are almost all are triple lumen, because you have a gastric lumen to aspirate and you have a jejunal lumen to feed. The only patients where you will not be able to give when is a gross ileus or there is some obstruction in the transverse colon area or somewhere distal to that, then obviously you can't do the entire nutrition.
So we can put in the algorithm somewhere higher to putting this nasojejunal triluminal tube in the feeding protocol.
I'm sorry,
Can we put it in a protocol, a subset of patient, putting this nasojejunal tube as a feeding management?
Yes.
Triluminal.
No, nasojejunal tube is the preferred in our practice, that's what I said.
But the studies are always...
Nasogastric has done about 3 to 4 studies and they said the words used are, it is feasible. They is not saying it is preferred.
Thank you.
Thank you. Now we are closing this session. If there is any more question, you can ask over the lunch. Thank you.
Thank you.
Now may I request esteemed speaker and chairpersons to please move to the felicitation area as we proceed to our next session. So our next session is on infected pancreatic necrosis. To chair this session, may I request Dr. J.R. Mohapatra sir, Dr. Pawan Rawal sir, Dr. Rakesh Khan sir, Dr. Indrajit Tiwari sir and Dr. Kaushik Chatterjee sir to please come on the stage. They need no introduction, they are all well known to us. So I request them to please start the session by introducing the speaker.
I think Jahangir needs no introduction. He is from AIG. So what he will be doing is talking about antibiotics, antifungal and drainage of infected pancreatic collections. What is the right choice? He has to review on that.
So thank you sir for that kind introduction, and I thank Dr. Sanjay Banerjee and the team of Kolkata Pancreas Update for the kind invitation and the opportunity. So I'll be talking about primarily infected pancreatic necrosis and 3 most distinct and important aspects in the management. These are antibiotics, antifungals and drainage. So to make a right choice between the antibiotics, antifungals and drainage, the most important thing is when to use and exactly what is the right timing. Because if you look at the natural history of acute pancreatitis, it's very difficult to exactly know whether it's a sterile or infected pancreatic necrosis. So there the role of antibiotics, and we need to make a right choice. The second important thing is antifungal. So there are no clear guidelines when to consider, at which stage of clinical algorithm they are required. And the third important thing is when to consider drainage, how long to wait and how to go further. So the main learning objective of this talk would be to approach systematically the management of infected pancreatic necrosis, and the evidence-based literature I am discussing the landmark trials and the recent guidelines that are published. So as I already said, between the 3 components of infected pancreatic necrosis management, the most important is timing of each one or when to consider which one. So before going into the actual topic, let me just take you through the natural history of acute pancreatitis. In majority it is mild in 80%, in about 20% it is severe, and in severe in about 2/3 they develop sterile necrosis where the mortality is less. Whereas infected pancreatic necrosis occurs in about one-third of the patient, where the mortality is high as much as 35 to 50%. So that's one thing. And the second important thing is, in the natural history, any outcome of a disease is decided primarily by the mortality. And in acute pancreatitis, there are two specific reasons for the mortality. One, in the early course of the disease, due to systemic inflammatory response, which is responsible for the primary organ failure, causes maximum mortality. After the first week, the second cause of second or late onset organ failure is because of the infection in the pancreatic necrosis, which is responsible for again for the mortality in about 30% of the patients. So we need to understand that mortality after the early phase is primarily decided by the infection in the pancreatic necrosis, and we need to clearly understand how to approach further. So first, coming to the first topic of discussion, that is antibiotics in infected pancreatic necrosis, when to consider. Here, whether to consider prophylactic antibiotics and when to consider as a part of the treatment for infection, which antibiotics and why. So coming to the prophylactic antibiotics, earlier there was a lot of discussion about the prophylactic antibiotics, and the main rationale for this was, as we all know, mortality is high in infected when compared to sterile necrosis, and the main treatment was operative debridement earlier, where the morbidity and mortality was high. So the rationale was, if we can treat or if we can prevent the infection in sterile necrosis, maybe we may improve the morbidity and mortality. So this was the main rationale, by treating the sterile infection by preventing the infected pancreatic necrosis. So various randomized, well-designed controlled trials were published. Based on these trials, almost 7 meta-analyses were published, and earlier data showed there was a beneficial effect with the prophylactic antibiotic, but subsequent antibiotics showed no benefit. So this meta-analysis I am discussing here, this is in 2015, almost 11 studies included 864 patients, and there was no difference in the all-cause mortality, and they were not helped in the preventing the infection. So overall, the conclusion of meta-analysis was no benefit. So having understood that there is no role for prophylactic antibiotics, but if you look at the antibiotic usage globally, this was a data collected from 22 countries and more than 9,700 patients. The variation in antibiotic use was almost 31 to 82%. And the parameters they used were amylase, lipase, WBC, CRP, which are very non-specific. And the final consensus was there is no rationale to start antibiotic. And there was a suggestion that maybe procalcitonin may help. So before going into how to treat with antibiotic, we need to understand what exactly is the timing of the infection in acute necrotizing pancreatitis. Usually infection starts around day 10 of the pancreatitis, and gradually there is increased risk of infection, with a maximum risk of infection is at around 14 days. That means end of the second week. So we need to understand this timing so that whenever there is a fever, then we can think of infected pancreatic necrosis. How to suspect or confirm, primarily based on the clinical criteria of the patient, both not only the fever and the presence of organ failure. And another important cause is we need to rule out other causes of infection like urine or respiratory or other catheter related infection. We should consider WBC, CRP. Procalcitonin is one important thing that I'll discuss, and blood cultures are important. If there is a positive blood culture, then we can consider antibiotic. And presence of a gas bubble on CT scan was a lot of discussion, but the exact frequency is not very clear. So this is a ProCap trial, so which actually looked at around 260 patients, which divided into 2 groups, where antibiotics were given based on the procalcitonin elevation, and in other group only as a fever was the indication. And they monitored the sequential test day 0, 4 and 7, and then weekly onwards. If you look at the antibiotic use in procalcitonin guided, it was 45% compared to 63%. That means there was a 18% reduction in the antibiotic usage if we take procalcitonin as a guide or marker, and there was no difference in the important parameters. The third important aspect is which antibiotics and why. So if you look at the antibiotic penetration in the pancreatic necrosis, there is a highest penetration for carbapenem group, including imipenem and meropenem. Ciprofloxacin has the next, subsequently metronidazole, piperacillin, and third generation cephalosporins. So the first line choice is imipenem or meropenem whenever we are suspecting infected pancreatic necrosis. Alternatively, we can consider ciprofloxacin or metronidazole. So these are the antibiotics we need to consider when there is an infection. If you look at the major guidelines, what they are saying about antibiotics recently from AGA or ESG or IAP guidelines in 2025, antibiotics play an important role in the management of infected pancreatic necrosis, and there is no role for prophylactic antibiotics. Coming to the antifungals, on the same important issues I would like to address. What is the literature says about the prophylactic antibiotics? Before that, we need to know what exactly is the incidence. We can see around 22 studies, more than 2,000 patients. The risk of fungal infection was 26. It is almost variable between 20 to 40%. And who are the patients that are most risk? Patients who are prolonged antibiotic use, chronic catheters, and persistent fever. So these are the important clinical clues. So whenever there is already antibiotics are going, already effective drainage strategies adapted, still the patient is sick, organ failure is there, then we need to consider antifungals. Candida albicans is the most common antifungal, and amphotericin B is considered in these patients. So when to consider antifungals, as I said, we need to consider when there is a positive culture of fungal growth, definitely an indication. If that is not there, we need to look at the high risk features and the clinical behavior of the patients. Despite of antibiotics and drainage, organ failure is there, then we need to consider antifungal. So prophylactic antifungals, there is no role for major guidelines, but antifungals should be considered when the clinical suspicion is high, when the patient is not improving. Coming to the third aspect of my talk, that is drainage. So in these three important areas I would like to address. One is when to consider drainage. Can we consider early, or what is the ideal time? Which route should be adopted, and what strategy for the necrosectomy should we consider, step up or upfront? So this is the old revised Atlanta classification, which clearly shows that it requires at least 4 weeks for the wall to mature. So this is a pointer trial from NEJM, so which looked at whenever there is an infection or clinical suspicion, do we need to immediately drain these patients or can we wait, and what is the difference? So they randomized into 2 groups, where in immediate group there were 55 patients, in postponed group in 49 patients. If you look at the difference between the important parameters, there was main composite clinical score was not difference, but the mean number of interventions were significantly higher in immediate group. And another important conclusion they made was, in postponed group, almost 19 patients, that means 40% of the patient, they did not require antibiotics, and they improved only with the antibiotics. So they did not require the drainage. So this is a landmark paper which had clearly shown that immediately drainage is not required. Better to postpone the drainage as much as 4 weeks until the wall matures would make no difference without reducing the mortality. So this is the same conclusion which we had shown and learned from the pointer trial. So the problem is, whenever there is an infected pancreatic necrosis, we start antibiotics, we wait till the wall to mature. But the problem is when to stop the conservative treatment and venture into the drainage, or what is the exact time frame which we can say that the failure of conservative treatment has been there. There are important parameters like persistent fever, tachycardia, raised WBC count, raised flow calcitonin, organ dysfunction, and most important of these is organ failure. If organ failure is there, despite of effective antibiotics, consider drainage. So early drainage less than 4 weeks can also be considered. Various studies have been published. This is a meta-analysis which showed that earlier drainage less than 4 weeks can also be an option without increased in the mortality or side effects with the similar clinical success, but we need to look at what exactly the parameters we are looking at. Next, how to drain it can be surgical, percutaneous or endoscopic. So we need to consider whatever the modality we adopt, the choice should be step-up approach. We start with antibiotics, then drain either because of primarily by endoscopic or percutaneous, then required based on the primary modality what we adopted, where we can consider necrosectomy, either percutaneous or endoscopic, and subsequently the surgery. So this was an important trial, a landmark trial again, the tension trial. I'll make it simple here. So this is from the Dutch pancreatitis group, which compared a step-up approach with the endoscopic approach. And if you look at the primary outcome, that is major complication or death, is almost same in both the groups. But there are important conclusions from this study. Though it was not superior, the rate of pancreatic fistula and also hospital stay were lower in endoscopic group. So this probably shift the choice towards the endoscopic course. Subsequent 3 important landmark trials, Penguin from JAMA, tension trial, Lancet we discussed, and gastroenterology, MISA trial. Almost all trials showed same conclusion, endoscopic approach is better compared to minimally invasive subsequent strategy. Sorry for the little blur in the slide. This was the small project we considered, done at our center. So we discussed a lot about which option to drain, whether it is a percutaneous or the endoscopic. But it's not, when it comes to the clinical real life scenario, it's always not so easy to answer this question, because even though we try to consider endoscopic drainage, in majority of the cases it won't be possible because of the lack of maturity. So we looked at the patient of 117 where we put our efforts to do endoscopic drainage primarily, but out of 117, almost 60% of the patients required PCD only despite of our efforts. So that means it is not our choice. Actually, the morphology of the collection and the clinical picture decides the choice of the drainage rather than our approach. Does this mean there is no role for surgery? We could not say that. There is a definite role for surgery, especially when there is a significant necrosis more than 50% with predominant solid component, when there is a no response to antibiotics, organ failure, and the patient is significantly deteriorating. And when there is a colonic communication is again an important indication. The choice between the metal and plastic stent, now the data is very clear. Lamps are very effective and they effective in control the bleeding, and lamps also are very effective in controlling the infection by doing as a port for doing the necrosectomy. We can take the accessories, go in and remove the necrotic debris so that we can clear with endoscopic gadgets only. So these are the various studies, but I would like to highlight our study which has clearly shown though the outcome between metal and plastic is same, the re-intervention free clinical success was significantly higher with the lamps compared to the plastic stents. And the recent network meta-analysis based on 28 studies and 3,000 patients showed that there are 2 distinct clear indications where we need to consider lamps. One is when we are dealing infected pancreatic necrosis, the second one is the necrosis is more than 30%. Which strategy? Obviously step-up approach, as already had discussion. With this paper we have shown clearly that there is an incremental increase in the success when we go from one step to subsequent step. There is the option of discussing upfront necrosectomy also. This is a landmark paper again from Lancet, from Sham group. We are also part of the study, which has shown that there is some benefit, but we should not consider in all patients, especially in unstable patients or who are very sick patients. So again, coming back to the last slide, which I can conclude by showing the guidelines, what exactly they are saying regarding to this topic. Antibiotics, there is definite role from all major guidelines in treatment, but there is no role for prophylactic antibiotic. Prophylactic antifungals are no role. We should delay the drainage till the wall matures. Endoscopy is the first preferred option. Always multidisciplinary care has to be adopted. Thank you all. So I would like to invite you all for the upcoming AIG Live in 2026 on 4th and 5th December 2026.
Excellent.
Thank you.
Excellent presentation. I think difficult to cover in that short time. I would like to highlight two trials. You make it mention, but in a quick succession, that current guideline is step-up approach in spite of going through the direct upfront endoscopic necrosectomy. The trial you have shown, the last one, the BANG trial in 2024, Lancet Gastroenterology and Hepatology. Although the number was only 70, but in a specific subgroup of patients, they have advocated upfront direct endoscopic necrosectomy has a age above the step-up approach. What is your comment on that? And second thing, I am putting you have shown in the Singh et al. Trial, that is the Ritu Singh trial, the 2021, I think, antifungal. Because antifungal has only role, because you are not going to give the definitive unless you give the culture. And if you are even giving definitive, the mortality is more than 50%. So you have to give the empirical or imperative. Prophylaxis, we know, no role. When you will exactly consider this empirical or therapy, what is your comment on this antifungal?
So thank you for that important questions highlighting. So one is upfront versus step-up approach. We are also part of this study from that Lancet study, where patients were randomized to upfront versus step-up approach. In all patients, LAMPs were used. And the important conclusions or what I would say as a part of the study person. So what I would say is, in select group of patients where wall is matured and the necrosis is there, those are the patients where early upfront necrosectomy definitely helped by reducing the cost and also the stay. But when we randomize the patient and when we actually taking into the study, and many times we observed that the early group, there were a proportion of patients who are falling before 4 weeks, and early drainage group, where the wall is a partially matured wall. In those patients, upfront necrosectomy we attempted, there was a bleeding complications. So I would say at the end, in select group of patients, when the necrosis is more, wall is matured, rather than waiting for step up and prolonging the stay, directly proceed for the upfront necrosectomy. There is no problem.
That is the point. If it is most of the patient, 90% is taking after 4 weeks. So in that subgroup of patients, do you recommend direct upfront endoscopic necrosectomy?
Yeah, if you ask my personal opinion, I would still prefer a step-up approach. Okay, so maybe that study is appropriate for the US setting where most of the patients were covered under insurance, where the cost factors and the timing, duration of the hospital stay were matter a lot, and they want to get rid of the things as early as possible. But that is not a case in most of our clinical practice centers. So patient safety is first. So my personal choice is still, though we are part of the study, step-up approach only. Yeah.
Can I make excellent presentation? I have two questions.
Yes, yes.
First one, the procalcitonin level, so which we are sending for diagnosis of infective necrotic pancreatitis. So what is the day? Which day you will send the procalcitonin?
Yeah. So another again important, in the first week there is no value for sending the procalcitonin, because infection usually sets after the first week. If you are suspecting strongly some other source of infection in the first week, you can consider. But for infected pancreatic necrosis, if fever starts after the first week, after 7 days or after 10 days, then you need to consider procalcitonin, whether it is a prolonged SRES or infection.
Thank you. And my second question is there any role of surgical intervention in increased intra-abdominal pressure?
Yeah, very important question. So earlier there was a lot of discussion about the increased intra-abdominal hypertension. When it is more than 12, it is IAH. But abdominal compartment syndrome happens if it is more than 20%. So that's the emergency where there is a risk of ischemic complications also. We need to intervene, but the management is simple. Put a Ryle's tube and do a decompression that reduces the pressure in majority of the cases. Then do a CT scan, look for the ascites and the fluid collection, drain it off, ascites first. If infection is also possibility is there, if the patient not improved with Ryle's tube and ascitic drainage, then consider the drainage of that aspect also. And another important thing is if you manage analgesia properly, that also has an impact on the intra-abdominal hypertension. So these are the three important areas where we need to look at. If patient is still not improving with Ryle's tube and ascites drainage, then we have to consider surgery.
Dr. Ajay has a question. It's the last question.
Jahangir, excellent presentation. Just taking that point further, when
Sir.
you talked about your initial trial of a step-up approach versus the Shams trial of which your group was a part of it, was but the last trial published 2 weeks back or maybe a week back in endoscopy from Jimil group from PGI,
Yes.
that has shown select patients of more than 30% necrosis, their step-down approach is better than that. So
Yes.
ultimately the question will become that you have to select your patient whether it's a step up or a step down. That's my.
Yes, sir.
And I strongly believe in that.
Yes, sir. Absolutely correct. So it's the most important thing is the patient category decides the strategy.
Thank you. Thank you, everyone.
Thank you. Thank you.
Thank you.
Thank you. Request respected speaker and the chairpersons to kindly move to the felicitation area. We move forward to our next session. To chair the session, may I request Dr. Ajay Kumar sir, Dr. Dilip Todi sir, Dr. Sudipto Ghosh sir, Dr. Kaushik Shah sir and Dr. Devjoy Shah sir to please come on the stage and start the session by introducing our esteemed speaker.
Well, friends, we have been asked to introduce somebody who doesn't require any introduction. Matthew is a dear friend. Of course, all of you know that he's the current secretary of the Indian Society of Gastroenterology, doing a wonderful work. And he comes from Kochi. I think straightway we'll go to the topic of exocrine pancreatic insufficiency and diabetes following acute pancreatitis. What are the recent insights? Over to you, Matthew.
Thank you so much for the kind introduction, respected chairpersons. My dear friends, special thanks to Apollo team for this wonderful invitation. Traveling from Kochi to Kolkata has become very difficult now. Earlier there were 2 direct flights, now there are none. So I reached here 2:30 a.m. in the morning. I was running very high fever, severe sore throat. My sound will be bad, so I requested Mahesh to increase the temperature of this room. Anyway, thank you so much. And you know that acute pancreatitis is a very complex disease, and it is recently more and more known that it is going beyond the acute phase. And people are knowing that there is late complications and you require long-term follow-up. There is a close relation between the exocrine and endocrine pancreas. And this starts with the organogenesis and it persists throughout life. So any complication which can occur in the exocrine pancreas, that can affect the endocrine pancreas as well. And exocrine pancreatic insufficient acute pancreatitis is a reality. It occurs in a significant group of people, and it varies from the time when you start checking it, and in long term it can occur in 1/3 of patients. Diabetes mellitus, the term type 3C diabetes, which is people are not using it now, it's a secondary form of diabetes which has got complex mechanisms. So 2 aspects I would look into. One is exocrine pancreatic insufficiency. I'm happy that Samir is actually discussing on this issue, so I'll be cutting that area. Diabetes mellitus, and you know that acute pancreatitis is no more than an acute illness. On 12 months, studies have shown that on 12 months of follow-up, and it has said you got at least 1 GI symptom in those patients in 12 months, and there is weight loss, and there is reduction in the fecal elastase level beside the development of diabetes. And EPI and diabetes mellitus can occur wherever there is a loss of oleum or where there is not adequate tissue of pancreas, when there is ongoing destruction or other autoimmune mechanisms, or when there is no opportunity comes between for mixing of food because of surgical reason. These can happen. And you know that exocrine constitutes more than 95% of tissue and endocrine constitutes less than 5%, almost 2 to 3% of the tissue in functional tissue types in pancreas. And you know that in my MBBS days, I thought acute pancreatitis one and done. Because you don't have either the patient recover, he is fine, or he will have some major issues at that time. But it is known that is not true. And the one and done dogma is gone. It has become a persistent reality that there could be damage in the pancreas. So my outline will be like this, pathophysiology of this. Is it possible to identify those patients who are at risk? How to monitor them? Do these complications improve long term? Should we offer therapy and management of pancreatic diabetes? As I've told you, there are multiple reasons for pancreatic insufficiency and EPI. Most commonly we know is chronic pancreatitis. And there are many other diseases, extra pancreatic diseases also can affect this and produce this. What is the clinical impact of this? It is quite substantial. You know that it impairs the digestion, it impairs the absorption of macro and micronutrients, significant weight loss, metabolic bone disease, fat-soluble vitamin deficiencies, etc. Why do this occur? Basically, it is a reduction in the functional oleum of exocrine pancreas, which actually produces the enzymes. It also can occur when there is an obstruction in the main duct, or because of the inflammation, or due to the nerve dysfunction, the secretion as well as the hormonal outflow can be affected. Especially this happens in after surgery or very selective involvement of pancreatic head the pancreatic aspect. So when you intrinsically look into the various aspects of pancreatic function in acute pancreatitis, what happens? There are changes which can occur in acinar cells, and it is quite vast. I'm not going into the details of that. Then there is something called islet and acinar axis disruption, which is very relevant and quite important for both exocrine as well as endocrine insufficiency. Then comes even the duct cell injury is quite important. And it can actually, because of the mechanical effects, the duct cell injury lead on to stricture, etc. Reduced bicarbonate secretion actually in fact reduces the secretion also. Then islet cell injury, which can be because of multiple mechanisms, not only because of necrosis, but also the area where the pancreas is affected, and also through the islet acinar axis itself. Then as the villain comes there, that is the stellate cells. We know in liver it happens, and pancreas also this is quite important, and that lead on to periacinar cells will come around the periacinar region and start repairing this mechanism, leading on to fibrosis, ultimately leading on to all the reduction of the oleum of the pancreas and stricture formation and stasis in the pancreas duct, etc., etc. Diabetes, actually, glucose intolerance has been known as a complication of severe acute pancreatitis. We know that every patient admitted in our ICU with acute pancreatitis, especially severe pancreatitis, got hyperglycemia, but we all thought it is transient, and cohort studies have shown that it is actually up 30 to 40% of patients can have some sort of diabetes-related involvement in that. So from a stress hyperglycemia, it has gone to unrecognized diabetes, and now we know that there is something called post-pancreatitis, diabetes mellitus, and a new onset diabetes after pancreatitis. So acute pancreatitis episode, transient glycemia, a small group develop into long-term complication of diabetes. The mechanisms are different. It can be inflammation, it can be scarring, or it can be islet loss, or something beyond that which we are not sure. When you look at the diabetes in pancreatic disorders, we used to call it with different names. Either earlier it was pancreatic fibrocalcific pancreatitis, but in pancreatic diabetes, then type 3 diabetes, type 3C diabetes, and now we know this is all classified differently. And what are the contributing factors of the pathophysiology? It can be local or even systemic. But I think the most important will be hormonal related activities also quite important. So the EPI connection and incretin axis loop, it is exocrine failure, endocrine failure, and it's all vicious circle, and nutrient malnutrition, which ultimately lead all these things. But I think the incretin drop becomes very important, and that is one reason where exocrine pancreatic insufficiency or disruption can lead on to diabetes as well. So there is a mechanical disruption, then there is an exocrine dysfunction, which will actually lead to exocrine pancreatic diabetes. Actually, it is exocrine function that is quite important that lead on to changes on that. This is a study from AIG and Wahid Akbar and Dhruv Jyoti group, and they have found that new-onset diabetes, this is a recent paper in 2020, came in Pancreatology, endocrine dysfunction is quite frequent after an episode of acute pancreatitis, and WON, any necrosis occurring in pancreas, is a risk factor for that, and intervention for W is an independent risk factor for endocrine dysfunction. So they have looked into at baseline 3 months, 6 months, and 12 months. They have found that impaired glucose or pre-diabetes and diabetes, the numbers are increasing at frequent levels, or up to 12 months, it is increasing in number. So is it possible to identify that these patients who are at risk for developing all these complications? The strongest predictor for developing exocrine pancreatic insufficiency is severe acute pancreatitis, alcohol-induced pancreatitis, then pancreatic necrosis. Even in patients with milder acute pancreatitis, they can develop EPI. When you look at the mild versus severe acute pancreatitis, it is found that the EPI is much more in patients who require necrosectomy, and also when compared to mild and severe, it is more in severe, and in necrotic pancreatitis is more than that of conventional pancreatitis or mild pancreatitis. So the risk factors are much, much more in patients with severe pancreatitis, not severe, the damage of pancreatitis occur, or when there is diabetes occurs in those patients who have got exocrine pancreatic insufficiency. It is not directly related with the severity of pancreatitis. It is not related to the alcohol. We all thought that alcohol can increase the incidence of pancreatitis. Increase the incidence of diabetes. Is not true. Recurrent pancreatitis, yes, it can. Double the risk of pancreatitis. Disconnected pancreatic syndrome also increases the risk of diabetes. Another study which has shown that high glucose value and high HbA1c during the acute episode can probably predict this diabetes. And also it has shown that when there is infected pancreatic necrosis, the HbA1c is actually values are very important. A serum HbA1c correlates with the infected necrosis in these patients. And in the clinical outcomes also, long term, those who have got high HbA1c, long term they have got development of diabetes mellitus. So it is a vicious circle. The hyperglycemia, high HbA1c, and these patients, they have got high incidence of infected pancreatic necrosis also, which ultimately lead to diabetes. Should you offer PERT in acute pancreatitis? I'm sure Somir will be talking on that. But the real-world data from Indian study has shown that PERT, that is again from AIG, which has shown that probably it has not very clear benefits when you give randomly for everyone. But if you choose your patients correctly, probably this could be true. That is when there is mild disease, this is not necessary. But in severe disease, well, then probably this could actually go in. So for interstitial pancreatitis, no need of starting. But when you have got severe disease, especially with infected pancreatic necrosis, necrotizing pancreatitis, and in those patients, probably this is true. But we need to do a test and confirm whether it's deficient or not. The EPA treatment is basically PERT, which I'm not going into details because there is another talk on that. The next question is, these complications, do they improve long term? Studies have shown that there is a remarkable potential for pancreas on long term, especially for EPI, and it is found that probably this can improve. You can see this particular study which has shown that on baseline and long term, the fecal elastase level has improved from the first month or baseline over a period of time. Similarly, the pancreatic enzyme insufficiency, exocrine insufficiency quality score also improved on long term. And also another very interesting study which has shown the dynamics of EPA in acute pancreatitis, they have shown that on follow-up up to 5 years, this is found to be improving in the patients on long term. So how to monitor these patients? You do for extrapancreatic, exocrine pancreatic insufficiency, you do a elastase test in the initial episode, 3 months, 6 months, and 12 months. Similarly, at the time of admission, do a HbA1c, then 3 months, 6 months, and 12 months. And I think, acute pancreatitis follow-up should be at least for 1 month to find out all these things. And how do you do an algorithm approach for acute pancreatitis for diabetes? It's basically we need to find out a type 2 diabetes who developed pancreatitis, or a type 1 diabetes patient has developed because of acute pancreatitis, or basically a patient who has type 1 diabetes, or it is a pancreatic diabetes of acute pancreatitis we need to do. And there are no definite tests by which we can really find it out, but by following this patient, probably if the patient did not have any diabetes before the onset of pancreatitis, then this could be a potential post-diabetes of pancreatitis of acute pancreatitis. This is a multidisciplinary approach, how you do in patients with diabetes in pancreatitis. You need many factors because there is exocrine pancreatic insufficiency. This needs to be addressed and treated, and also nutrition supplementation is also quite important in that. So my final slide, acute pancreatitis is not just a single episode disease. It has got long-term complications due to exocrine pancreatic tissue loss. EPI and diabetes mellitus are significant complications of acute pancreatitis with complex pathology. Early intervention is recommended after proper diagnosis and monitoring. Follow-up strategies are quite important and need to be planned. No patient with acute pancreatitis all patients should be followed up for at least 1 year. PERT is used selectively in appropriate indications. Don't put this as a blanket prescription for anybody after acute pancreatitis. And we need more multicentric studies of EPA and diabetes in our patients. Thank you so much. I am sure most of you have registered for WCUG by yourself. If not, this is time. And now 3 more days are there for not registration, 3 more days for abstract. And please do register and make sure that all of you attend for this conference. Thank you so much. I'm sorry about my throat.
Thank you.
Sir,
Excellent lecture as always. So, it is from my point of view, that is diabetology or the endocrinology. You are saying that the acute pancreatitis is related to the EPI. Now, in certain situations, we don't have any history of any acute pancreatitis or the chronic pancreatitis. Now, patient is having the diabetes for a long time, and they have symptoms like EPI. So, in that situations, what is your going through, and how do you go into the...
Excellent question. See, we know that the connection between exocrine and endocrine tissue are quite important. There is a hormonal, and it's actually a network. You know that there is a paracrine action as well as an endocrine action inside the pancreas. And long-term diabetes, it is known that can have reduced the exocrine pancreatic insufficiency. And it's also known that when there is exocrine pancreatic insufficiency not addressed, their diabetes is poorly controlled. So it is a very good question you asked. So in generally, if the patient is, what in my practice, if a person come with some sort of pancreatic insufficiency, my first thing is to do abdominal X-ray, look for pancreatic calculi, because that is what we are taught. Because in Kerala, any diabetic, especially below the age of 40 years, we always take an X-ray of the pancreas and to look for pancreatic stones. But if it is negative, we'll do an ultrasound also. But I think this is important. It is very difficult to differentiate between these two. This is a non-fighter, it's a different entity, but it's interconnected.
But is a question basically based on long-term diabetes, how often they have EPI. I think Roop has written quite a lot on this particular topic, and he used the cross talk between the different. We can talk about this. There's another question from that side.
Sir, nice and lucid lecture. And I have one question. You have mentioned that alcohol-related acute pancreatitis that can cause develop the diabetes mellitus in future. Is there any other etiology that can cause acute pancreatitis? We have monitored this patient for looking for the diabetes mellitus in the future. Is another etiology, any etiology that can cause acute pancreatitis? Is there any?
See, the severity of acute pancreatitis for diabetes is not very important. Even mild diabetes sometimes it can produce on that. But in severe acute pancreatitis, EPI is very quite common because because of the pancreatic tissue loss. And alcoholic, we expect that alcoholics can produce pancreatic damage and then it can produce diabetes. It's not necessarily that is true because it is not directly linked with the diabetes. It can be linked with the pancreas because it is shown that, as he has asked, people have done study on pancreatic tissue in diabetic. They have found there is a lot of focal damage in pancreas. This one. Even in diabetic, you can see that, but not necessarily it is directly linked with alcoholism.
Though, Matthew, you did mention, but I'll just reiterate that we had also a postgraduate thesis protocol, and that pancreatic insufficiency is common in severe acute pancreatitis, but large number of patients will recover with time. I mean, most of it's a transitory rather than a persistent API requiring long-term PERT.
So that is exactly what
Sadhana,
I wanted to say, that aren't we merging two issues? There is a group of acute pancreatitis per se, agreed, acute severe necrotizing very bad pancreatitis will go into some kind of insufficiency on long-term follow-up. But our experience has also been the same. The time you do the testing is very critical. If you do it too early, you will find exocrine and endocrine insufficiency. You wait for 3 months, it will not be that to that tune, and if you wait 6 months to a year, it will be even lesser.
Absolutely.
And another thing that we found was, rather than acute pancreatitis single episode, it is those patients who have acute recurrent pancreatitis, those are the ones who go into the exocrine and endocrine insufficiency, and those are the ones which need to be followed actually, because as we all know now, ARP is the formifolstay of chronic pancreatitis.
Madam, you have brought in a very pertinent issue. You are talking about something called any acute pancreatitis comes to you. It can be the first episode of recurrent acute pancreatitis. And recurrent acute pancreatitis is known to be an initial presentation of chronic pancreatitis.
Enlarged.
So that can be slightly different. Thank you so much.
Okay, thank you, Matthew, for a wonderful presentation. This is a topic which we don't discuss very often, but it's important. Thank you very much. Thank you.
So thank you very much to the chairperson and the speaker. I request all of them to come to left of the dais for the felicitation. And now we move on to our next talk, anatomical anomalies in recurrent acute pancreatitis, causative or epiphenomenon. For that, our chairpersons would be Professor Sadhana Lal, Dr. Gautam Roy, Dr. Kaushik Munshi, Dr. Ogribo Datta, and Dr. Shashwata Chatterjee. And our speaker is Dr. Pawan Rawal. May I request all our chairperson to come to the dais and start the proceedings.
I think without wasting time, and Pawan has got a flight to catch, we will begin with the topic directly, anatomical abnormalities in RAP.
Thank you very much, ma'am. At the outset, let me thank Dr. Sokananda, Dr. Sanjay, and the organizing team, Kolkata Pancreas Update, for having me here. So I'll try to answer this very, very difficult questions, whether the anatomical anomaly they have any contribution in causing recurrent acute pancreatitis, and once we do some treatment, whether this helps in management or not. So the objectives would be, what is RAP, recurrent acute pancreatitis, then what are the type of anatomical anomalies or ductal anomalies which are pertinent, and then how do they cause pancreatitis or RAP, and what is the implication of different anomalies in the pathogenesis, and whether the treatment in the form of ERCP helps. So RAP has been classically defined as when there are two or more distinct episodes without any underlying chronic pancreatitis. The episode should be well documented, and there should be a complete resolution between the two episodes. That we label as the recurrent acute pancreatitis. Classically, the etiology in adults have been the alcohol, the commonest one, 25 to 50%, then the occult gallstones, maybe sludge, the malignancies, genetic mutations, they also contribute, and the pertinent topic to us is the anatomical anomalies, where the incidence is too less to be labeled, so it's very difficult to say how much percent they are contributed by these. The possible anomalies which probably have led to RAP are anomalous pancreatobiliary junction, pancreas divisum we'll talk about, ANSA pancreatica, annular pancreas, though it mainly causes the gastric outlet obstruction, duodenal obstruction, and the meandering pain pancreatic duct. Now, before we start understanding about the anomalies, we should go and see what and how pancreas develops. So we know that the pancreas develops from the dorsal duct and the ventral duct. They arise from the, if you see this diagram, see the dorsal duct, the dorsal pancreas arises from the gastric mesentery, and the ventral from the pars hepatica, from where the gallbladder and the liver also develop. Over the time, the ventral duct, which has two parts, right and left, the right part goes behind the duodenum and it joins the dorsal segment to form complete pancreas. And finally, the dorsal part forms the head, body and tail, and the posterior inferior part of head and uncinate is formed by the ventral duct. So this is what we have. Finally, we have two ducts. This is the dorsal duct and the ventral duct. The main pancreatic duct is called as the duct of Wilson, and the accessory is called a duct of Santorini. So that's we have as of now. Once we talk of pancreatic duct anomalies and we classify them, we may start with the which have lower prevalence. The meandering pain pancreatic duct is one where the main pancreatic duct forms a loop. You see there is a loop, or it is having a exaggerated curve. So the curve gets exaggerated or they form a loop, and finally it leads to pancreatitis because of some obstructive pathology. In ANSA pancreatica, the accessory duct arises from the main, it forms a loop like this, crosses above, crosses the CBD, and then opens in minor. So this is called ANSA pancreatica. It leads to the RAP in very, very few number of cases. And pulmonary pancreatobiliary junction, that means the CBD and the pancreatic duct, they were supposed to join inside the duodenum, but here they join outside the duodenum at various angles. And then they are classified as SCOMI type 1, 2, and 3, depending upon the angulation. In 1, it's 90 degree, in 2, it's acute, even further, and in 3, there's a very complex interaction of multiple ducts. Santorini seal, when there is a cystic dilatation at the end of dorsal duct. You see in MRCP, this is the accessory duct, and because of the pressure, there is a cystic dilatation at the end of this duct, and this is called Santorini seal. It has a possible association with the PD, and probably the mechanism is again obstructive, pancreatopathy. The juice is not getting out of it, leading to ductal hypertension. Now come to the commonest one, which is pancreas divisum. So we saw that there are two buds, ventral duct and the dorsal. The ventral, it goes behind the duodenum to join the dorsal, and it forms a complete pancreas. Now, then we have seen there are two ducts, the main duct and the duct of Santorini. So, if there is a abnormal fusion or no fusion of the main and accessory duct, then it leads to pancreas divisum, and they are classified accordingly. So, we see in type 1, we have both the ducts available, ventral duct and dorsal duct, but they are not joined. And whole of the burden of draining the pancreatic juice lies on the dorsal duct, and it opens through the minor papilla. In type 2, the main drainage is through the dorsal duct and there is no ventral duct at all. In type 3, there are both the ducts, but they are joining with a very, very small or inadequate filamentous connection, so the drainage is not adequate through the major papilla. Why there is a controversy? I mean, why we are talking about this topic? one, whether PD, that is pancreatinism, at all causes recurrent acute pancreatitis, and second, whether the treatment will help us or not. Now, if we want to prove this hypothesis, we have to prove that the prevalence of pancreatinism should be greater in patients with idiopathic recurrent acute pancreatitis. Second, we have to prove that there is a dilated dorsal ductal system leading to ductal hypertension. Third, the pathology changes should only develop in the dorsal duct if we are true to that. And fourth, the frequency and severity of recurrent attack in idiopathic pancreatitis should diminish once we treat this pathogenesis. So let's try to do that. From the very outset, early 90s, Sugawa et al. Have shown that this PD is very common in general population, and they thought it is just a normal variant of pancreatic development with no association with the disease, that is the recurrent acute pancreatitis. The same was potentiated by further author, the Burton et al. And Delhay et al. They also found that this is very, very common. It's very difficult to label it as etiological factor in RAP. And they even went up to extent that they said that there is no stenosis as accessory papilla, and it is a poor association between the two things. The same was potentiated further by Di Magno et al., where they shown that the prevalence of PD in general population and idiopathic pancreatitis was same. It was 8% in both. So they refuted that PD at all may cause RAP. But then we have seen that there is a subgroup of patients, maybe 5 to 7%, in whom the PD tends to develop pancreatic symptom. That means the people who had pancreatic divisum documented, they had pancreatic symptoms, maybe the acute or recurrent acute pancreatitis. But then again it was challenged by few people, and initially by the Gerrud et al. They shown that PD presence itself is not an indicator of RAP, and in patients of pancreatitism who develop pancreatitis, they had an underlying genetic mutation in the form of CFTR gene mutations. So that means PD itself was not leading to pancreatitis, it was the underlying genetic issue which was leading to pancreatitis. The same was proven by Indian study from AIMS as well. They also documented significant genetic mutations in people who had RAP with associated PD, so making it as an epiphenomena. So there was probably no causative association found, and this was recurrently proven. Second, it was shown that PD may not alter the natural history of patient with pancreatitis. That means if we have some people who have chronic alcoholic pancreatitis or CCP, and if there is associated PD, it doesn't alter the natural history, again nullifying the fact that PD contributes in the pathogenesis, again in this case. The last thing we discuss, that whether we find PD and we do endotherapy, that helps or not. So initially, there were no randomized trial available in early 90s and early 2000. Then there was one trial with very, very small number of the patient, like 19 patients, which was published. This was in 1992. And they compared the minor papilla stenting. Mind it, that time they did stenting. They repeated the stenting at 4 months. And then around 3 to 4 times the stent exchanges were done as a part of endoscopy intervention. But they found that stenting was found to reduce the episode of pancreatitis. It helps in reducing the hospitalization and improve the quality of life score. This was the first RST which was available in 1992. Now, problem with stenting is that once you stent recurrently, they itself cause issue. They lead to changes in the pancreatic duct. And there are, of course, the risks of post-ERCP pancreatitis in that case also. And rather, people or patients who were stenting multiple times, they develop sphincter restenosis. So that's challenging the role of pancreatic stent in these kind of people. Further on, since the stenting had issues, so minor papilla endoscopic sphincterotomy was tried. By multiple studies were published, though they were small. Initially, a 40-patient study where it was found that endoscopic sphincterotomy temporarily stent, if you do and you do just a sphincterotomy with no stenting, it reduced the risk of acute pancreatitis at 6 months, and same was proven by Chaco et al. And Marion et al. The prospective study was by Marion et al. Otherwise, there was a retrospective study. So these were going on, and then there was a pooled analysis which also showed that some kind of endotherapy, especially with the sphincterotomy, it leads to reduction in the episodes of acute pancreatitis in follow-up of those people of pancreas divisum. So showing that there is some benefit coming out of it. Then the major trial, which is recent, is published in 2025, it was presented in DDW. was the SHARP trial that used sphincterotomy for prevention of acute recurrent pancreatitis in patients with the pancreas divisum. It was a double-blinded randomized sham-controlled trial wherein around 148 patients were randomized to endoscopic sphincterotomy vis-a-vis others who were randomized just a sham pancreatic therapy. In those cases, the intubation was done in the duodenum and the stent was just put in the duodenum. The papilla or the minor papilla was not even touched upon, and then they compared the primary and secondary outcome. The primary endpoint was the development of acute pancreatitis, and the secondary the outcome was the development of the chronic pancreatitis and the complication of the diabetes and the exocrine pancreatic deficiency in these people. And they found that there was no difference in either. The incidence of the acute pancreatitis was same in both the groups, and the same was the issue in the secondary outcome, where the diabetes and the EPI, and they were same in both the groups, thus showing that ERCP in patient with PD and RAPV not beneficial at all. So that actually proven that probably again it is probable epiphenomena to this. But then small rebuttal, what we thought about this trial was a very important concept of dorsal duct dilatation was not considered, and they were underrepresented. And in the background also, the people have found that if there is a dilated dorsal duct, like that happens in Santorini seal, or you document in an MRCP, the outcomes were better. So they were underrepresented in this trial, and they didn't do any genetic mutation testing, and we have seen that the genetic testing has always confounded the issue of the RAP in PD. So again, this is kind of rebuttal that can be put upon. Now, ERCP in other ductal anomalies, though they're very less common. So, ANSA pancreatica, the only case reports we could find, and the usual approach is minor papilla sphincterotomy and the ventral duct stenting one can do, but then it's not conclusive whether that would help or not. The same is in the main pancreatic duct. One or two studies were found and they had complete or partial response, but inadequate to give it a guideline. And then abnormal pancreatobiliary junction study by the Zinn et al., they reported an overall effective rate of around 60%. But there was a very small study, it was there. So, though it's very difficult to answer the question I was given with, but to summarize, the anatomical and ductal anomalies of pancreas, of course, they are not the common cause of RAP. Mechanism is usually obstructive pancreatopathy that happens in Santorini seal and others, and sometimes it's bile reflux, especially in anomalous pancreatobiliary junction. PD, the pancreatism, is the most common ductal anomaly, and we commonly see as well, but we have to see that the genetic mutation are confounding the pathogenesis of RAP in PD, so we may be looking after that. Now, difficult to comment whether every person would require ERCP or not. My take would be a patient of pancreatitism having a symptomatic history of recurrent acute pancreatitis, and possibly if they have a dilated dorsal duct, may be having some benefit of the interventions in the form of sphincterotomy. So that's probably can be considered as of now as a criteria for putting patient through the endotherapy. Thank you very much.
Thank you, Dr. Pawan. Lucidly said and nicely summarized that possibly if there is an evidence of obstruction, then possibly you can attribute to the congenital abnormality, otherwise it is anybody's guess. One comment about the genetics. In acute recurrent pancreatitis, I think we are going to have a discussion subsequently. A lot of the patients anyway are going to have genetic mutations. I mean, it's a question mark again, whether you can attribute what is the role of the genetic mutation. So I don't think that particular thing is going to sort out the pancreas divisum story. The closest thing is obstruction. If there is obstruction, possibly attributable, otherwise not.
So we have to choose those subset of the patients where probably, I mean, again, it's a probable thing that whether this will work, but yes, the subset of patients we can consider are those.
We have seen patients in adolescents recurrent pancreatitis. You commonly face this problem of pancreatic division. In that case, you have to exclude that. What is your opinion?
Pardon, sir, can you repeat?
In adolescents, if the patient came with the acute pancreatitis, we should always look for whether any pancreatic division is there or not.
No, I mean, of course, see, if you are dealing with the person of RAP, or a subgroup of people who have RAP, it's not the common cause. We of course follow the same phenomena of ruling out, at least in adults, though madam in pediatric population may look at more, but in adults of course it's one of the uncommon causes. But then a particular subset of the people like young adults, adolescents, in that group we have to consider of course the PD as a cause. But it's not the common in adults.
Sorry, is there any genetic abnormality which predisposes to these pancreatic ductal anomalies, not the cause of pancreatitis? I mean, the genetic abnormalities causing pancreatitis. Is there any study
I think
on
ma'am is the right one to answer. She is a chief of pediatric gastroenterology.
I think not that I'm aware of, except if you consider APBJ associated with congenital hepatic fibrosis, then there are well-defined mutations associated with it. Otherwise not. But what our experience is that ARP, lot of the patients are going to have genetic mutations. So attributability is the question. Whether you can attribute it, what is the role, and whether it is the sole thing.
Actually, one of the studies where they looked after the genetic mutations in people of RAP as a confounding factor, they found that in 50% there was a thick pancreatic juice they found. But then whether to label it as a, a contributory factor is very difficult as of now. The number was less.
If there is no question from audience, we have to conclude this session. Thank you very much.
Thank you very much.
Requesting the speaker and chairpersons of this session to please proceed to the felicitation area. We move forward to our next session. To chair this session, may I request Dr. Munu Tandon, Dr. Kingshuk Dhar, Dr. Shrikanta Goswami, Dr. Devopratim Raut and Dr. Shrikanta Mohanto, sirs, to please come on the stage and start the session by introducing the speaker.
I ask Rupajyoti to start the session of recurrent acute pancreatitis and genetic background. Please start.
Yeah. Thank you, and thanks to my friend Sanjay Banerjee and the entire team for having me here. And I think this is an exponentially improving meeting with good topics and more audience, so congratulations for that. So today my job would be to speak on the Indian patients with recurrent acute pancreatitis and CP genetic landscape. What's the genetic story? So let us, rather than talking theoretically more about the genes, we'll do that, but let us make it a theme of should genetic testing be done? Also, how many of you, can I have a show of hands, how many one of you advise genetic testing, especially in patients with recurrent acute pancreatitis? Audience. Okay, only 2, 3, maybe 4. Okay, so 5. Okay, we have 6. Oh, very good. We have many. Now, if we do this genetic testing, what would you prefer to do? Is it a targeted genetic testing or a whole exome sequencing? Targeted, how many targeted? 1, 2, and 3, 4. Exome, whole exome? 1, 2. So one person is saying both targeted and exome? Okay. Okay, we'll discuss that. So before that, I think let's go a little bit into the basics of genetics. I think 2 slides, which I think we should know before we think of testing for genetics. So this is how a gene, if we open up a chromosome, it will look like. And all these are fragments of the chromosomes are genes, and each genes have this nucleotide, pair of nucleotides. We won't go into the details, but it contains pair of nucleotides. And these triplets, 3 pairs of nucleotides will form a genetic code that will produce a specific protein. Okay. So then, if there is a problem in one of these nucleotides, suppose one is replaced by something else, we got something called single nucleotide polymorphism. And this is what causes most of the abnormalities in pancreatitis. And this SNPs could be
pathogenic, and most of them are non-pathogenic. Pathogenic could be to have more than a normal function, they'll produce more enzymes, more pathological enzymes, or they will produce less enzymes. It's a less non-pathogenic. Now, again, a little bit more detail. So if you take the example of SPINK gene, for that matter, any gene will have 4 or 5 important parts. So this exonic part are the actual part that will produce the protein, the coding part, which is seen in whole exome sequencing. But there are introns between the exons which are non-coding. They don't code any protein. And there are some promoter region and there are some regulatory region which are not a part of the exon, right? So that is why when we talk about genetics, usually we have the habit of saying the patient has SPINK mutation, PRSS mutation, but that may not be explaining the entire story. We should always talk in terms of what polymorphism is there. Then we get the real picture. For example, if we say SPINK, but this only N34S is the pathogenic variant. So if we say N34S, SPINK1, N34S, there we are more focused and telling the right thing. Otherwise, it could be a misnomer. General SPINK may also involve many non-pathogenic variants, right? So this is how we should talk about the genes, not just the names SPINK or cathepsin B or SPINK, right? So these are the genes that have been shown to be present in Indian patients of chronic pancreatitis and recurrent acute pancreatitis. Most common is the SPINK variant. Again, this is based on a study it's a Jiva study. CTRC, cathepsin B, this is a gene that is not usually seen in the West. Carboxypeptidase A1, PRSS2. So all these are not going to the details of the names, but these are the genes that are specifically seen in Indian patients. We don't know how many of them causes, how many of them are bystanders. Will come to that, but these are the genes that are seen, right? And then we had reported these 2 genes which were reported by GWAS from the West. So again, these are seen more in female patients and in alcoholic recurrent acute pancreatitis patients. And now let's spend a little time here, the hereditary pancreatitis. So again, we have the habit of putting all genetics into one bucket of hereditary pancreatitis, which is not correct. Hereditary pancreatitis means this 3 specific genes which have an autosomal dominant transmission, high penetrance, 80% or more, meaning if the gene is seen in 100%, 80 of them will have the disease. So it's a highly penetrant autosomal dominant. It increases the pancreatic cancer risk by 50 folds. So the good thing was still few years back, we did not see any of these genes in India. But recently we had encountered 2 patients who has a homozygous mutation of the R122H and the N29I. These 2 are the more important. And that is why now we have found this once, so we will find it more. And why is this happening? Because of transmigration, moving all over across the world, and cross marriages and having some hybrid kid with. So since we have got this, we are more likely to have more of this in future. And that is why I think genetic testing becomes important, because these are the mutations that are prone to predispose the patient to pancreatic cancer. So that is one important thing. And then now let us see how all these genes that I named, how do they act, right? So this is the normal physiology. The acinar cell, trypsinogen, is transmitted by zymogen to the duodenum. Enterokinase would convert trypsinogen to active trypsin. But what happens here if in one set of genetic mutation, the trypsinogen gets activated within the acinar cell? And what are the genes that are responsible for this? The PRSS R122H and N21Y. So they increase their function. It's a gain of function. If you remember, I was talking about gain of function and loss of function. So they will produce more than necessary trypsin within the acinar cell, right? And then there are 2 other genes which have a loss of function. So SPINK and chymotrypsin C. SPINK has a role to inhibit activated trypsin within acinar cell. So if that inhibition is gone, the active trypsin will cause injury. Same thing happens with CTRC. And then this gene that is predominant in the Indian subcontinent, not seen much in the West. We really don't know the function, but probably it causes some missorting abnormalities, and by virtue of which it causes active trypsin. So this is what happens within the acinar cell. And there's something else called the ER stress, endoplasmic reticulum stress, within the acinar cell, which is modulated by the mutation in a CPA1. It's a loss of function. Now what happens in the duct is supposed to produce lots of bicarbonate so that the pancreatic zymogen is transmitted through the pancreatic duct to the duodenum and do not get activated. So here trypsin may get activated if the bicarbonate becomes less. And why do they happen? They happen because of a mutation in a gene called CFTR, and there is a mutation in a gene called CASR, calcium sensing regulator, which increases the calcium. And again, increased calcium can cause activation. So if we club them into three baskets, it would be the acinar pathways will be the trypsin dependent pathway, ER stress will be misfolding dependent pathway, and whatever happens in the duct follows the ductal pathway. So these are the three baskets by which we can classify the genetic mutation. Now this is important. So if we see here, again I was talking about the Mendelian inheritance. So this hereditary pancreatitis gene always follow Mendelian inheritance. So there is a high penetrance, is an autosomal dominant. So especially these two genes, and these are causal. This can actually cause, and it has been proven by animal experiments that this have a causal association. They can really cause recurrent acute pancreatitis, chronic pancreatitis, and predispose to cancer. But if we look at these other genes, here these are pretty common in the population, and the effect size is less, means they are not having a very strong effect to produce the disease, and very common. So these are like non-Mendelian, they get transmitted in a non-Mendelian manner, and this is what we call familial pancreatitis. These are not hereditary pancreatitis, so this mistake should not be made. So these genes are more seen in familial aggregation, so it's a familial pancreatitis. And these are disease modifiers. They do not cause the disease by itself, but if there is another event going on, that can contribute to the disease. So if there are disease modifiers, there has to be other factors, and the most important is environmental factors. So there has to be some gene-gene interaction, right? So all these genes can interact with alcohol, smoking, hypercalcemia, pancreas division. We heard a great talk just now. So, right, so this gene-gene interaction, the most important interaction is again pancreas divisum. Again, there is a controversy, and the SHARP trial has shown that doing a sphincterotomy in divisum is not helpful. But here in this study of over like 700 patients, we could show that if the patient has a cathepsin B mutation, specifically this SNP or the single nucleotide polymorphism, there is almost a 4-fold elevated risk of developing recurrent acute pancreatitis. So this could be a subgroup of patients who have divisum who might be beneficial with a sphincterotomy if they have a especially centrorenal or a dilated dorsal duct, right? So, and this is the environmental and gene interaction of alcoholic chronic pancreatitis. So this set of genes, especially this claudin and MORC4, these interact with alcohol, and then that can cause or increase the susceptibility to alcoholic acute and alcoholic chronic pancreatitis. So this is a great example of a gene-gene interaction, gene-environment interaction. And recently, Madam is there, she'll agree, so there are good medications that have come up for cystic fibrosis. So these are called the CFTR modulators. They act on the cystic fibrosis gene and modulate the secretion of bicarbonate. So that also can be considered as an environmental factor that can be modulated by these newly developed drugs, right? So since on one side there is gene environmental interaction, now there will also be gene-gene interaction. So again, if a particular gene is not causal by itself, they can interact with other genes, and then that can contribute to the progression of the disease. And this is another example. Let me take you through it's an ongoing study from our unit. So over 1,200 patients of idiopathic recurrent acute pancreatitis, 500 controls spread all across India. So what we see here is, so these are the different combination of the genes. And if we look here, as Madam was also saying, almost all these patients will have some genetic mutation. Here, what she says is very correct. Only 9% of them had all wild, no mutation. But if you see, at least one mutation was seen in almost 1/3 of patients, and another 1/3 had more than 2 SNPs. Right? And if we see here, these are the single mutation and how the odds ratio. But if we combine, if we see this combination of cathepsin B, PRSS, and SPINK1, even though they are heterozygous, they have a high odds ratio. And combination of CTRC, cathepsin B, SPINK, even though they are heterozygous, came from only one parent, there is a high odds of developing this recurrent acute pancreatitis. This means that gene-gene interaction has something to do. It's not only about one gene or one polymorphism. And when we split the data into pediatrics and young adults, and if we see it's almost a 50-50 split, If you see here again, CTRC, cathepsin B, and SPINK homozygous had a more propensity to develop this disease earlier in the pediatric age group. And if we see the other combinations, it's more prone to develop the disease in the adult, so young adults. So again, by doing these combinations, would be able to prognosticate, we'd be able to say the prognosis or age of onset. So that's why this is another important point that supports a genetic testing, right? And there are several other studies actually which have shown combination of genes can lead to significantly higher fold risk of developing recurrent acute pancreatitis and chronic all over the globe. So now coming back to the question, should genetic testing be advised for this patient? So now, is the raise of hand more? Can I see more hands now? Okay, so yeah, so you can see some new hands. Okay, so genetic testing for recurrent acute pancreatitis definitely yes. For chronic, I don't do, and I think it doesn't make sense because the patient has already reached the end stage. But if it's a recurrent acute phase, we can modulate. And the importance of that is prognostication, to look at the gene-gene interaction. Treatment, possibly if we have some more studies, divisum with cathepsin B sphincterotomy might help. We have to do some trials. New medications, CFTR modulators, and new drugs are going to come up actually. So that's why genetic testing can be important. It will allay the anxiety. The parents and the children will be scared of what is happening, but at least we know, we can label, okay, there are some genetic polymorphisms. The anxiety can be allayed, and it saves expenses. Rather than going for multiple MRCPs, multiple testing, it will help reduction in the cost, right? Now, who should be tested? Children and young adults with idiopathic recurrent pancreatitis with or without divisum. Family history of recurrent acute pancreatitis in a first or second degree relative, and of course under approved research protocol to look at gene-gene interaction, gene-environmental interaction. Skip this part. So now again, coming back to another important question, if we are doing genetic testing, is it whole exome or targeted? So many of you were telling targeted and many whole exome. Now let's see this. So this is a twin brother from Bihar, and they have allowed their picture to be shown. They have permitted that. So they had a whole exome reporting done. This guy did not have, had recurrent pain, and this brother had no pain. And if you see, the whole exome shows several mutations. Many of them are common, but many of them are not common. And if we see some of this, we understand some of this, we recognize some of this, but many of them we do not recognize. So when a person or a patient come with exome reports like this, with many mutations which are not reported or which we do not understand, that gives more perplexity to the patient, to the doctor, and also to the person who's reporting that, right? So that creates more confusion. So that is one part. And secondly, if we see, these are, just two more slides. So these are 4 different genetic polymorphisms, and these are the genes. So we all know that whole exome sequencing will check for only the exonic areas. But there are many intronic variants which could be pathogenic. And whole exome sequencing do not go for the intronic segments, the regulator and the promoter segments. So by doing a whole exome sequencing, we may miss many important, potentially pathogenic intronic variants, right? So whole exome sequencing is a great tool for research to find out new genetic SNPs. But for diagnosis, I think still targeted panel is more favorable. If we do targeted, whatever we know, whatever is present in Indian subcontinent, if we know those, then we can do our own gene-gene interaction. So I think this is why I think we should avoid doing whole exome for diagnostic purpose. For research, it's fine. And again, whole exome is much costlier. Targeted, we do only 4 or 5 mutations, and you know these are the combinations, right? So that is why this is important. And this is what we do at AIG, only 13 genetic specific SNPs that are more prevalent in India. And I think I'll stop here by concluding that the proportion of patients with IRAP and ICP, of course, are associated with genetic SNPs. Gene-gene and gene-environment interactions are more likely to be causal than only 1 or 2 specific variants by itself. Genetic testing does have its benefit if performed in the right manner for the right patient with the right kind of counseling. Just we should not do the testing and leave the patient. We have to explain, answer their questions. Benefit is of course more in RAP than CP. CP we do not do much after the testing. Targeted gene panels, I have probably been able to convince why targeted gene panels is more useful for diagnosis, again not for research. And of course, the futures would lie in the development of polygenic risk scores to diagnose the disease better and develop more gene-specific drugs like CFTR modulators. So I'll stop here and be happy to take questions. Thank you.
Nice lecture. You said that you don't do whole exome because it does not pick up the intronic variants. Neither does the targeted. It will pick up only those intronic variants which are adjacent to the exome. Otherwise, it will not pick. So, not an advantage. And you have yourself mentioned that novelty, novel genes, this is the way we picked up TRPV6. Then the cost is almost the same. So, it's a matter of where you are, how good is your bioinformatics. If you're in an institute where the bioinformatics is good, you can get away with doing whole exome, you'll probably get a lot of new information. So I think that is a debatable question.
Yeah, I agree. But then the thing is, because what is happening actually, many...
It's been indiscriminately
exactly,
used.
that's
that
my point.
Should be, so then again, it should not be done by everyone.
Exactly.
Only if you are able to understand and prognose and explain, is it valid? Otherwise, it is just a mass of information which is not going to do any good to the patient. This is what we tell our patients routinely. Point number 2 is regarding the use of the modulators, CFTR modulators. You have to understand that whenever these drugs are there, and you find a genetic mutation, it is so very important to do the functional testing. What is the exact dysfunction caused by the mutation? Unless you pin it down in your lab, you might be going on a wild goose chase. So it's not going to be a cure-all, it's not going to be a magic pill, it is going to be very targeted, depending on what is your mutation, what is the functional assay, and then can you use those drugs. So that needs to be taken into
in fact, in this Evacaftor studies also, the results in was very variable. Some studies actually showed more pancreatitis. So we are not there right now. As you rightly said, testing is important. This to the sweat test and other functional.
It's a difficult question. As I said earlier also, we are doing a lot of testing in research scenarios. But what is it going to translate into?
Exactly,
It is not 1 year, 2 year, 3 year business.
No, we are not yet there.
We are going to take a long time to sort out and correlate the genotype with the phenotype. It's a very patient job, and it is not going to be 1 year's or 2 years story.
Can we move on? Matthew, quickly, please. Very briefly, we are running out of time.
Excellent talk, but I have some issues on this. Because, for example, you do whole exome sequencing or target sequencing, and you find out there is a genetic abnormality in Andhra Pradesh. But in Kerala, that may be different. So unless we do a whole exome sequencing, we may not be able to find it out. I agree that intron we will find out. That can be done later, I think. Another thing is that there are so many environmental factors which can modify the genes, epigenetic, this one. So how this will influence when you do this type of test?
So exactly, as Madam has also said, I mean, it depends on whom we are doing and why we are doing. So I had skipped that slide because of time. That said many things, why we should do and whom we should do. It's not that a patient has some pancreatitis and we do genetics. We have to be clear what we want to do, and based on that we can choose our polymorphisms. In fact, in the West, only SPINK and PRSS are done for some patients. For some patients, only CFTR is done. So second is not that we have to do a whole panel. I mean, it depends on the age group, the pattern of the disease, the phenotype, and based on that we can select our genes.
Quickly, please. Yes.
Excellent talk as usual. Sir, I have one question, one issues with me that you have recommended that the first degree relatives of chronic acute pancreatitis, recurrent acute pancreatitis should be subjected for genetic testing.
Not all. If they have the PRSS1, R122, HNN29, not all.
Just like colonoscopic surveillance in colon cancer. But in this group of patients, how does the genetic testing help to the first degree relatives? Is there any
so if it is in that autosomal dominant pattern, the hereditary pancreatitis genes, so then this autosomal dominant pattern, that is why it's important to look at the family screening, not for the other disease modifiers like SPINK and cathepsin V or CFTRs.
Can we prevent the further recurrent acute pancreatitis in those group of patients?
It won't prevent, but you can decrease your threshold.
Point on the same, because you have opened a really important topic. See, what happens is that these are not Mendelian. Presence of a gene is not equal to having the gene. And this gene further have gene-gene interaction, then post-translational modification. Until unless odds ratio for a gene is very high, I will not incriminate that gene to be causing the disease by alone. And in fact, you have to do in silico analysis. So in my opinion, these are still in experimental stage.
So-
in individual practice, we sometimes do. Because we have nothing
But the PRSS one is autosomal dominant. That's only one gene in his pancreas.
yeah, but even
Others
there
are not,
also-
of course.
But there also there is a post-translational modification,
Yeah.
gene interaction. Presence of a gene is not equal to it.
Not equivalent to disease, he said.
Yeah, that's true.
So, did you
Okay.
look at the alcohol metabolism enzymes, like, if there are any?
Not yet.
Like
We did not
alcohol
look at the
dehydrogenase?
metabolism, not yet, yeah.
I think we'll have to close with hints from Sanjay. So please, sorry, Sanjay was hinting. Thank you very much,
Thank
Roop.
you.
Very well done. Thank you.
So thank you, sir. So I request speaker and chairpersons to kindly proceed to the felicitation area. Now we proceed to the next session meanwhile, which is on acute pancreatitis in children. To chair this session, may I request Dr. Joydev Rai, sir, Dr. Praveer Rai, sir, Dr. Bhashwati Acharya, madam, Dr. Shubhamay Das, sir, and Dr. Trambak Shamanto, sir, to please come on stage and start the session by introducing our speaker.
Hello. Dr. Sadhana and I did our MD together in 1990. Now she is the HOD of Pediatric Gastroenterology in PGI Chandigarh. I request Dr. Sadhana to give the Indian consensus on acute pancreatitis in children.
At the outset, I would like to thank Dr. Goenka for having this conference and having me over. Now, we'll quickly go through this because time is limited. So this was instigated, this consensus was conceived because of the explosion of acute pancreatitis and chronic pancreatitis that we are seeing. We actually had two parts of it, and the standard methodology was followed. We identified about 20 experts, made 6 teams, which identified with the aim of coming up with guidelines and guidance, I should say, to improve the care of children with pancreatitis. And the standard methodology as far as the level of evidence and grading of recommendation was followed. We identified PICO questions where we could, a lot of groundwork was done, and finally it culminated in the consensus in which the draft guidelines were made, which are due to be published soon. Okay, so for the definition, we all agreed that the INSPIRE definition of acute pancreatitis should be followed, which means abdominal pain suggestive of or compatible with pancreatitis. Now mind it, you have to understand here that in children, any nagging pain which is prolonged and severe, causing refusal to eat, has to be considered as pancreatitis, along with elevation of amylase and lipase at least 3 times. This is standard. And only 2 criteria needed to be fit. That means most of the time imaging is required, but ultrasound does the trick. The existing classification of pancreatic severity is also followed as per the INSPIRE, that is the International Consortium for the Prevention of Pediatric Pancreatitis. So same criteria is followed depending upon whether or not there is organ dysfunction and whether or not there are local complications. I think I'm not going to repeat this because we all know how to diagnose mild, severe and moderately severe pancreatitis depending upon the organ dysfunction being transient or prolonged and upon the presence of local complications. So what is different in children obviously is the definition of the organ dysfunction, and the cardiovascular dysfunction is defined as the presence of any of one of these 2 criteria despite administration of isotonic intravenous fluid bolus of 40 ml per kg. That means when the BP is not fitting the centiles, much below the minus 2 SD, and if there is a need of vasoactive drug to maintain the BP in the normal range, along with 2 of the other criteria of cardiovascular dysfunction, which include the metabolic acidosis, increased arterial lactate, oliguria, prolonged capillary refill, and a core to periphery temperature gap of more than 3 degrees centigrade. And this is the standard definition which we follow in pediatrics. And we have stuck to this. The lung dysfunction is again based on standard pediatric definitions of PaO2 versus FiO2 criteria, the PCO2 levels, and the proven need of more than 50% FiO2 to maintain saturation of at least 92%, and the need of non-elective mechanical ventilation. The renal dysfunction similarly, serum creatinine above 2 times of upper limit of normal for age, or a 2-fold increase in the baseline creatinine if known. We are edging towards we are edging towards new criteria, which is called the Phoenix sepsis score or criteria, which are again applicable to a large variety of acute illnesses spanning different organs. However, these are yet to be validated in the acute pancreatitis setting, so we have not recommended this so far. Possibly another 5 years of now, we would be shifting to this for the definition of multi-organ dysfunction. The baseline investigations is the second recommendation is simple, the CBC, the LFT, the calcium profile, lactate pH. Basically, we need to have investigations at the baseline which will prove the pancreatitis, which will determine the severity of pancreatitis. These are again standard, and the special scenarios in children especially, I would like to draw your attention to TMS, GCMS. This is an investigation which is targeted, which we tend to do in very young children with pancreatitis. The ultrasound, then imaging. This is the third recommendation. Imaging, ultrasound should be the initial modality in children with suspected diagnosis of acute pancreatitis, and there was a very strong agreement on this, though the level of evidence is B. However, because we find in practice that 80% of your diagnosis can be made, CT should not be used in case of routine evaluation of acute pancreatitis. It should not be used for routine follow-up without a proper indication in children, because as pediatricians we feel very strongly about radiation, and CT and MRI should be used for diagnosis only and only if the ultrasound is non-contributory. However, in cases of abdominal polytrauma with suspected multivisceral injury, we do have to do CT upfront even in children. Follow-up CT and MRI. There was some discussion earlier, and I completely agreed with the people who said in our center also, and in a lot of the tertiary pediatric gastroenterology centers, we are not routinely doing CT, what to talk of the first 3-4 days, but even in the first 7 days. So there has to be a definite case of clinical deterioration or a local complication which needs intervention. That is our criteria to do a CT in a child. We got sick actually of getting children in our wards who are already arriving with to you with a bunch of CTs done as soon as 2 or 3 days. Actually, your local complications also take time to evolve. So it is very difficult to to diagnose even either the severity or predict anything with a early done CT. So we have to restrict in children to when it is actually a clinically deteriorating child, or we have a local complication like an infected necrosis or a walled-off necrosis which needs intervention. Otherwise, then MRI is to be preferred. I mean, we are graduating or shifting, at least in our center, 95% of the imaging is MR based now, because again, it is children friendly and avoids the unnecessary radiation exposure. Then, coming to the topic of feeding, again, some discussion took place. Actually, if you look at all these scores, we were talking about what to do in severe pancreatitis, what not to do. If you look at all these scores, these do not actually rule in pancreatitis. They've got a good negative predictive value. The experience is similar in adults, as well as there is a big basket full of pediatric scores available. All of them, same story. Good negative predictive value, but very poor positive predictive value. So actually, when the patient is coming to you, you do not know where the severity is going to go. You will not be able to triage if you go on to the existing scores that are there. So what is good clinical practice. A lot of retrospective studies in children have shown that the outcomes are definitely better in those kids who have early enteral nutrition. So in our center, and this is our recommendation, this is the experience of the pediatricians based on various studies, though again the level is B, mind you, that we should aim for early enteral nutrition as soon as the patient tolerates, preferably within 24 to 48 hours. So in our unit also, you will find children on NIV in the first 24-48 hours with a Ryle's tube or a nasogastric tube at least in place to attempt to feed. And a lot of time, majority of the time, we are rewarded, and by the end of the week, we are able to institute at least 60 to 70% of the calories which the child requires, which is good going. So early nutrition. Then even in children with predicted severe acute pancreatitis, early initiation of enteral nutrition is what we recommended, as tolerated obviously if the child is not vomiting, is not having an exacerbation of pain, and is hemodynamically stable. For enteral nutrition, though there is not enough data to have in favor of any monomeric formulae or polymeric formulae for that matter. So enteral feeding with polymeric diet, that is the standard dalia khichdi, and even the semi-solid food, even on day 1 or 2, is what we recommended. However, we have to understand the problem arises in the rare case of severe acute pancreatitis in children. These are the children who are often on NIV, and their feeding becomes a little bit of problem. In those children, possibly the formulae which are available, the polymeric formulae, can be life-saving and save a lot of malnutrition in these children who will otherwise lose invariably more than 15 to 20% of their weights due to acute pancreatitis. The children requiring enteral feeding, nasogastric feeding should be initiated. If does not tolerate, then go on to the nasojejunal feeding. It should be started again if it is not tolerated, same thing in this recommendation. Then coming to the fluids quickly. Now again, this is a practical issue. Everybody recommends 1.5 to 2 times of the fluid to save the microcirculation and prevent the evolution into more severe disorder, disease and complications. However, practical situation on the ground, I think in pediatrics at least, and also I think in adults, your patient is not going to report to you within the first 24 to 48 hours. They will be sitting in the periphery with a lot of pain, lot of analgesia being given, a lot of people treating them, and finally they will realize that there is something wrong. The patient invariably lands in the tertiary care hospital at the time when the SIRS has set in. The capillaries are already very, very, very leaky. So we are not going to have indiscriminate fluid, at least in children. We have that's the next recommendation actually. The current one, on the basis of literature which showed that there is a better economics, no difference in the ICU admission rate in children. There are a couple of studies. So ringal lactate seems to have an edge because it causes less of hyperchloremic acidosis. So possibly ringal lactate is the recommendation from our group. Then again, this is the point I was making. Indiscriminate use of 1.5 to 2. You get pseudo-SIRS. You get pseudo-acute lung injury. We often have children referred to us, managed outside by gastroenterologists, that, okay, this patient has got persistent organ dysfunction. There will be pleural effusion, and the only thing we do is moderate the fluid intake, dry up the lungs a bit, and the kid sits up. So basically, lot of the kids in the periphery are suffering from over-aggressive use of IV fluid. So what is the standard? The standard is that the fluid therapy should be targeting parameters like the mean arterial pressure, the urine output, the blood urea nitrogen, and the hematocrit. And we advocate the liberal use of POCUS. In pediatric practice, pediatricians are inherently much better in intensive care because the training goes like this, otherwise you lose most of your patients. So the point of care ultrasound is an invaluable tool for you to decide what is your fluid therapy in your kid going to be like. So The pain, again, step-up management. Now, somebody said in the morning, standard is we avoid opioids in children as far as possible. A step-up approach, starting with paracetamol, escalating to NSAIDs like diclofenac. We are not against diclofenac, we use it extremely successfully. Upfront of use of opioids, even the milder ones, should be avoided because we are dealing with a susceptible population who are prone to addictions. So opioids to be used only if necessary. Largely, and the severe pancreatitis is not very common in children, not so common in adults also. So the upfront use of opioids is not advocated by us, and this is against what the INSPIRE shows, because there is enough literature to show that the use of parenteral paracetamol, and if it does not work, diclofenac, round-the-clock dosing in the first few days does wonders for the pain, in pediatric pancreatitis at least. So in case of lack of response, opioids should be used judiciously. Amongst the opioids, the weaker opioids are to be used before escalation to stronger opioids, and in the worst case, possibly in my entire career of 30 years, we have used ketamine as analgesia in about 3 or 4 patients of really bad obese kids with severe acute pancreatitis. Prophylactic antibiotics are not recommended in pediatric acute pancreatitis, and in the first week, CRP and WBC count should not be used to guide antibiotic treatment because they are going to be elevated anyway. So unlike the adult cutoffs of more than 150, we routinely see CRPs of more than 200 in most of our kids with acute pancreatitis, mild, moderate, severe, in the first week. So we really do not pay attention to it. Neither do we pay attention that much to fever in the first week, because all that inflammation inside the peritoneum is causing chemical irritation and will give rise to at least moderate grade fever. So procalcitonin is what we use. I'm sorry, I think I missed something. Maybe I think one slide I've missed. So procalcitonin, we have found second week onwards to be a much better bet to decide about antibiotics, and children are prone not only to infected necrosis but to other kinds of necrosis. So they have to be you have to be aware of those, or you have to be alert for those. Antioxidants not to be considered in acute pancreatitis. Insufficient evidence for the use of PERT for presumed pancreatic exocrine insufficiency during admission for acute pancreatitis, but things might change there in the context of acute severe pancreatitis with prolonged admissions and infected necrosis requiring drainage. Then majority of the collections are managed conservatively in pediatrics, unlike the adults. Intervention in the early phase may be needed in case of suspected or confirmed infected collections. Interventions after 4 to 6 weeks may be needed for symptomatic collections causing compression, persistent pain or infection, and radiologic intervention is preferred in the early phase when the ball is not mature if they require. Otherwise, endoscopic drainage is preferred when indicated and feasible, if there is an indication for drainage of a walled-off correction. Surgical necrosectomy, minimally invasive or open, is rarely needed but may be considered in those children who are not responding or amenable to radiologic or endoscopic drainage. In pediatric acute pancreatitis, ERCP is limited to those children who have got choledocholitis and have in addition got cholangitis, otherwise no indication of ERCP, though if you have an odd case of traumatic pancreatitis with a disrupted duct, you may judicially use ERCP to bridge the gap a little later on in the course. Systematic screening for abnormal glucose metabolism may be performed after the first episode of pancreatitis, at least 3 months, and again at the end of 1 year. Cholecystectomy, obviously these are standard things, is indicated in all pediatric patients after first episode of gallstone related pancreatitis, and the ideal timing is during the same admission or at least within the first 4 weeks to prevent the occurrence of recurrent pancreatitis. And in severe acute gallstone pancreatitis related pancreatitis, the cholecystectomy obviously needs to be delayed till the inflammation and the local complications resolve, usually which will take about a couple of months. So, to conclude, pediatric acute pancreatitis is a rapidly increasing problem in children, and the fraction of children with severe acute pancreatitis is probably much lower than adults. Ultrasonography suffices as an initial imaging modality in most children. MRI is to be preferred modality of cross-sectional imaging, but should be performed only for concrete indications, not as and when you please. Fluid management should be goal-directed and not indiscriminate, and a step-up approach for the pain management with opioids best avoided. Early enteral nutrition with a polymeric diet remains the crux of management of pediatric acute pancreatitis. The use of antibiotics should be judicious, and the pancreatic collections, I think they need the approach which has already been discussed. Thank you. This is the team which led to the consensus, and I'm just representing them. Hard work was done by all of them. Thank you.
Thank you, ma'am. I think that was a very lucid introduction, as well as a journey to the guideline and management of acute pancreatitis in children. Because we are running short of time, I think if the organizer allow me one quick question. So just one single question, ma'am. For your, since you are representing a tertiary care center with the maximum load of referrals of this pancreatitis to you, so just one question I would like to, what is your experience or take in acute severe pancreatitis with a high procal? So would you start IV antibiotic, or you will directly push to a intervention radiologist for a quick drain, percutaneous drain, to give a quick relief? So
obviously, in the first week, we really take
after the first week, ma'am.
After the first week of thing, we do use a rising procalcitonin. A rising procalcitonin, procalcitonin can be elevated in elevation as well as if there is renal dysfunction, that's a double whammy. It is going to rise. So a rising procalcitonin we take as a marker, plus worsening SIRS. Worsening SIRS usually indicates an infected collection, and if there is and that is the point when the SIRS is worsening after the second week, that is when we would go in for a CT, because we mentally make up our mind that possibly if this child is not going to improve without a drainage. So such children with a lot of pus lying inside them, no point giving only antibiotics. Yes, you have to drain them if you have to cure them.
Sir, if you can share your experience. I think I pushed a lot of patients of this acute necrotism in adolescents at least for this drainage, and we have done a few cases.
So as Dr. Lal just said, that we try to avoid drainage in the first week unless we think a situation of compartment syndrome. Yeah. So if there's a compartment syndrome, we would drain even if there's no evidence of sepsis. Otherwise, first week we avoid. But we are very liberal about draining the second part. I think we are coming through a cycle when we try to avoid it. Now we are a little liberal whenever the indications which she talked about is there, we would usually drain.
Yes.
And drain with the largest possible bore of the catheter.
Yes, sir. So that is the message we have a lot of physicians also in this hall. So they are also managing pancreatitis in the periphery. So that is one message. After 7 days or after a week, if the patient is not improving, we are suspecting a necrotized infected collection, they should be referred to a tertiary center for the intervention. That's
not only on we see very few of these. And I think in the main text of the guideline, obviously this is elaborated a little more. It is almost exclusively limited to the very obese children with pancreatitis.
Thank you, ma'am. Thank you for the audience. And thanks from all of us.
Thank you, ma'am. So I request the chairperson and speaker to proceed to the felicitation area. Now our next session will be a competitive session on pancreatobiliary endoscopy with 3 presenters. To chair this session and be the judge, I request Dr. D. Nageshwar Reddy sir, who needs no introduction, is the chairman AIG Hyderabad. May I also request Dr. Mohesh Goenka sir, Dr. Matthew Pilip and Dr. Monu Tandon to please come on the stage and start this competitive session on video endoscopy.
I think I can't see Nagi as yet in the hall, so he can join as soon as he comes, but Matthew and Manu. Manu was around. So we can start with the first presentation, and there are 3 selected videos. Each would have 7 minutes, so please stick to your time, and then we have
good 3 minutes for discussion. Interestingly, when I was looking through the list and when we decided they're all three US related, so obviously US is gradually taking over from the conventional endoscopy. So I would request the first presentation, Manu please join. The first presentation is EUS guided pancreaticogastrostomy as a patient-centered alternative to LPJ for benign obstructive CCP after failed ERCP. Dr. Jonalagada Bihari is going to present it.
Good afternoon, respected faculties. Myself, Dr. Jonalagada Bihari, DM final year resident from Some Hospital, Bhubaneswar. Today, I am going to present the case of US guided pancreaticogastrotomy as a patient-centered alternative for LPJ in benign obstructive CCP after failed ERCP. Here in this case, it is a 62-year-old female with chronic calcific pancreatitis presenting with worsening postprandial epigastric pain, vomiting and poor oral intake. She had significant comorbidities including hypertension and poorly controlled diabetes with a HbA1c of around 10.3. On evaluation, it was confirmed to be an acute exacerbation and MRCP revealed a dilated 7 mm main pancreatic duct with intraductal sludge and microlysis. Biliary anatomy was normal. As per standard practice, we first attempted ERCP for ductal decompression. However, despite the multiple techniques, we were unable to cannulate the pancreatic duct via either the major or minor papilla, a challenge often encountered with tight strictures or distorted anatomy. At this stage, surgical drainage via the LPJ, longitudinal or lateral pancreaticogynostomy, is the traditional next step. However, due to her high surgical risk and personal refusal of surgery, we were in a difficult position. ERCP had failed, surgery was not an option, and the patient remained symptomatic. This is where US guided pancreatic duct drainage came into consideration. While US guided pancreatic duct drainage is one of the most technically challenging procedures in therapeutic US, requiring a stable scope positioning and precise wire manipulation throughout the fibrotic tissue. So it offers a vital, minimally invasive pathway. Following a step-up strategy, since retrograde access had failed, we proceeded with antegrade transmural drainage. As shown here in the various available pathways, including transpapillary, transenteric routes, the most practical option here was US-guided pancreaticogastrotomy, creating a direct tract between the duct and the stomach. Technically, we identified a safe transgastric window using the Doppler to avoid the vascular structures, and we then punctured the duct with a 19-gauge needle, which provides the necessary stability to advance a 0.025-inch guide wire. Once the wire was secured and coiled within the duct, we created the tract using a 6 French cautery-assisted cystotome. A 5 French by 7 cm single pigtail stent was then deployed, establishing the pancreaticogastric fistula. We observed the immediate drainage of pancreatic juice, which was highly reassuring. The procedure was uneventful. Clinically, the patient improved rapidly, her pain subsided, and she was discharged in stable condition. At 6 weeks follow-up, she remained asymptomatic with imaging confirming a patent tract and reduced ductal caliber. Looking at the global data, this US guided pancreatic duct drainage carries a technical success rate of almost 75 to 80%, while the adverse event rate is approximately 15 to 20%, including the risk of pancreatitis or leakage. So a careful patient selection and procedural expertise are key to mitigating these risks. To conclude, this case demonstrates that when ERCP fails and surgery is not feasible, US guided drainage offers an effective orgone preserving technique and alternative. With growing standardization in advanced therapeutic centers, US pancreaticogastrotomy is increasingly becoming a reproducible technique. Our experience at this tertiary care hospital in Orissa highlighted that it can be delivered safely, providing a meaningful clinical relief in an expert setting. Thank you.
Thank you for a very clear presentation. Before I open the case, a couple of questions. Did you try to go across the papilla?
Yeah.
Because that would be a more anatomical treatment for such. That's number one. And number two, what do you intend to do over a period of time? Whenever we do a pancreaticoendotherapy of this type, we usually exchange the catheters every 6 months to 1 year. So what's your long-term plan in this case?
Sir, in this patient, we plan to follow up, initially we followed up at 6 weeks, sir. 6 weeks she was asymptomatic and stent was in situ. And our long-term plan is to follow up every 6 months with MRCP. And if in case, our plan is to go for stent exchange every 6 months for 4 times till 24 months. Then after stent withdrawal period trial, we plan to go ahead with the stent withdrawal trial after 24 months.
So if I can ask you a counter question, puncturing a non-dilated duct may become a little more difficult during the second attempt. So did you try to go across the papilla and establish the drainage into the duodenum?
Yes, sir, we can try actually.
You should go across what the...
Yes, sir.
I wanted to ask you, how are you going to do it the second time? You're going to remove this stent and redo the procedure, or how are we going to do it? The second time, this was very well done, excellent. Let's say 6 months. The life of any plastic stent is 6 months. If you're lucky, beyond that, otherwise, by itself, it's an nidus for a stone.
Yes, sir. Usually stent migration almost 50%, 40 to 50%
So
by 6 months stent migration usually
What do
happen.
you do next time? You redo the whole procedure.
No, sir.
Yeah.
We'll try to, if stent is in situ, we'll try to pass the guide wire through the
stent. That may be a little,
may
not be so easy.
No, that is the only option now.
Uh-huh.
You can attempt passing a guide wire through the stent into the biliary system. Then once you have, into the pancreatic duct system, once you achieve, if you are able to pass into the duodenum, is fine. Otherwise, use a stent retriever to remove the stent, and then it's maybe not very easy as we do, because the guide wire in the pancreatic duct is not huge. Yeah, it's not that good length. It's a technically challenging. Always try to pass through that ampulla. But I agree. Sometimes you fail and you have to put the stent. You have to come out of the pain after time. And many times I've seen the patient pain reduces. Then we can remove the stent also after some time. But again, they may come with the pain. But that immediate response will be good. Probably then we can try through the papilla. Some days it succeeds.
You want to make any comment? Jaydev? All right, then.
Thank you, sir.
Thank you. Well done, anyway. It's a good procedure. Well, the second also, as Mahesh has said, EUS is taken over. EUS guided pancreatopleural fistulogastrostomy as a salvage procedure in a pancreatopleural fistula. Dr. Saswati Kar is going to present that. Saswati, yes, you've got 7 minutes and then we'll take the questions.
Good evening, everyone, respected faculty and judges. I'll be presenting this US guided pancreaticopleural fistulogastrostomy as a salvage therapy in pancreaticopleural fistula. So I'm a final year DM resident from AIIMS Bhubaneswar. So, yes. Pancreaticopleural fistula is a rare complication in acute pancreatitis, especially in a setting of chronic pancreatitis, which is seen in up to 0.4%. Especially in cases of pseudosis, it can be seen in up to 4.5% of the cases. Mostly the etiology being alcohol, but it can also be seen in traumatic pancreatitis, gallstone-induced pancreatitis, and idiopathic pancreatitis as well. And mostly it presents as a pleural effusion, which can be gross, which can be recurrent, mostly left-sided, which need recurrent thoracocentesis, intercostal drainage, and with very minimal abdominal symptoms, it can lead to delayed diagnosis, and the clinching points being the very high pleural fluid amylase and protein levels. Along with that, our imaging can help like CECT and MRCP, which can really find out like with the fistula tract and the cause of the pleural effusion being a pancreaticopleural fistula. And traditionally, the management being like we can go from conservative management. However, spontaneous fistula closure can only be seen in up to 30 to 60% of the cases. Apart from that, the endoscopic management, which can achieve fistula closure and the resolution of PPF in up to 80% of the cases. And if that fails, we can go for surgery. Till now, traditionally, ERCP with pancreatic sphincterotomy and pancreatic duct stenting is the first line endotherapy for pancreaticopleural fistula. I'll be presenting one case here, a 46-year-old male who presented with left-sided pleural effusion. He had history of alcohol use disorder with CCP and underwent and had an acute exacerbation 3 months back, and he presented with a left-sided pleural effusion. And here we can see in a coronal view of the CCT, pancreaticopleural fistula, which is communicating with the main pancreatic duct. And the MRCP was also done, which showed this fistulous tract communicating with the left pleural cavity. And this is the US view, where we can identify the fistulous tract with the hypoechoic, this collection we can identify. And it is seen to communicate posteriorly with the left pleural space, as we can see here. Then under the US guidance, the fistulous tract was punctured with a 19 gauge FNA needle, pancreatic fluid was aspirated, and the guide wire was advanced into the fistulous tract. Here it is technically challenging, just below the G junction, and we have to be careful while advancing the guide wire, because minimal space can be seen here. Then following this, the communication was created between the cardia and the fistulous tract using a 6 French cautery-guided cystotome. As we can see, the cystotome puncturing the fistulous tract. Following this, we are trying to deploy a 7 French 7 centimeter stent with one end in the fistulous tract and the other in the gastric lumen. This is the final picture of the stent placement, and this is the X-ray where we can see how the fistulous tract and the stomach, this is the fundus gas, so the stent is placed, and there is resolution of the pleural effusion. So at 3 months follow-up, there was no recurrence of pleural effusion, and we have to say that in other, apart from this, there are other cases where the ERCP had failed initially for management, and then we had resorted to this modality, and it can be used as a rescue option in cases of failed ERCP. Thank you.
Can I ask? One question, Saraswati.
Yes, sir.
Suppose you had done, see the proximal duct is grossly dilated, your MRCP, it's chronic pancreatitis. Suppose you had put a stent from the stomach into the proximal part, it would have been like an ERCP. I am sure the fistula could have closed if you had drained from the proximal.
Yes, so did the ERCP fail in this case?
Yes, sir.
Failed, he said. So
ERCP failed.
Yes, sir.
EUS you are doing, maybe that's another alternative. Proximal to the fistula, if you can drain, that's what we do in ERCP. We drain, many
Yes,
times
sir.
we don't cross the fistula, we drain proximal and
Yes, sir.
since the pressure drops in the PD, it closes.
Sometimes.
So that's an alternative.
Yes, sir.
My question is about the choice of stent. You have used a double pigtail stent.
Yes, sir.
Usually when we do pancreatic endotherapy, the end inside the duct is usually a straight end.
Yes, sir.
So why did you choose a double pigtail stent? Can somebody answer from your team or you?
Sir, it derives from the way we do the cystogastrostomy. The concept is similar to that. It's related to that. The transmural drainage of cystic cavity. So we are treating the fistulous tract as that. And in due course of time, we have seen that the stent migrates in the patient, just like in a case of cystogastrostomy. So that was the idea behind.
Thank you. Nice case. I think one small problem in the video. Once you puncture, then don't keep the Doppler on, because that will hamper the visibility of that. Every time you pass
Yes,
it.
sir.
So the moment you puncture, it's done. So no need of any Doppler at that time.
Yes, sir.
Otherwise, the quality of it would have been so good. And I agree to Dr. Mahesh that the inside one should have, because the size is not big. Double pigtail, there is no space to keep it there. No, it's better to put you could have put a guide wire into the pleural cavity, and you could have put that limb of that distal limb deep into that fistula. Anyway, it's good. The patient is doing well, no?
Yes, sir. No recurrences.
Okay.
Thank you, sir. Thank you so much.
I think we will call upon the next case by Dr. Vikas Panwar, and he is presenting on celiac plexus block and pancreatic decompression as synergistic protocol for refractory chronic pancreatitis. Dr. Abhishek. Okay, Dr. Abhishek, please.
Louder. This that side. Cricket match, you know.
Alternate.
Good afternoon, sir. Good afternoon, everyone. Myself, Dr. Abhishek Sinha from Artex, Kolkata. I'm going to present a video presentation on US-guided celiac plexus block and US-guided pancreatic ductal decompression for a patient of chronic calcific pancreatitis with significant pain. We had a patient, 53-year-old hypertensive male patient who has a history of chronic calcific pancreatitis since last 8 years with severe pain of VAS score 8. Pancreatitis cause was most probably due to alcohol use, and this was associated with loss of appetite and weight loss. He also had a history of ERCP 2 times before and pancreatic duct stenting for the pain, and also had symptoms of exocrine and endocrine insufficiency. The lab reports were normal. Endoscopy showed gastritis, and there was edematous D1, D2 junction, and the side view endoscope was not negotiable beyond D1. The outside contrast enhanced CT was done, which showed chronic calcific pancreatitis with bulky pancreatic head and atrophic body and tail. Multiple parenchymal and intraductal calculi was also seen with a small pancreatic pseudocyst of 1.8 into 1.8 centimeters. So I'm going to start the video now. And I don't know, sir.
You may go to the attached file.
Yes, sir. And video actually. Video is not.
Click on the video.
Actually. Video is.
Can somebody run from the console? Do you have an attachment?
Sir, no, sir. Actually, my colleague.
It's all right, but you don't have the folder. You don't have the folder.
I have a video in my mobile, but that's not edited. That's a long
Oh
video.
no.
What did you do?
You just explain what was done.
So first, US guided celiac plexus block was done, and on the next day we did the US guided pancreatic duct drainage. So in the celiac, first we identified the aorta and the left crus of diaphragm, and just superior to that there was we could see the left adrenal gland, which was hypoechoic, triangular shaped, and in this case we found it a bit difficult to find the celiac vessels and the aorta most probably due to distortion of the anatomy due to chronic pancreatitis and post interventions. And eventually we were able to locate the celiac ganglion, and we put a 19 gauge FNA needle into the celiac ganglion, and we injected with triamcinolone and bupivacaine, almost 80 mg triamcinolone and 20 ml 0.25% bupivacaine in that place. But first we aspirated so that we could see that there is no blood in the needle, and then we injected, and while taking out the needle also we kept injecting so that the entire plexus could be covered. After the celiac block was done, the next day we took the patient for US guided pancreatic duct drainage, and we identified the dilated pancreatic duct. We put again the 19 gauge needle, FNA needle. We aspirated the pancreatic juice to confirm our position. We put the contrast and saw the pancreatogram, which showed dilated pancreatic duct, and there was also filling of the pseudocyst, which showed there was connection of the pseudocyst with the pancreatic duct. After pancreatogram, we
so you possibly the same procedure what was
yes, sir,
described in the first case. Can you go to the next slide then?
Where did you put the stent? I wanted to know. Where did you put the stent? Beyond the stones, proximal, distal, or in between the stone? You had multiple stones.
Yes, sir. Yes, sir.
Where did you put the
Sir, beyond the stones only.
Means proximal.
Proximal most.
Towards the duct.
And we also tried to pass the guide wire through the head of the pancreas to do the rendezvous, but it was not achieved. So we then dilated with a sphincterotome and hurricane balloon up to 4 mm, and then we put the stents at 7.
So can we just have a look at the literature you have prepared subsequently? Next slide.
Sir, then we just, the literature part, that the combination of these two procedures has not been studied yet, but individually we went through the meta-analysis, which showed there was efficacy of the pancreatic duct drainage is almost 80% for the pain reduction, and for celiac plexus block it's almost 60% for the pain reduction. Both the procedures performed together can synergistically reduce the pain. However, it should only be done in the expert center by experts.
See, I think we must have a very clear take-home message. Now, whenever we deal with a pain in the chronic pancreatitis and there is an intraductal pressure which is increased, our first aim is to reduce the intraductal pressure. And that can be done either by stenting, stone removal, extracorporeal shockwave lithotripsy. And if these fail in very rare situations in chronic pancreatitis, we advocate celiac axis block. So I think in this case, you did a celiac axis block first, and then next step you went to drain the duct. This looks unphysiological overall to me. Rupjyoti, you would like to comment on this?
Yeah, clearance would have been a better option, whichever way you took, surgical or medical.
So,
my first choice would have been surgery for this patient, because we cannot go beyond duodenum, go beyond the pylorus into the deep duodenum, and doing celiac plexus block, it is seldom practiced, because it can produce abscess if a patient has diabetes, maybe if a patient has diabetes. Unless it is really mandatory, don't do that. Maybe in my practice, I do a lot of celiac plexus neurolysis for cancer, pancreatic cancer, but not for this one. Maybe I've done in the past, 20 years, 25 years back, when it came into the field. Now nobody does, I think. It's okay, but we missed seeing your video, interesting video, but I think, the message is that we should try a one-time procedure because, surgery would have been much better for him if that was advisable in this patient. Thank you.
Any comments from the audience? Anybody want to make any comment?
I think we'll
No.
close.
In that case, we'll close the session.
Yep. Well done, all of you. Keep
Sir.
up the good work.
Sir,
Yes.
For better pain control, can we do both these procedures, or is it advisable to just drain the pancreas first and see for
First the drain
he
the
has already
pancreas.
been underwent 2 times CRCP and PD stenting, and still his VAS score was almost 8, sir, severe.
That's why
pain.
what Matthew
And-
said, maybe surgery would have been a first option. Third option, after the 2 ERCPs. Yes, so now you can't go, maybe surgery. Anyway, PD decompression, ductal hypertension.
Thank you, sir.
Thank you, everybody. We'll close this.
Thank you, respected judges and the presenters. Now we move to our next session. To chair this session, may I request Dr. Partho Sarkar sir, Senior Professor, Department of Medicine and Chairman, API West Bengal. May I request Dr. Somir Mohindra sir, Dr. Manoj Agrawal sir, Dr. Amitava Goswami sir and Dr. Partho Saruthi Patro sir to please come on the stage and start the session, which is on the gut pancreatic axis.
So this session will be on gut pancreatic axis and the role of gut microbiome in pancreatic diseases. To talk on that, I will ask Dr. Uday Ghoshal, who is a senior consultant in gastroenterology department, Apollo Hospital, in the motility disorder division. So, very relevant topic, though it is evolving over now. So without wasting any further time, I will request Dr. Uday to start deliberation. Stage is yours.
Thank you. Thank Dr. Sanjay for giving me this opportunity. I'll be talking about the gut pancreas axis. So I want to address 2 questions. How gut, or in other words, gut microbes and their metabolite may influence pancreas and its diseases. We know there are several other control systems from the gut to the pancreas. For example, through neuroendocrine system. We are not going to address them in 15 minutes. I'm not talking about neural control from the gut of pancreas. I'm not talking about control by the hormones, gut hormones of the pancreas. I'm going to talk about microbiota and its metabolite because this is the most current topic. And how pancreatic diseases influence the gut microbe. So if you look at the gut pancreas axis, there are several microbes in the gut. Obviously, gut contains more bacterial cells than number of human cells that we have. And there are several metabolites that are produced, for example, short-chain fatty acid, tryptophan, bile acid, and so on. They're important for barrier integrity because in intestine there is a barrier so that macromolecular antigen cannot go beyond epithelium. Because if they go beyond epithelium, they start having immune interaction And then this immune interaction can produce several cytokines, obviously through adaptive and also innate immune system. And these cytokines can affect the pancreatic endocrine cell, particularly the beta cell, and even they can kill the beta cell by apoptosis. So therefore, microbiota, through their metabolite, influence beta cell function. Let us look at this obesity. Obviously, obesity causes a lot of pancreatic problem. We now know there is an entity called non-alcoholic fatty pancreatic diseases, and this is associated with acinar cell death. It causes insulin resistance, beta cell damage, diabetes. There is increased severity of acute pancreatitis on obese patient. There is altered bile acid metabolism, also bile stasis, predisposing to gallstone, and even obese people have greater risk of pancreatic cancer. Question is, does gut influence obesity? Is it related to the amount of food that we eat alone, or is it related to microbiota? There is a very common practice that the animals are treated with antibiotic to produce more flesh, to produce more meat. And this was scientifically proven in 2012, where biopsy mice were given antibiotic, different types, and water. And they looked at microbiota change with antibiotic. Yes, it was there. They looked at gonadal mass, and they looked at overall muscle mass or fat mass of these animals. And they showed that microbes or microbiota of the gut can cause obesity. Is there a human proof? Yes. This is a very interesting study from UK where more than 21,000 children who were born, they were traced backward to their first birthday. And during this 4 years, they looked at, did they receive antibiotic? And they found 6% of them became obese 4 years later after birth, and those who became obese more often received antibiotic, and it is independent of all factors. And this is one of the best human study to show that microbes which are influenced by antibiotic can lead to obesity. This is a very interesting study from Israel which showed that exercise, type of the food, for example, low glycemic or high glycemic food that we eat are not the major factor that influence blood glucose. But the major factor is gut microbiota. Because of shortage of time, I will not go through the entire study, but this is one of the best study that I have seen published in Cell. So what gut microbe causes in the system? For example, talk about liver, talk about pancreas, talk about immune system. There is an obese gut microbiota which reduces fatty acid oxidation. It causes more inflammation of the fat, increased fat in the liver and pancreas. There is increased butyrate production in the colon, and we all know those who are more firmicute, they extract energy from unabsorbed carbohydrate. So therefore they became obese, and there is a reduction in incretin secretion. On the other hand, lean microbiota causes more fatty acid oxidation, decreased inflammation of fat, less lipogenesis in liver, less butyrate production in the colon, and increased incretin secretion in the gut. So therefore the microbe is influencing in big way fatty pancreas, pancreatitis, and so on. Now look at the effect of the pancreatic diseases on microbe. For example, I am talking about small intestinal bacterial overgrowth now, and we know that chronic pancreatitis patients more often have small intestinal bacterial overgrowth. It may happen because we give PPI to them. Second, many of them have maldigestion of the fat, and we know fat, if it is maldigested, it goes to the ileum, produces neurotensin and enteroglucagon, gives break to the small bowel motility, and there is an increased colonization of bacteria because of stasis. There could be stricture in the duodenum in this patient, which can lead to also bacterial overgrowth. Now, also cholecystectomy that is often done in patient of particularly acute pancreatitis has been shown to cause bacterial overgrowth because bile is an important antibacterial substance for the gut. And also drug, for example, opiate tricyclic that we regularly prescribe to the patient can slow motility and cause bacterial overgrowth. Let us look at the literature. This is some of the studies, particularly this is a study that we did while we were in SGPGI, and Samir is here, and Samir is one of the co-author or rather lead author, where we found chronic pancreatitis patient as high as 15% of bacterial overgrowth compared to 1.3% of the control. I was doing a meta-analysis recently, and obviously it is currently under review in digestive disease science, and what we did is we looked at all studies which looked at bacterial overgrowth in patient of chronic pancreatitis, and also those studies which had a control group to compare. And obviously what we found is you can see the odds ratio for bacterial overgrowth in chronic pancreatitis almost 10. What does it mean? If a patient has chronic pancreatitis, he has a 10-fold greater risk of having bacterial overgrowth. So therefore, if you test it, you will get it. Now also, when you give PPI to this patient, indiscriminately given along with pancreatic enzyme, which may not be always needed with enteric-coated tablet, they may develop bacterial overgrowth, and this is the data to show that long-term PPI can cause bacterial overgrowth. But when I was doing meta-regression of all this study to look for which are the factors that predisposed to bacterial overgrowth, interestingly on meta-regression, these factors did not become important. That means that whatever we talk about, presence of diabetes, pancreatic enzyme insufficiency, even use of PPI, they did not come to be significant, maybe because of a small number in those studies and therefore possible type 2 error. Now, what are the unanswered questions? There are no doubt that pancreatitis, chronic pancreatitis is associated with bacterial overgrowth, but what are the unanswered questions where you can embark a study? Is there a relationship between bacterial overgrowth, symptoms, severity, steatorrhea, and malnutrition? Only in 5 of the 13 studies, antibiotic was used to treat bacterial overgrowth in this patient, and all studies use antibiotic in a non-randomized manner. There is a scope to do a randomized controlled trial. And let us look at, this is a recent paper that Kakoliul is presenting in the room B from our center, where in last 2 years, 33 patients with chronic pancreatitis at our Apollo multi-specialty hospital and 51 historical healthy control, we looked at bacterial overgrowth. And look at this, almost 9 out of 33 patients with chronic pancreatitis had either hydrogen-producing SIBO or methane-producing SIBO or both, compared to only 1 out of 51 control. Now, small intestinal bacterial overgrowth in acute pancreatitis, does it happen? There is no study till date. Why there is no study? One of the reasons is whenever a patient of acute pancreatitis gets admitted, he gets antibiotic. And I'm not saying that it is always needed, but unfortunately they get it. And if they get an antibiotic, we cannot do a bacterial overgrowth study. But I believe, and many authors believe, that this may be an important having bearing in relation to development of septicemia, development of infected necrosis and so on, but unfortunately there is no data on this till date. There is a need for study. Also, we know obesity negatively influences severity of acute pancreatitis, and also hypertriglyceridemia does the same, and both of them have metabolic basis, and also microbiota and gut plays important role. Is there a relationship of pancreatic cancer and gut microbiota? There are a lot of conjecture, there are a lot of hypotheses, there are a lot of discussion. Now, only thing is there is no good foolproof study, but it is not impossible because we know microbes can cause carcinogenesis, viruses, bacteria and so on. For example, EB virus causes lymphoma, gastric cancer, H. pylori causes gastric cancer, primary gastric lymphoma, HBV causes HCC, human papilloma virus causes cervical cancer, human herpes virus causes Kaposi's sarcoma. So therefore, if the literature that is trying to show or project that pancreatic cancer can have an etiological issue in gut microbiota is possible, but there is no literature. Interestingly, now people are hypothesizing gut microbiota can lead to or predispose to acute pancreatitis. The reason is we all know microbiota influences our immune system and therefore autoimmunity. There is no reason why this should not be suspected, but there is no study yet. So gut microbiota, pancreatic diseases, we have more question than answer, and we don't know what came first. Is it the microbiota alteration that led to these diseases, or is it the disease that led to microbiota? There are several other issues that I could cover, but obviously I have only 10 minutes, so therefore thank you. I give greetings to you from our institute and also invite you to 2 forthcoming meetings, one in Coimbatore of Australasian Neurogastroenterology and Indian Neurogastroenterology Motility Association, and other is World Congress of Gastroenterology at Delhi. Thank you so much.
Thank you so much for a topic. I think microbes are coming into everything and anything now. Is there any role of probiotics or postbiotics in some of these diseases?
Yeah, very good question. I tell you, probiotics are also being projected very rampantly everywhere. But I tell you, probiotics are relatively weaker agent to modulate gut microbiota, but they are probably safer agent. So if you are talking about SIBO, typically I don't treat SIBO patient with probiotic. I give them antibiotic. So what happens is I will give rifaximin, and in fact we need a study that can rifaximin in patient of chronic pancreatitis with SIBO improve their malnutrition, improve their steatorrhea, improve their diarrhea, and make their absorption better. There are some data that once you have treated them with antibiotic, the recurrence of SIBO is very, very common, and probiotic and prokinetic may prevent the recurrence. So in chronic pancreatitis, I would not sort of give any strong suggestion that you should be treating with probiotic, but you should be treating with antibiotic if SIBO is present.
Are there anybody else? Any other questions from the audience?
The bacterial overgrowth.
Yes.
I think it is the result because chronic pancreatitis patients have several problems, including there are studies to show there is a gut immune deficiency, because we all know that defensin is a very important antibacterial substance in the gut. It is liberated by Paneth cell of gut mucosa as prodefensin. It is trypsin which cleaves prodefensin into defensin, and therefore it works as an antibacterial. And we all know that pancreatitis patient has a deficiency of obviously trypsin, and therefore the prodefensin will be less liberated. Also we are giving PPI, we are giving opiate. All these factors can be causing the bacterial overgrowth. So I believe that it is an effect rather than the cause.
Excellent.
Thank you, Dr. Sir.
Can I ask one question?
Yeah.
Excellent talk. That some issues I want to know from you, that in the chronic pancreatitis with exocrine insufficiency, there is lot of fat in the intestine, and that fat is maldigested. So there is that incurs the small intestinal bacterial overgrowth. So how these metabolites of this bacterial overgrowth can influence the beta cell dysfunction and ultimately development of diabetes?
Yeah, you see,
Is there
very good question. It is not that bacterial overgrowth is only factor causing beta cell dysfunction. But there are some data which are animal model data and also molecular studies to show that if you have bacterial dysbiosis and overgrowth, there is increased cytokine. And some of these cytokine affect beta cell function. But other than that, why do the bacterial overgrowth develop? I told you, if you put excess fat into the distal part of the small bowel, that is ileum, it liberates peptide YY, neurotensin, and enteroglucagon. It causes ileal break. What is ileal break? It is fat-induced slowing of proximal gut motility. Therefore, there is stasis and bacterial overgrowth.
Thank you, Dr. Kushal, for an excellent overview of the topic. Thank you.
Thank you, sir. May I request speaker and the chairpersons to please move to the felicitation area. Now we proceed to our next session. To chair this session, may I request Dr. Joyanto Dasgupta, sir, Dr. Uttam Pal, sir, Dr. Sunil Baron Das Chakraborty, sir, Dr. Shubhobroto Ganguly, sir, and Dr. S. Rakesh Kumar, sir, to please come on the stage and start the session introducing our speaker. The session is on early diagnosis of chronic pancreatitis from bench to bedside. Requesting our chairpersons to please come on the stage. Dr. Joyanto Dasgupta, sir, Professor Uttam Pal, sir, Dr. Sunil Baron Das Chakraborty, sir, Dr. Shubhobroto Ganguly, sir, and Dr. Rakesh Kumar, sir.
Hello, next session is early pancreatitis and early diagnosis of chronic pancreatitis. The speaker is Dr. Prabir Roy.
Very good afternoon. I'd like to thank the Kolkata Pancreas Club and Dr. Sanjay for this wonderful opportunity. So, I'll be talking about early diagnosis of chronic pancreatitis from bench to bedside. So first we need to understand what is this term early chronic pancreatitis. So it's defined as a distinct borderline clinical entity between acute or recurrent acute pancreatitis and established chronic pancreatitis. So identifying ECP, that is early chronic pancreatitis, it provides an opportunity for timely intervention as parenchymal changes may be reversible and progression towards end-stage fibrosis has the potential to be discontinued. So how common is this? So the global incidence of chronic pancreatitis is 10 per 1 lakh persons per year, and significantly more men than women are affected. In Japan, the overall prevalence of early chronic pancreatitis is high, that is 4.2 per 1 lakh persons, and the annual incidence is 1 per 1 lakh persons. In a Dutch population-based study, the cumulative incidence of chronic pancreatitis after recurrent acute was 13% at 10 years, and it indicates the importance of detection of early chronic pancreatitis. And early chronic pancreatitis is estimated to affect around 10 to 20% of patients initially diagnosed with recurrent acute pancreatitis, especially in alcohol-related cases. So this importantly means that to pick up this entity is important as halting the progress of the disease in certain scenarios like alcohol, smoking, it prevents the development of the disease, and that's the reason it's important to detect this at this stage. So this is the Japanese guidelines which were published in 2018, initially in 2009. CDCC stands for Clinical Criteria for Diagnosis of Chronic Pancreatitis. And this, as you can see, this 2019 guidelines, this importantly looks at the clinical parameters and the imaging parameters. And if you see this, the clinical parameters include repeated upper abdominal pain or the back pain, abnormal pancreatic enzyme levels in the serum or urine, abnormal pancreatic exocrine function, and continuous heavy drinking of alcohol equivalent to more than 60 grams per day of pure ethanol or pancreatitis-related susceptibility genes, and history of acute pancreatitis. So to establish a definite diagnosis of early chronic pancreatitis based on this Japanese guideline, you need to have 3 or more diagnostic items. So these are the diagnostic items. Out of 5, you need to have 3. Along with this, you need to have either the imaging features, either A or B. What is A and B? A is US findings, 2 or more findings, including 1 or 2 both, that is hyperechoic foci or strands. Lobularity, what are these? I'll come to that. Hyperechoic duct margin and dilated side branches. So as you can see in this criteria, importantly, they have mentioned upon US as one of the most important imaging to make a diagnosis of early chronic pancreatitis. The B is irregular dilatation of 3 or more branch pancreatic ducts on ERCP, which no one does now, or on MRCP. So on MR, you have irregularly dilated ducts, more than 3. And on US, you have the typical features of early chronic pancreatitis, which are picked up on US to make a diagnosis of definite ECP, while a probable ECP is when you have out of these 5 only 2 diagnostic items, and along with this, one of either A or B. So it's a bit complicated, but this is what we have to diagnose ECP as of now based on Japanese guidelines. So in 2016, Whitcomb, who obviously does a lot of work in chronic pancreatitis, established a mechanistic definition of chronic pancreatitis. And this mechanistic definition means it's not just the structural change which you pick up on MRCP, but a multitude of factors which determine chronic pancreatitis. So you have genetic, environmental, and the risk factors. This leads to parenchymal injury or stress. This leads to inflammation, and it undergoes resolution, regeneration, and this can lead to fibrosis and the development of chronic pancreatitis. So what happens is early chronic pancreatitis is a part and the initial occurrence in the initial development of chronic pancreatitis. So this is what it looks like. So normal pancreas, you develop an episode of acute pancreatitis, then you have recurrent acute pancreatitis. Then this is the potentially reversible. So that's the reason we are trying to look at early chronic pancreatitis and giving criteria to make a diagnosis, which again is not easy. And then early chronic pancreatitis, if you don't check at this particular point, the disease becomes irreversible, and you have the established chronic pancreatitis, which is again irreversible, and you just manage either the pain or the endocrine and exocrine insufficiency associated with chronic pancreatitis. So then this Japanese criteria, again, as I mentioned, it's a bit complicated. However, at the international level, this is not uniformly believed by everyone. So this is again an international consensus statement on early chronic pancreatitis, which was published in 2018. Though the Japanese society was a part of it, but you see the difference in the diagnosis and what they have to say about ECP. So no consensus statement could be developed for definition of ECP or any diagnostic criteria. So what does that mean? So that means for ECP, the international consensus does not propose any diagnostic criteria, or they could not reach to a definition of early chronic pancreatitis. And however, they had consensus on 5 statements related to early chronic pancreatitis. And what are these? The word early in early chronic pancreatitis is used to describe disease state, not the disease duration. The ECP defines a stage of chronic pancreatitis with preserved pancreatic function and potentially reversible features. Genetic variants are important risk factors of an ECP and can add specifically to the likely etiology, but they are neither necessary nor sufficient to make a diagnosis. Again, the environmental risk factors provide evidence to support the diagnosis of early CP, but they are neither necessary nor sufficient to make a diagnosis. And the differential diagnosis of ECP includes other disorders with morphological and functional features that overlap with chronic pancreatitis. So the reason I'm spending a lot of time in the definition of ECP is that as of now in 2026, we don't have a very clear-cut definition of what ECP means. And importantly, in this, they stated that the diagnosis of ECP cannot be made on imaging. This is what the International Consensus 2018 mentioned. So if we talk of the diagnostic tools, so you can understand the literature that we have related to these is again very weak. We definitely need a lot of studies in this particular area to reach to a consensus and the modalities that will make a diagnosis. So as of now, the imaging modalities that we have include MRI, MRCP, secretin enhanced MRCP, EUS, which is again one of the very important imaging that we have, elastography, and then we have biomarkers. A lot of biomarkers have come up. I will be touching upon that, not going into detail, just listing the biomarkers that we have as of now. Genetic mutations that we need to pick up, PRSS1, SPINK1, CFTR, CTRC. And again, the therapy is, we are not discussing this, but these are the reasons why we need to pick up early, because there are certain interventions which can be done to prevent the progression of early chronic pancreatitis. So the imaging diagnosis of ECP is challenging, as I mentioned. It's situated at the borderline between acute inflammatory episodes and established pancreatic fibrosis. It requires imaging tools sensitive enough to detect subtle early stage changes before the irreversible damage happens. So first is endoscopic ultrasound. As I mentioned, this is a very, very important tool, and it really picks up a certain proportion of these patients to make a diagnosis. So what do we need to look at in EUS? We need to look at hyperechoic foci, hyperechoic strands, lobularity with honeycombing, lobularity without honeycombing. So lobularity without honeycombing, I'll touch upon how it looks like. And then the presence of cyst. This cyst should be greater than 2 millimeter. Dilated side branches, presence of greater than 3 tubular anechoic structures rising from the MPD, each more than 1 millimeter in width. So these are the dimensions that need to be picked up on EUS, or if you're trying to make the diagnosis on MRCP. Hyperechoic duct margin, echogenic structure involving at least 50% of the MPD. So these again correlate with histopathological attributes. Lobularity correlates with interlobular fibrosis, and hyperechoic foci with focal fibrosis, hyperechoic stranding with bridging fibrosis. Cyst, again with pseudocyst or retention cyst, dilated duct branches with periductal fibrosis or thickened duct wall. So you can see just a spot here, these are hyperechoic foci. When you have longitudinal, more than 3, this is the hyperechoic strands, what looks like on EUS. And again, this initially they proposed 2 out of the 7 parameters that I had showed you, the 5 parenchymal and the 2 ductal features. However, subsequently they defined lobularity with and without honeycombing together. So what is honeycombing? So once you have a lobule like this, hyperechoic line which surrounds the hypoechoic area, and once you have at least 3 of these situated close together, this is known as lobularity with honeycombing. So this is one of the important parameters to make a diagnosis of early chronic pancreatitis. And in majority of these, you will not pick up anything on other imagings like CT scan or MRCP. There still is a problem. So if you see this study, there are around 260 patients where they did US examination, abdominal or back pain alone, 54 patients. Out of these, 46 patients were diagnosed to be having ECP. However, ECP they further divided into being definite, probable, and possible, and those negative. So if you see this, the definite CP was only in around 15% of these patients. When they took only abnormal pancreatic enzyme elevation, only 3.3% could be found to have ECP on EUS, and out of these, the definite diagnosis was made in none, while the probable diagnosis in 1.6%. So this just tells you that even EUS does not ensure that you are making a definite diagnosis of early chronic pancreatitis, which correlates with histology. So the correlation with histology, again, this is an old study, and the reason I'm putting it is because one of the important study here. So here, certain US findings were found to correlate with histology among histologically proven cases of non-calcific chronic pancreatitis. The foci correlated strongly with the presence of the foci and strands correlated strongly with the presence of diagnosis. Hyperechoic MPD wall, the irregularity of MPD, and the dilated side branches also correlated significantly. So the study had showed a high likelihood of CP when diagnosed by US based on ductal features compared to parenchymal features. Having said that, there are certain other studies which say that US may not always correlate with histology. So this is again a study by Sakin et al. This is 2021, published in Pancreas. They found that lobularity correlated significantly. However, the hyperechoic ductal margin did not reach a statistical significance to make a diagnosis of early chronic pancreatitis. So this is what is important, is there is a heterogeneity in the outcomes of the studies that we have for this particular entity of early chronic pancreatitis. So B mode EUS, although sensitive to chronic pancreatitis, is shown to have a significant inter-observer variability in studies, and that's the reason why elastography is important. So what is elastography? Elastography just tells you how hard the tissue is, and that's what is detected by this imaging modality. So if you see this, if it's hard tissue, it's blue, while a soft tissue is usually orange or red here. So again, you can have the the strain ratio, the quantitative elastography is a strain ratio, and it tells you how, again, hard the tissue is. Normal pancreas, you can have 3.7, chronic pancreatitis 8.2. So in ECP, you will have a value somewhere between the normal and pancreas and the chronic pancreatitis. So again, the shear wave elastography is again where you are measuring the velocity of the wave, the shear wave that you have produced. And here again, this is now considered to be one of the very reliable imaging modality to make a diagnosis of early chronic pancreatitis, as shown in this published study published recently. 22 patients, you have this is ECP, early chronic pancreatitis 34, normal group 53, finally 22 in each group. And here importantly, the ECP was diagnosed using, again, the Japanese diagnostic criteria. Pancreatic stiffness was assessed based on the velocity of EUS shear wave elastography, and a practical shear wave values of more than 50% was considered significant. So here again, you see the VS cutoff value for the diagnostic accuracy of ECP was determined to be 2.24 here with an ROC of 82.82, and there is a strong correlation between the EUS shear wave elastography finding and the Japanese diagnostic criteria of 2019 for ECP. So this is only one of the few studies that are available to talk specifically of early chronic pancreatitis. We don't have many studies on this. What about EUS, FNA, FNB? Obviously, you don't want to establish a diagnosis of early chronic pancreatitis based on histology in each and every patient, it being an invasive one. So we have only limited reasons to do a biopsy, especially when you have a suspicion of underlying malignancy because of some reason. Otherwise, this is usually not done. Again, in guidelines such as those from Japan and Europe, emphasis has only been placed on EUS for the diagnosis of chronic pancreatitis and early chronic pancreatitis, and no mention of EUS, FNA, and FNB. So if you talk of CT again, in general for CP has got a sensitivity and specificity of 75 and 91%. The changes that you can pick up on CT to determine a diagnosis of ECP includes a dilated MPD, pseudocyst, dilated side branch, mild pancreaticomegaly, are changes that have been described in studies in early chronic pancreatitis. MRI, again, more sensitive than CT scan, and here you can have features like dilatation, strictures, and pathological side branches being picked up better. Secretin MRCP is the one which possibly fares far better than CT scan and may have a role somewhere comparable to EUS. So here you can have an MPD dilatation pseudocyst of 1 centimeters, irregular MPD with dilated side branches. So just a word about inflammatory markers. So you have inflammation, you have fibrosis, you have oxidative stress in patients with chronic pancreatitis. So this is all the inflammatory markers which are there, and this is the list of inflammatory markers that are there as of now. However, none of these have been proven to make a diagnosis of early chronic pancreatitis. Again, you can have fibrotic markers, and this is the mechanism how fibrosis comes into picture. And these are the fibrotic markers which are there. Again, I have just enumerated. None, again, is at this point of time able to make a definite diagnosis. And these are the oxidative stress associated with CP, and these are the oxidative markers that have been delineated. So to conclude, establishing consensus definition and above all diagnostic criteria for diagnosis of early CP is an essential requirement, still not fulfilled. There is still no diagnostic method in clinical practice that can establish the diagnosis of the early form of chronic pancreatitis with adequate accuracy and reproducibility. And the diagnosis is, to some extent, a jigsaw of individual test results. That is, you need to take multiple factors into account to make a diagnosis of early chronic pancreatitis. Thank you.
So thank you, Dr. Rai, for excellent speech. One question, Dr. Rai, one question, US guided elastography. US elastography, does it really meaningful? I mean, pancreatic fibrosis may occur in several other conditions. Yeah. So can you highlight?
Yeah, so I think I mentioned in that's a limitation. So what you mentioned is you can have pancreatic fibrosis just because of old age, or because of many other conditions.
CKD,
yeah. CKD in chronic kidney disease. So that's again is a problem. So I think the message here is none of the diagnostic modality in isolation will give you a definite diagnosis. So you need to have a multitude, as mentioned, the Japanese guidelines, though a bit complicated, but that's how one should be making a diagnosis, because you need to have all the clinical parameters, some imaging parameters, some biochemical parameters to make a diagnosis of chronic pancreatitis.
Can I ask something? Praveen, excellent talk, as usual. But you are shifting your gear from the, I think, the intervention to the much earlier side. See, then you want to tell us that this is early chronic pancreatitis, then you have a compensated chronic pancreatitis, and then you have a decompensated chronic pancreatitis. If we want to make it. But possibly it will be difficult. In liver, we are already in trouble to say what is early, how early we can pick up in F1 and F2 and F3. And you have really shown that US elastography will be not that easy in pancreas as compared to liver. We have small space, and your specificity sensitivity may not be whatever we are getting in liver. We will not get it in pancreas, probably also with different machines. And your, as well as intuition has changed to contrast US to get the other lesions rather than concentrating on US elastography. If we go back to 2012, the initial data started coming. So what will be your tech? It's really difficult. Still now we don't have very good markers. How do you pick up on early chronic pancreatitis? Fecal elastase is too late, or you have something more coming?
Yeah, sure. I think the whole message is at this point of time, I think it's a bit difficult to make a definite diagnosis for sure based on just one imaging. And what we are trying to do is, the reason why we are trying to make a diagnosis is to pick up these cases early so that we can possibly do something, alter the natural history of the disease. That's what we are trying to do. Unfortunately, at this stage, we don't have very good modalities, but the promising modality is one, I would say, a shear wave elastography. That is one which possibly, after reviewing the literature, looks great, has definitely promise, but we need further studies in that.
Thank you. Praveer, great, good thought on this. What I wanted to know is there today any gold standard in early chronic pancreatitis? Second, and how do you distinguish this early chronic pancreatitis from established chronic pancreatitis? Is there any marker or there is any, when you say it is early chronic pancreatitis and when it is standard pancreatitis?
So I think the gold standard obviously in all these is biopsy. Once you have a biopsy which definitely shows the convincing changes which I have enumerated too. But however, again, once you have a calcification, dilated duct, you don't need a biopsy to prove that. You already have a diagnosis in place. So the diagnosis early, if you are trying to make a definite diagnosis of early CP, you compare it with gold standard, which should be a biopsy. So it's only biopsy which can tell you confirmatively that this is a patient with chronic pancreatitis.
So thank you, sir. Thank you for time constraint. We are concluding the session. Thank you from all of us.
Thank you. Thank you.
Thank you, sir. May I request speaker, sir, and chairpersons to please move forward to the felicitation area. Now we proceed to our next academic session. So to chair this session, may I request Dr. Pradeep Bhaumik, sir, Dr. Sujoy Rai, sir, Dr. Upajyoti Talukdar, sir, Dr. Orko Banerjee, sir, and Dr. Prashant Devnath, sir, to please come on stage. The session will be on ESWN in chronic calcific pancreatitis. So requesting the chairperson, sir, to please start the session by introducing our speaker.
Afternoon. Okay, so I think Dr. Manu Tandon doesn't need any introduction, but for the younger people who are in the room, so I think he has the maximum experience with ESWL with more than 15,000 plus patients which he is following over the last several years. And I think there could be no better person than him in the world to speak to us on ESWL in chronic pancreatitis. Sir, it's all yours.
Thank you, Roop. Thank you, Sanjay. It's a pleasure to come back again to the Kolkata Pancreatic Club, the entire organizing team. But Sanjay is the one who's been regularly contacting me. Well, the topic is very obvious. ESWL in stones and chronic pancreatitis is still relevant today. First, let me tell you, this is not a debate. And then I'll tell you why did this come. Because some time back, Roop is here, all of us participated, AIG, it was a multinational study. There was this study where there was a slight confusion, but the actual conclusion from the same study is that in patients with CP and intraductal stones, ESWL and followed by ERCP, provided short-term relief. Short because the follow-up was for a short time. So this was the this was the article that gave us that doubt, but I'm going to clarify the same today that ESWL still remains the gold standard. And for that, a brief introduction, why we need to remove stones and why ESWL is still the best technique. Now, all of us know that pain is the most dominant symptom in CP, and most of the patients, 80% present with pain, 90% will eventually have it. And all therapies, whether it is pharmacosurgery or endotherapy, it's purely directed at relieving pain because there is no cure for pancreatitis. And pain, Roop has written a very good article, many factors, and I'm not going to go into the details, only going to concentrate on ductal hypertension, which eventually leads to parenchymal hypertension. And Roop, as I told you, wrote a very nice article some time back on the various mechanisms of pain in chronic pancreatitis. Now, what are the clinical situations where you can get pain? You will get pain with ductal obstruction, what is called as ductal hypertension. Mahesh and all of us raised the topic sometime during the course of the day. Sometimes you will get pain even after you decompress the duct. It could be endoscopically, it could be post-surgery, but the duct is clear, the duct is dilated, no obstruction, the pain persists. And finally, you have the third scenario where you have a minimal duct disease, the toughest to treat, I feel, with severe pancreatic pain. So these are the three clinical situations where you come across. So we will concentrate on ductal hypertension because stones come in this scenario. 60 to 70% of pancreatic pain is because of ductal hypertension. It could be a result of strictures or calculi or both. In two of our very large studies, in one we had 18% coincident structure and stones, in one we had 22. So roughly about 20% you have both strictures and stones in the same patient, leading to ductal hypertension. And these are examples of some of the stones that we come across in our Indian population, a majority of who are non-alcoholic, so it's the idiopathic pancreatitis. The one on the extreme left, riding in the head up to the genu, the one going, second one going beyond the genu, the third one extensive and parenchymal and secondary branches. So you have stones everywhere in the pancreas. Here again, parenchymal, secondary branches, main duct. Now, why are these stones so difficult to remove, the ones which produce this ductal hypertension? Stones larger than 5, like biliary stones more than 15 are considered difficult. Anything more than 5 is considered difficult for the simple reason that the stones are very dense, they are spiculated and they are adhered to the ductal epithelium, making their extraction difficult. Two other factors, the diameter of the PD is nowhere near like the CBD, and the PD, as you know, is tortuous. So this combination makes passage of all the accessories that we normally have for the CBD, the same accessories are used, very difficult, and that is why extraction is difficult. So, coming to what are the options that we have. For small stones, ERCP and extraction. For the larger stones, I've put shockwave lithotripsy as the first option. In India, we almost always follow it up with an ERCP, where there are some studies from Europe which say that if you pulverize the stone well, you don't need a follow-up ERCP. What about mechanical lithotripsy? And then finally, spice scope. The new kid on the block with pancreatic spice scope, I'm talking, with intraductal lithotripsy, either electrohydraulic or laser. So let's talk about the others, see their limitations, and then concentrate on why ESW is relevant and, as I told you, remains the gold standard. Now, mechanical lithotripsy is challenging for the simple reason that the duct is small and tortuous, very difficult to pass. We had two very large studies, more than 1,000 patients. You see the response rate, 9% and 14%. And see the complications, 700 patients had complications thrice as high as bile duct. So you have a combination of poor response and really unacceptable high side effects. And that is why it is not advised for the extraction of pancreatic calculi. We do not use mechanical therapy with the standard basket for the same. What are the other options? You blast the stones. Blast it extracorporeally or use a pancreatoscope, either EHL, as I told you, electrohydraulic, which is a bipolar device, or a laser. We have different types of laser and not going into the details. First, let me talk about pancreatoscopy with the two types of lithotripsy. Small studies in the last 10 years have shown, these are meta-analysis with 300 patients. You see the fragmentation is roughly about 85%, but more important, 14% adverse effects and a very high rate of pancreatitis. Secondly, what is not mentioned is these studies, a high level of expertise. Please, if you have a pancreatoscope or what is now known as the spice scope is commonly used, we have got different varieties now. Don't make an attempt unless you are really backed up by a good team, because pancreatitis is very common. Similarly, another review, again 16 studies, 380 patients, they showed similar results with both of them, high list of adverse effects and pancreatitis being the commonest. And finally, this study which came late. 35 patients they tried, in 5 they could not reach the stone, for which I am going to come next. Partial clearance was seen in 5 and complete clearance was seen in 20. If you see the entire number, 20 out of 35, a little more than 50%. So why is it difficult? Because I told you the ducts are narrow and tortuous. Sometimes you have tight MPD strictures. The diameter of the Boston scope that we use is 10 French and you may not be able to pass it. Sometimes you have loops, you have an altered anatomy, and stones which are very deep in the PD, it may be difficult to reach them using the pancreatoscope. The other thing is that the stones are very close to the ampullary opening. You need a length of at least 1 centimeter, at least 1 centimeter. We have got champions of endoscopy. I'll ask, Nagi, how much do you think we'll need to stabilize the scope? At least 1. Yes, maybe more. For a person like me who's not half as good, I'd probably need a little more. So, very difficult if the stone is either very far or very close. And then this is, of course, a specialized instrument with high technical skill. So we come back to ESWL. We have seen what are the existing devices, their limitations, and now I am going to show to you why ESWL still is relevant. This is the calculi that I showed you in my index slide. As I told you, most of the patients are adults and young adults with non-alcoholic. The important thing which Roop told in that article is that you select the patient properly. And whom do you select? Patients with painful stones, preferably in the proximal half of the duct. With the new devices, the new ESWL machines, the 3rd, 4th generation, we can even target distal stones, but by and large, classical teaching is proximal. And what do you aim at? Pain must be present. No point in removing a stone which is not producing pain. To fragment it to 3 millimeters or less, or decrease the home density so that you can extract it at a subsequent ERCP. And some classical examples from our studies. Large stone, totally fragmented, put in a stent. You see the duct itself has disappeared. Become smaller, not disappeared, become smaller in size soon as the stone was removed. The same here, big stone this is in the dorsal duct, removed, put in a stent. Sometimes you have radiolucent calculi. Those were opaque calculi and we used image intensifier. For radiolucent calculi, which you cannot remove by the standard technique of ERCP, we put in a nasopancreatic tube. There you can see in the figure on the right, the arrow is showing the radiolucent calculi. With the help of the nasopancreatic tube and a dye, we localize the stone, blast it, and in the last film on the bottom, you see that stone has disappeared after ESWL. What does all this do? This is painful fellow who has come to you with severe pain and a large stone. You saw one of the students present a video also on the same today. So we did a study and found a decrease in the pain score, decrease in analgesic use, decrease in hospitalization, leading to increased appetite and weight, and that is how quality of life improves. And in our own experience, more than 5, now we have more than 11 or 12,000 cases of pancreatic lithotripsy with excellent results, 72 to 73 complete clearance and 17 partial clearance. Short-term pain relief, I'll come to the long-term ones very shortly. We compared it with other large studies at that time when this article was published. Results from 50 to 80% in the few centers. Europe does a lot of it. America, probably ESWL and epidural anesthesia are not yet very popular. I think it's not FDA approved yet. But I told you it's a disease of the young. What do you do for long-term follow-up? So we had this study where we followed up to 8 years and 60% of the stone patients were doing well. They were doing very well in all aspects. And we had follow-up of 120 of them for 17 years. Well, with Nilay's permission, I'm going to use his name here. We have one doctor here who's now a faculty. He came to us 17 years back, Nilay, if he's there. 17, yes, Nilay is there. 17 years back, we did his ESWL. Till today, he has not come back again to me. He gets his test done here once a year for CA99 and ultrasound because, you know, chronic pancreatitis has some issues later on. But that shows that patient 17 years and going strong. He's 16 years. We have got studies close to 20 years now. Similar studies from Europe. The first one is from America. The second one, America means USA, and the second one is from Europe. Smaller number, but the results are similar. Long-term pain relief. Then you would ask, is this a dangerous problem? Does this produce a lot of adverse effect? The answer is no. Our own 5,900 patient, the biggest or the most worrisome side effect was pain at the site where the shocks were applied and some ecchymosis. Pancreatitis was just 3.5, mind you, they are chronic cases. And severe pancreatitis, less than 1%. Similar results from two large studies from Europe and Asia. Overall, less than 6% results. Only one of them had non-related mortality, but since it's over the study period, it's considered as a mortality due to the procedure. ESWL is not everything. There are many limitations. Inability to fragment sometimes. We are not going into the solutions. Stones can come back to us. We have really no effect on exocrine endocrine function. Again, Roop did a study where he said that early intervention in CP may delay diabetes. So probably we can modify the course of the disease. The role, whether it can help in preventing malignancy, not clear. So there are limitations, and sometimes you have unusual side effects. These are one for case reports and we rarely see it. Steenstrasse. Steenstrasse is a German word. Steen is stone and Strasse is road. Sometimes after fragmentation, the stones block the entire road and you need an urgent ERCP because that's a very painful condition. This is very rare, 6%, but all these complications that I have listed are not common, and if you have accurate targeting and a well-sedated patient who's not moving, you will prevent collateral damage. So concluding, ESW is an excellent modality for large PD calculi, both short and long-term pain relief. And as I told you, quoting Roop's study, that we may probably modify the course of the study. What does the rest of the world think? The best guidelines of this come from the European Society. They had identical guidelines 10 years, almost 8 years apart. And this is what they say for treating patients with uncomplicated, see the word, painful chronic pancreatitis. I need just a minute. With stones which are more than 5 mm, ESWL is the first step in treatment. And what do they say for the pancreatoscopy and lithotripsy? ESWL guidelines suggest that it should only be attempted if you have done adequately performed ESWL and failed to fragment the stone, because they show that the studies, evidence is from small studies and a very discordant rate of fragmentation, anything from 40 to 80%. So that is why if the first three clinical scenarios, in ductal obstruction, endotherapy, and if there are stones, ESWL remains the ideal choice. And of course, you have surgery to back up the 10-12% who don't help at all. So as we concluded in one of our recent articles, it not only is a relevant option, I think it still is the standard of care in the management of stones, large pancreatic duct stones in chronic pancreatitis. Thank you. Jahangir has invited you, and I invite you all once more in December for a real exhibition of live endoscopy. The top masters, international and Indian, will be there. We look forward, we welcome you and look forward to your presence at Hyderabad in December. Thank you.
Excellently summarized, sir. Sir, as ESWL is not available in maximum centers, and as you know, CP is very common across India. So, with the evolution of pancreatoscopy, we are being using it more commonly as we are using it for biliary stones as well. So, do you have any criteria to suggest that these patients should be directly sent for a ESWL rather than doing a pancreatoscopy? Because many a times we feel this difficulty, presence of a stricture or something, when you're not able to.
In our place, there is no criteria for pancreatoscopy. Pancreatoscopy is only taken up if ESWL doesn't give us the result. Otherwise, we first option standard ERCP and removal if you can. If you not and the stone is big or blocking or impacted or whatever the reason, straight away to ESWL. We think of the third option, that is only beyond a well-performed ESWL and no success. And when do you call it unsuccessful? When 4 times we have blasted and the stone has not made a dent, that we say that the ESWL has failed, and it happens in 8 to 10%.
Yeah, I think.
Yeah, Roop.
Yeah, I agree. So I think if there are no more questions and running a little short of time, I think we should close the session here. Thank you very much.
Thank you.
Thank you, sir. May I request Speaker, sir, and chairpersons to please proceed to the felicitation area for the felicitation, and we will be starting the inauguration ceremony shortly. So we are about to start our inaugural ceremony. So firstly, may I request Dr. Ashokanando Konar, sir, Chairman, Kolkata Pancreas Club, to please come on the dais, sir. Then may I request Professor Dr. Partho Sarkar, sir, Professor, Department of Medicine, KPC Medical College, and Chairman, Association of Physicians of India, West Bengal Chapter, to please come, sir, on the dais. May I request Professor Jyotirmoy Pal, sir, immediate former President, Association of Physicians of India, and Professor of Medicine, Sagar Datta Medical College and Hospital, to please come on the dais, sir. May I request Dr. D. Nageshwar Reddy, sir, he needs no introduction. He is the Chairman of AIG Hyderabad, to please come on the dais, sir. Then may I request Dr. Mahesh Kumar Goenka, sir, Director and Head, Institute of Gastrosciences and Liver Transplant, Apollo Multi-Speciality Hospital, Kolkata, to please come on the dais, sir. Now, may I finally request Dr. Sanjoy Banerjee, sir, Secretary, Kolkata Pancreas Club, to please come on the dais, sir. Now it's time for felicitation of our esteemed dignitaries. May I request Dr. Mary D. Cruz, madam, to please felicitate Dr. Ashokanando Konar, sir, Chairman, Kolkata Pancreas Club. May I now request Dr. Mary D. Cruz, madam, to please felicitate Dr. D. Nageshwar Reddy, sir, Chairman, AIG Hyderabad. Now may I request madam to felicitate Dr. Mahesh Kumar Goenka, sir. Now I request to felicitate Professor Partho Sarkar, sir. Now I request madam to felicitate Professor Dr. Jyotirmoy Pal, sir. Finally, may I request Madam to felicitate our Secretary of Kolkata Pancreas Club, Dr. Sanjay Banerjee, sir. Now, may I request Professor Jyotirmoy Pal, sir, to kindly felicitate with a token of gift to Dr. D. Nageshwar Reddy, sir. Now, may I request Professor Jyotirmoy Pal, sir, to kindly felicitate Dr. Mahesh Kumar Goenka, sir. Thank you, sir. Now, may I request Chairman API, Professor Dr. Partho Sarkar, sir, to give his introductory speech.
Respected dignitaries on the dais, Dr. D. Nageshwar Reddy, Dr. Mahesh Kumar Goenka, Dr. Ashokananda Konar, our immediate past president, Dr. Jyotirmoy Pal, and our secretary of the Kolkata Pancreas Club, Dr. Sanjay Banerjee. I, on behalf of West Bengal chapter of API, also on behalf of Pancreatic Club, welcome all the esteemed faculties and delegates who have assembled here for this prestigious 4th annual program of the Kolkata Pancreas Club. And like every conference, this conference, I think, will enrich our knowledge with the experience and wisdom of the senior faculties from abroad and from this city. We will be much enriched when we leave this venue at the end of the program. So I welcome you all over here. Enjoy the day and just leave the podium at the end of the day, enjoying the program, enjoy the culinary delights of today's, and also go with a fond memories of this program. Thank you very much.
Thank you, sir. Now, may I request Dr. Mahesh Kumar Goenka, sir, our patron and chief scientific advisor, to kindly share his valuable insights.
My dear friend Nageshwar Reddy, colleagues on the dais and in the hall, I think this program is gradually becoming a very uniform program, and the topics which are chosen, the faculty who are here for this program is really enriching this activity very much, and I'm very happy to be a part of this. If the credit has to go to one person for this organizing this program, is Dr. Sanjay Banerjee. He has really worked very, very hard from A to Z. We have been just a support system for him, and I'm very happy to see that the program is evolving over a period of years. Thank you very much.
Now, may I request all the dignitaries on dais to please come forward for the lamp lighting.
देवैः सदा वन्दिता
Thank you. Now, may I request Dr. D. Nageshwar Reddy sir to please share his valuable insights and give his inaugural speech.
Thank you, guests on the dais and friends. This is a very happy occasion to see the 4th Kolkata Pancreas Club meeting going on. In fact, several years back when this was the first one was coming, Sanjay had told me that he and Ashok Anand were thinking whether we should start a pancreas club in Calcutta. So at that time I was wondering why another pancreas club, because even the All India Pancreas Club didn't seem to have so much attendance and enthusiasm in that, whether this will work out. But looking at what happened over the last 4 years, I think this has been a grand success. I think mainly due to the leadership, I think Sanjay is providing along with Ashok Anand and Mahesh. One of the unique things about this club is I see a great unity among all the gastroenterologists and physicians in Calcutta coming together. This is not very common in many cities. All of them come together for this particular meet. And then I think the meeting also run in a very nice way. The pancreas is a very paradoxical organ. It's retroperitoneal, it's very silent. Most people, including the lay public, know very little about it. Unless an acute attack of pancreatitis comes, kills somebody, or pancreatic cancer manifests. But in spite of all this low background, there's been dramatic change in recent years in the science of pancreas. For example, I think all of you must have heard of news of pancreatic cancer, new drug coming in. When a drug which just prolongs pancreatic cancer by 6 months came into a lay public in recent months, every single channel in the world, CNN, BBC, all Indian, everybody carried headlines on that. So that shows the importance what pancreas carries, at least in terms of malignancies which are difficult to detect. One of the few last malignancies which has very high mortality and morbidity. And also, of course, acute pancreatitis now with machine learning, our ability to predict very early which patients are likely to go into acute pancreatitis, we can in fact now prevent this from going on, and we have starting to get new types of drugs which can change the pathway of how this goes on. I think chronic pancreatitis, we just heard Manu talking on extracorporeal, new therapies are coming. In fact, a very new drug that Dr. Whitcomb is working on is actually going to prevent recurrent acute pancreatitis, which is the commonest precursor of chronic pancreatitis, from progressing. So it stops that progress. This is again, a lot of new drugs, new pathways, new discoveries are happening in the field of pancreas. And as we come here every year, gather, listen to each other, discuss, I think all of us are learning new things. It's a very productive meeting, and I'm sure that it will go on for a very, very long time. And I wish the organizers all the luck in this, and I'm extremely grateful that I've been a part of this from the beginning. Thank you very much.
Thank you, sir. Now, may I request all the esteemed dignitaries on the dais to please hand over the check to Kashundia Alo Welfare Organization.
So I am grateful to all the speakers, dignitaries, the stalwarts and legends in the field for coming here for this academic, and we've all been enjoying this academic program. But the responsibility does not stop here. We have a Kashundia Alo Welfare Organization, with whom I am associated for a long time. Our team, Kolkata Gastrocare, is associated a long time, and they are doing a lot of social service, particularly relief and clothing distribution, relief work during Cyclone Amphan in COVID-19 pandemics, and they are also providing clothes to street children or women living in the red light areas. They're distributing winter garments to tribal communities in Bolpur, and they are running a school for the street children called Shikhar Alo, the light of knowledge. Their core objective is to stand beside the underprivileged, remove the darkness of deprivation from society, spread the light of education, humanity and compassion. And I am glad, I am privileged to be part of this, and I would request all my dignitaries, all my teachers to give a small token of 1 lakh rupees from our previous year's surplus amount of conference to this organization. I would request the secretary of the organization to come to the dais and take this check of 1 lakh rupees from our teachers.
Let's give a big hand to them.
Thank you, sir. So we close the inaugural. So we now proceed to our next scientific session. So thank you, esteemed dignitaries. So we proceed to our next scientific session, which is on understanding pancreatic exocrine insufficiency and its treatment. To chair this session, may I request Dr. S.P. Desarkar sir, Dr. Girish Pati, Dr. Prashant Parida sir, and Dr. Abhishek Banerjee sir to please come on the stage and start the session by as esteemed panelist. And to moderate this session, may I request Dr. Shamir Mohindra sir, who needs no introduction, he is well known to the field, to please come on the stage, sir, and start the session by moderating with our esteemed panelists. So over to Dr. Shamir Mohindra sir.
Thank you, Samir sir.
Can you hear me? Yeah. Dr. Goenka, Dr. Sanjay for the kind invite. Now we are going to have a panel discussion on a very important entity related to pancreas, that is pancreatic enzyme insufficiency, which is important because of many reasons. Number one, it's a common clinical problem. It is treatable. It is associated with significant mortality and even mortality. And we have a treatment which can improve the condition of this patient. But more importantly, the treatment is expensive and the indications of treatment has to be very clear before we start this therapy. Why I put this graph is the number of publications in Index Journal has almost tripled in last 20 years on pancreatic enzyme insufficiency. It shows the relevance of this entity. If we look at the basic concept of what is pancreatic enzyme insufficiency, we need to understand three terms. Malnutrition. Malnutrition means poor nutrition because of decreased intake, impaired digestion and assimilation. Maldigestion means incomplete breakdown of luminal contents, and pancreatic diseases and diseases related to the bile salt deficiencies are maldigestion. So what we are meaning by pancreatic insufficiency is it's a maldigestive disorder. That's very important to understand. There are three phases of secretion of pancreatic enzymes which are controlled by hormones and vagal nerves. So we have to understand these three phases because they play a very important role in the pathophysiology. Now, how do we define PEI? Dr. Girish, can you throw some light?
So,
as of today, how do we define pancreatic enzyme insufficiency?
Yeah, we define the pancreatic exocrine insufficiency as it is insufficient pancreatic enzyme. Either it could be secretion or there is increased destruction of the pancreatic enzymes within the lumen. Yeah. So in that way, the digestion process will not up to the esteem, and there it can be manifested with this malabsorption, nutrient deficient, other parameters.
So traditionally, we have thought that pancreatic enzyme insufficiency is related to pancreatic disorders. So therefore, we had been concentrating on chronic pancreatitis, cystic fibrosis, pancreatic ductal carcinoma, or post-pancreatic surgery. But pancreatic insufficiency basically means either there can be a decreased secretion and or intraluminal concentration of pancreatic enzymes insufficient or below the threshold to maintain the normal nutritional status of that person. So that is very important, and which to translate into clinically relevant maldigestion, which shows in the form of deficiencies. So it's very important to understand that. Dr. Prashant, how do we assess PEI? We think that person has got PEI. How do we assess that whether patient has got PEI or not?
Actually, there is four stages there for PEI. Pancreatic enzyme insufficiency. One in stage 1, stage 1 and stage 2, there is no symptoms usually absent, and the nutritional deficiency is mainly absent in stage 1 and stage 2. But in stage 3 and stage 4, there is the presence of symptoms and if the symptoms along with the presence of nutritional deficiency, that is stage 4 and advanced stage.
Yeah. Basically, why I wanted to show this slide is that when we assess PEI, we need to look at symptoms, we have to look at nutritional deficiencies, we need to look at pancreatic function test, which can be either enzyme secretion assessment or digestive activity of the pancreatic enzymes. For example, fecal elastase looks at the enzyme, while CFA looks at the digestive capacity of pancreatic enzymes. So one is direct, one is indirect. And depending upon what we get, we try to state that how severe is pancreatic enzyme insufficiency. So why is it important to diagnose PEI? I mean, does it increase morbidity? Does it increase mortality? Does it affect quality of life?
Absolutely. It's very important to diagnose PEI because it is related to protein and fat malabsorption, multiple nutritional deficiencies, sarcopenia, weight loss, osteopathy, and ultimately increased morbidity and mortality. So in various studies, it has shown that up to 65% patients with pancreatic exocrine insufficiency suffer from various forms of osteopathy, either in the form of osteopenia or osteoporosis. Osteoporosis is in fact prevalent in up to 24% of the patients, and around 17% of the patient are suffering from sarcopenia, and sarcopenia is an independent factor that is associated with increased morbidity and mortality. And various studies have shown that presence of pancreatic exocrine insufficiency is an independent risk factor for mortality in chronic pancreatitis.
Yeah, increased osteopathy, increased incidence of sarcopenia, increased hospitalization, prolonged hospitalization, increasing cost, poorer quality of life. So there are multiple factors which prognosticate these patients with pancreatic disease who have got PEI. So it's a very important aspect of diagnosis that we need to be sure that whether we have picked up PEI early or not. Dr. Girish, what are the common causes of PEI?
Yeah, relatively common causes are usually if it is recurrent acute pancreatic necrotizing, pancreatic chronic pancreatitis, pancreatic cancer, and even if type 2 diabetes mellitus if it is prolonged untreated, and other causes like if there is any operation post bypass, pancreatobiliary, post Sewell syndrome. So all these are few causes which can lead to this pancreatic insufficiency.
See, basically, basic pathophysiology is either the pancreatic parenchyma is reduced, number 2, there is ductal obstruction, number 3, there is decreased stimulation, which can be neural or hormonal, and number 4 is there is no synchronization between the passage of chyme into duodenum with the release of enzymes. So these are the 4 basic pathophysiological mechanisms because of which PEI happens. Now, depending upon that, we can have different causes as mentioned. If there is atrophy, then you can have chronic pancreatitis, you can have pancreatic ductal adenocarcinoma, post-surgery, recurrent acute pancreatitis where the parenchyma gets reduced. Then if there is an inhibition of the secretion because of various reasons, for example, if there is a ductal obstruction, the juice is not coming, then there are various drugs, then the enzymes which are coming in the lumen, they are getting destroyed, for example, Zollinger-Ellison syndrome. And post-Sewell dystrophy, which is most commonly seen in upper GI surgery, where the synchronization between the passage of partially digested food and secretion of pancreatic enzymes is reduced. So there are multiple mechanisms through which PEI can happen. It's not only restricted to pancreatic diseases. So that's what I wanted to highlight. How common is,
As the only surgeon in the panel, I also want to know.
Sir, I have a question for you for this.
See, that CCK is also a very important point post-surgery. You take out stomach, you take out duodenum, also the big part of pancreas exocrine. So many ways are there.
Absolutely. So, how common is PEI? See, it can be common, it can be very common, or it is rare. Now, we need to identify those high-risk situations where we should have a low threshold of suspecting PEI. See, symptoms are non-specific, signs are non-specific, tests are to a certain extent not very sensitive and specific. So we need to have situations identification which are high-risk situations. So this slide basically shows which are the high-risk situations. For example, chronic pancreatitis, 40 to 50%. But if you have extensive calcification, this percentage rises to 80%. Acute pancreatitis, there was a discussion in the talk. Approximately 2/3 patients of acute pancreatitis may have transient pancreatic insufficiency, which may persist for more than, at 1 year, more than 30%. So it may be transient in 50%, but can continue beyond 1 year because of the extensive necrosis, inflammation, fibrosis, which has happened during acute necrotizing pancreatitis. So this we have to keep a watch. And that study from AIG showed that endocrine insufficiency, that again is a manifestation that the gland has not come back. So we have to be careful. For surgeon, how commonly you see pancreatic enzyme insufficiency in patients with pancreatic adenocarcinoma? Because one is resectable, one is unresectable, one is post-surgery. There are 3 scenarios. Yeah.
I think resectable cases also, many 30 to 40% cases, many of them has PEI, and post pancreatic duodenectomy, even 80 to 90% are having the PEI.
Yeah.
Though the publication shows only 30 to 40% they are taking the PEI in right form because surgeons and others are not prescribing.
And studies have shown, though there is no prospective study, that the quality of life, tolerance to chemotherapy and immunotherapy, and to a certain extent, even mortality shows a trend towards improvement when these patients are put on enzyme supplementation. So it's very important.
Even cardiac death, they have noted that after pancreatectomy, others are more due to these deficiencies.
So this is basically pancreatic disease. Now look at non-pancreatic diseases. Non-pancreatic disease, there have been association with type 1 diabetes, CKD, congestive heart failure, post-upper GI surgeries, whether it's esophageectomy or gastric bypass, and so on. So there are a lot of conditions where you can have, but the problem is most of these studies have overdiagnosed PI because that was based on either non-specific symptoms or fecal elastase. So that's the problem. So we are not sure of the association. If you look at this picture, it basically shows there are so many diseases where PI is considered to be a part of it. But some are probable and many are kind of simply an association and observation. These 4 conditions I wanted to say, in aging, fecal elastase goes down, but that doesn't mean the patient has got PEI. If the patient has got symptoms, patient has got nutritional deficiencies, fecal elastase being low, then you should say that patient has got PEI. Diarrhea, anyway in a diarrheal stool, estimation of fecal elastase is not right. One important group which I wanted to highlight was drugs. Somatostatin analogs. They have a very high prevalence of developing pancreatic enzyme insufficiency because they decrease the hormone secretion and enzyme secretion. So these are the drugs where you have to be very careful. Immune checkpoint inhibitors, less common, less than 1%, but they and tyrosine kinase inhibitors. Celiac disease, 13.5% at diagnosis, but we should not do a routine screening. We should do it only when the person does not respond to PERT therapy. Then we should look at associated celiac disease. That's very important. It's simply an observation so far. I told you chronic pancreatitis approximately 50 to 90%. Risk factors are extensive calcification, ductal dilatation, associated diabetes mellitus, continuing smoking and tobacco. These patients have got a higher chance of evolution into having pancreatic enzyme insufficiency. AP I told, at diagnosis, 2/3 have transient pancreatic enzyme insufficiency, but at 1 year follow-up, less than 1/3. Alcoholic etiology, severe pancreatitis, extensive necrosis, post-necrosectomy. They have a higher chance of evolving into PIS with acute pancreatitis. Now coming to malignancy related, sir has already told, if you have a head malignancy, if you have an extensive surgery like pancreatitis, total pancreatectomy, or even in distal pancreatectomy, when you are doing that for a malignancy or chronic pancreatitis. Because the problem is how much was the baseline residual gland. That is also important. If the residual gland is healthy, chances of PEI are much lower. But if it is a diseased gland, then even a smaller distal pancreatectomy can evolve into PEI. Do you agree, sir? So we have to look at the background pancreas also. Overall, if you look at figure, approximately 3/4 of pancreatic ductal adenocarcinoma involving head will have it. That's very important. When do we suspect PEI? So,
if there is present symptoms is present, like steatoria or a patient have weight loss and some subnutritional deficiency in the form of osteoporosis, osteopenia is there, and patient having low appetite and decreased weight loss.
So symptoms can be non-specific. Common symptoms are steatorrhea, osmotic diarrhea, bloating, flatulence, and weight loss. But you have to look at the background high-risk situation. That is very important because these symptoms are non-specific. These are the various symptoms and signs which we need to look at, mainly weight loss, sarcopenia, and osteopathy. These three are very important. Plus micronutrient and macronutrient deficiency, of course, is there. But symptoms alone are non-specific. You can't rely on symptoms to make a diagnosis of pancreatic enzyme deficiency. It has to be in the context of background disease and associated deficiencies. So what I wanted to say was that reduced fecal elastase or any single test is not synonymous with pancreatic enzyme insufficiency. You have to correlate that biochemical value in the context of the patient. That's very important. So if there is a high test probability, we can immediately start treatment. If it's a moderate risk, we need to investigate. And if we have non-specific symptoms, then also we need to test for them. How do we investigate PEI, Dr. Abhishek? Yeah.
Yes, for investigation of PEI, it starts from the symptom assessment, history taking, anthropometric measurement, biochemical measurement, and body composition in the form of imaging. And for the pancreatic exocrine insufficiency, we have direct and indirect test. The most common test, then the first we order the test is the fecal elastase because it has ease of testing, wide availability, and it has a pretty good sensitivity and specificity in advanced disease. And we can also use this test when the patient is on PERT. So that has an advantage. Another test we can order is that carbon dioxide C13 mixed triglyceride breath test. But the problem with this test is yes,
I think I'm supposed to have 25 minutes, no? Dr. Sanjay, how much time I have? More. Okay.
Okay, sir. C13 mixed triglyceride breath test. Problem with this is that not widely available and it takes time up to 6 hours because 30 minutes gap we need to take the breath analysis. But it has advantage in case of post-surgical patients. Another we can have direct test in the form of secretin and cholecystokinin test, and this coefficient of fat absorption, that is the gold standard, but it's very difficult to perform, cumbersome, and it's practically not done nowadays. And also psychometric evaluation of patient reported outcome in PEI, it is very good for individualized treatment and to ascertain the response of treatment.
So quality of life assessment is very important, which we often neglect. Now there is a dedicated questionnaire which we need to fill in. It tells you, it helps you in making a diagnosis, what treatment we need to give, and monitor the response to therapy. That's so as to improve the quality of life. Ultimately, it boils down to improving the quality of life, which we need to pay attention to. Yeah, how will we treat PEI? Dr. Girish?
Yeah, treatment approach in PEI is usually by pancreatic enzyme supplementation. Ideally, this supplementation is usually bovine derived and usually microsphere formulation, and ideally it should be around 20,000 to 40,000 per small meals, and for large meal it should be 40 to 50,000 lipase. And in case of pediatric peoples, it should be 500 USP per kg. In case of the adult more than 3 years, less than 3 years, it should be 1,000 USP per kg. In less than.
What is more important, there is no need of fat restriction.
Yeah,
At
exactly.
least 30% of the calorie has
No
to be fat.
Fat
It
should
has
not
to
be
be taken
restricted.
with meal,
Exactly.
and those can depend upon a lot of factors.
Yeah.
It depends upon the age, it depends upon the nutrition content, what he is taking, background pancreatic reserve, and then anatomy of the bowel. So a lot of factors come into play. And it's safe in pregnancy and lactation.
Exactly.
Is there any...
Whenever it is not working, we have to supplement with PPI, and those can be increased.
We'll come to that.
Yeah.
See, is there any risk with PERT therapy? Do you think there is any risk of PERT therapy? I mean, any side effect or any transmission or infection?
Risk of therapy? So very important is fibrosing colopathy. If it is very high dose, fibrosing colopathy can take place. If patient is a CKD patient, usually hyperuricemia cases, in those cases it should not be prescribed.
There has been some reports of transmission of infection HIV. They were in patients with cystic fibrosis post-lung transplant. But that has been isolated case report. But there is always a risk of transmission because pigs have viruses. So, and we don't heat them to 120 degrees so as to kill the viruses. So that risk of infection will always be there. So this is what you said. These are the dosage which we use. standard dose. Now, there are newer drugs which are coming, a newer formulation. Do you think
I don't think these are efficacious. We have not tried yet.
recombinant and fungal are being used, and there is phase 2 trial, but there is a possibility that in future we may have a non-porcine origin of these drugs, because then the risk of transmission will be reduced. And especially in people who are vegans and who don't eat non-veg, porcine preparation is a problem.
Yeah.
It's very important. So what do you think that we should give spheres, microspheres, powders or tablets? Which is the best?
Ideally, we should give these microsphere formulations. Either it can be mixed with the chimes and it's easy delivery. Another time it will go, and ideally it should be entirely coated, and ideal doses should be maintained so that the dissolution can occur in the duodenum. If it is not working, then PPI should be given to reduce the acidity and keep the pH so that the adequate action can be taken.
What do you think about the diet? How should we approach about the diet? Because that's again nutrition.
Yeah, diet, there should not be fat restrictions, should not be there. The patient should take small, but multiple times, 6 to 8 times he can take. And small diet.
So normal diet, high calorie, high protein, small frequent meals.
Yeah, and Mediterranean diet, very important Mediterranean diet they should take.
See, how do we assess the response? You have started therapy, nutritional rehabilitation, you have started enzymes as per the dosing you wanted. How do you assess the response?
If the symptoms is reducing and patient is weight is gaining and other some non-invasive test, we can measure the response.
So basically we have to look at symptom, we have to look at anthropometry, basically weight, BMI, and number 4, we need to look at nutritional parameters which were abnormal in the beginning. So we need to look at all these at 4 to 8 weeks and then periodically. And there are certain tests which we need to do after once we have followed up these patients. We look at fat-soluble vitamins, we look at nutritional parameter, for example, pre-albumin, retinol binding protein to look at. Then we look at DEXA every 2 yearly, which are these patients are prone to get falls and they have frail, they have prone to non-traumatic fractures. So it's very important. If patient don't respond to therapy, then what to do?
First, we will have to verify the adherence of the dosing schedule and dosing method. If needed, escalate the dose of the PRT. Sometimes addition of PPI can alter the environment, and we need to also, even after these, if the patient is not responding, we need to exclude other comorbidities like SIBO, celiac disease.
Associated diabetes, do you think how big it is a problem?
Yeah, assessment of associated diabetes should be done by different testings. We have to look for the usually the HbA1c and the fasting blood sugar, and also the presence of proteins. So all those things should be taken care of. And ideally, in diabetes, usually 30% to 40% cases can suffer from chronic, and the reverse is also true. And also, as the insulin is less deficient, it should be ideally treated with insulin for better protective action and better prevention of the pancreatic insufficiency.
Yeah, absolutely. So it's very important to look at diabetes, because diabetes has got a bidirectional relationship. PERT improves diabetes, but if you don't improve diabetes, then because insulin has got a trophic action on exocrine function. So we need to tackle both so as to have a better glucose homeostasis. It's very important to look at it. So this is my last slide, which basically summarizes. We have to categorize these patients into high risk, moderate risk, and low risk. If high risk patients are there, for example, post-resectional surgery, extensive chronic calcific pancreatitis, then even without investigation, you can treat them if the patient has got symptoms. Now the problem is the other two groups. We need to test and treat. Even if the background disease is there, we need to document that patient has got pancreatic enzyme insufficiency based on symptom, nutritional parameters, and response to therapy. And then we go ahead and assess these patients and treat them. In low risk, for example, patient has got chronic diarrhea, steatorrhea, unexplained weight loss, we need to test them so as to make sure that the symptoms are because of PEI and there is no other competing etiology, and then treat accordingly. It's very important because the treatment is expensive, lifelong. So we have to be very, very careful before initiating PERT therapy. Very important. And what we have to realize is it's a holistic approach. We need to have a gastroenterologist, we need to have a nutritionist, we need to have a physiotherapist, we need to have an endocrinologist, and we need to have a psychologist. At least these 5 people should be there when we manage these patients with chronic pancreatitis, whether for pain or pancreatic enzyme insufficiency or even diabetes mellitus. I want to thank all the panelists for their contribution. Thank you.
Thank you, sir.
Thank you, sir. for a wonderful presentation. Thank you.
So may I request moderator sir and the panelists to please move forward to the felicitation zone. Meanwhile, we proceed to the next session, which is on ethical dilemma in clinical practice. To chair this session, may I request Professor Kunal Kanti Mojumdar sir, Professor Moushumi Basu madam, Professor S.N. Jha sir, Professor Nandini Chatterjee ma'am, and Dr. Mary D. Cruz madam to please come on the stage and start the session. Our speaker for this session is Professor Dr. Jyotirmoy Pal sir. He needs no introduction. So requesting our esteemed chairpersons to please come on the stage and start the session.
So today's speaker for medical ethics is Professor Jyotirmoy Pal, past president of the Association of Physicians of India and currently doing a lot of work for the academics in West Bengal and in the national level. Dr. Jyotirmoy Pal.
Thank you, chairpersons. I must congratulate Professor Asokananda Kunar and Dr. Sanjay Banerjee for keeping such a time-honored subject. We are at a crossroad. We entered in this profession with a Hippocratic oath. We have a legacy of Dr. Bidhan Chandra Rai, Nil Ratan Sarkar. But on the other hand, we have entered into the era of commercialization, privatization, and finally in the era of artificial intelligence. So our position in the society, which was previously as a god, then a leader, guide, friend, philosopher, there is some tremor in our position. So medical ethics, here comes the issue of medical ethics. So if we talk about the medical ethics, we must talk about the story from the Ramayana. That is the Shushen, Raj Vaidya. He was the Vaidya, means doctor of Ravana. So Lakshman was injured by Meghnad, by Shaktishel. He was severely injured. The Vibhishan given advice, the medicine for this injury only known to Shushen, Raj Vaidya, but he was a doctor of Ravana. So Hanuman went to Shushen, but Shushen accepted to treat Lakshman because he was a doctor. To him, patient is everything, whether it belongs to this camp and that camp. And that is the concept of medical ethics. To a doctor's, patient is everything. Patient is God. So if you go back to the history, era of Vedas, that time Dhanvantari was the son of Vishnu and god of medicine. And before treating, the people used to worship doctors as a god and Dhanvantari. Then came the, after 2000, Vedas age, that means around 5000 years back. Then came the era of Charak and Hippocrates, that is around 4 to 6 before Christ. In this period, both have established or given the oath. The physician, Hippocrates, written that physicians are bound by the oath to treat an ill patient. Most likely, in this over this 3000 to 4000 years, there is some deterioration in the attitude of the physician. That is why the Charak and Hippocrates, both these of the concept, so that physicians are bound to follow some certain rules. Then came the Dark Age, both in Europe and Asia. Common people, they believe in the religious rights as a modalities of treatment. And we know the history of Black Death. So many people has a faith on the church, and so many millions of people died in Europe because they initially thought that church can help them. So in the European Renaissance, when around 12th century there is a massive death due to the plague, then the European thought that we have to invent the scientific system. The God cannot save the people. So from that period, the European Renaissance started, and people start thinking the medicine in a scientific way. So first structured Renaissance came after the French Revolution in the 18th century. That time the doctor-patient relationship was redefined. 19th century. In this century, we get from the documents of Royal College of Physicians, London, that doctor-patient relationship take a new turn, and patient here started beginning considered as a person. Early 20th century, there is a rapid advancement in the science and technology, and empathy was compromised by the structured scientific approach, and patients are increasingly considered as a substrate. Finally, we enter in the 21st century. Here, patients are considered not as a person, but as an object. Somewhere it is a customer, somewhere is a client. So, and next century, we will enter entirely probably the era of AI, and the dream of Spielberg, which he has depicted in 1987 movie Inner Space, may come to reality. So coming to the present day scenario, this is a data published by the Indian Medical Association that more than 80% doctors has suffered of the violence, maybe in the form of physical or mental, and no doctors is devoid of the stress. So what happened to such a noble professions? So why there is a fall of our position from the Vedic era to current period? Whether we are losing empathy, whether we are too much dependent on the technology, whether there is too much commercialization, whether we are looking patient as a client customer, whether really is there any unholy relationship between the doctors and corporate, or there is a failure of counseling from our part. So in this 20-minute session, basically we need some introspections. So another story I'll tell you from the Mahabharata. First story I tell from the Ramayana. In Mahabharata, there is a Dharma Baka Upakhyan. There the patient and doctor relation very nicely told by Yudhishthir. Yudhishthir, Bonaparva, everybody knows the history. The 5 brothers one by one went to take the water. The Dharma in the form of crayon, he told, without giving answer to my question, don't take the water. And all the 4 brothers ignored and they died. Finally, Yudhishthir gone. And Yudhishthir tell him the 18 question, Dharma. Then asked Yudhishthir. One question was, who is the friend of one who is ill? Yudhishthir reply, it is a physician is the friend of one who is ill. So here very nicely in our ancient book Ramayana and Mahabharata, the duty of a physician very nicely in the form of story that is depicted. So medical ethics, what is medical ethics? Basically refer to a moral principle that guide the conduct of the healthcare profession in their medical practice. But in this century, we see there is a breach in the trust, breach in the confidence, breach in the respect. Basically this trust, confidence and respect, they are the basic pillars of the ethics. And this breach has happened at the individual level, at the institution level and at the social level. I can say you one story, how the breach, there is a breach in the trust. Maybe 15 years back, I went to someone's house that is near, the local people know that is near New Barakpur. And that time, that person was telling me, he was discussing about the current scenario of medical practice. He told, he then mentioned some of the doctors. I know, you know this doctor, he stayed nearby. I know him, but his father was a great doctor. I don't know why. Once my father suffered from diarrhea, he wore a lungi and whole night he was in my house given saline and treated. His son is doctor, he has some hiji-viji degree. Hiji-viji means he is MD, DM on particular subject, many of you know him. So he has some hiji-viji degrees. We don't think he is a big doctor. This is the attitude. The person, the doctors may have less degree, but always friend, what Yudhishthira has told. He is perceived as the best doctor to the society. I think there is something, some breach in the trust and confidence and respect that happened. That is why more than 80% doctors nowadays is facing either physical or mental violence. This breach is very easy to develop at the community level. That is why less allegation against the community-based doctors. Still they get a lot of respect. But more allegation against the institution-based doctors because here the trust does not develop. In the community level, trust between the doctor and patient develop over years. But here the trust, the patient first time come to the institution. So here the trust factor does not develop. So most of the allegation we see in the institution level, not at the community level. Hardly you have ever heard any biology is the quack. People in the village feel that quacks are their real friend. They do not believe the doctor, MBBS doctor working in the health center, it is their friend. So there is frequently they attack the health center, the MBBS doctor, but never attack the quack. They serve these people day and night, years after years. So issues, Dr. Sanjay Banerjee sent me a message. If possible, issues this factor, technology empathy gap, financial pressure and moral injury of the doctors, burnt down patient safety, resource scarcity and lack of equitable distribution. It is not possible in 10 minutes to cover all the subject, but I will try to touch upon a few of the aspects. Once Ma Sharoda told in his story that Sharoda Ma told, if you are criticized by others, do not find fault with the others, rather learn to see your own faults. So that is why what I will discuss in the next 10 minutes, basically introspection. Some issues may not be palatable to you, but we have to accept that in our society, in your profession, sometimes maybe 1%, maybe 0.1% this is happening, and that is becoming the issue of mistrust between the doctor and patient. So first issue I am coming, financial and institutional pressure and moral injury. So I am putting one scenario, scenario one, that is a real scenario. I also personally feel, I am a government doctor, at the same time when I do the private practice, I feel this scenario. Patient came with fever for 2 days, this happened only 7 days before in my practice, with headache, mild cough and nausea, seen by the emergency medical officer, and he advised all the tests. When I come to the round in the evening, I ask the EMO, what is the rationality of CT scan brain, the patient having 2 days fever with headache. The EMO replies, CT scan done due to the headache, and it is the hospital protocol. So transition, what is happening? Because when you were childhood, we have seen the hospital owners are basically doctors. That gradually scenario changed. Then it came to the hand of local businessmen. Then it came to the state and national level corporates. Now it is coming to the hand of international corporate. So doctors' voice, we doctors are bound by the protocols of the hospital, by the corporate regulation, and there is also fears of regulation. There is our voice. It is true, sometimes what Sanjay told, the moral injury, we are feeling, it should not be done. CT scan should not be done in a patient have a mild headache in a 2 days fever. But we are bound to accept. Sometimes we cannot protest due to the lack of various reasons. I will come later on. So we have a little voice. Why? Because of the corporate pressure. Too much competition among the doctors. If I protest that don't do the CT scan in a 2 days fever, other doctor will support and I lose the practice. Abolition of the single doctor chamber. Previously we see, now it is a polyclinic concept. You have to obey the rule of the polyclinic. Very important lack of proper forum of the doctor. Doctors are the least united community in India. If there is a group, you will see always there is an infighting. We do not talk in a single voice. The rickshaw puller, if there is a 500 rickshaw puller, they talk in a single voice. But we not the doctors. We have a lack of unity. That is why we cannot raise voice against the corporate. If we see we are forced to do something, to accept something, that is not ethical. Scenario 2, everybody has faced, patient diet, payment dues, body is not released. The patient party put pressure as if doctor is the culprit, for doctor is not releasing the body. But if there is a 1 lakh fees, 1 lakh billing, doctor's fee may be 2,000 or 3,000 only. Scenario 3, patients having the diabetes, initiated newly launched insulin or doctors have initiated some of the insulin or OHA which is newly launched by some pharmaceutical, giving the specific number of MR. And last 2 points I have personally feel, patient purchased patient medicine from Janu Oshudhi and physician was very angry, advised not to visit if continue to purchase medicine from Janu Oshudhi, and that patient came to me and complained about the previous doctors. So these are the issues, the institution, financial pressure, moral injury. Sometimes we are bound to go some unethical ways, and maybe due to pressure, maybe due to some other reason, that create and that develop the mistrust between the patient and doctor. Second issue I am coming, the technology empathy gap, because nowadays we are era of artificial intelligence. We have a conflict. How much artificial intelligence, how much will be dependent on artificial intelligence, or we will go by our age-old age-old traditional teaching. Nowadays, ChatGPT is there. Before giving treatment, everybody is searching what is the treatment modalities. Whether we will go directly by the ChatGPT, what ChatGPT is giving advice, or we should follow what our teachers has taught us. So we should go for the traditional method or by artificial intelligence. Artificial intelligence first created a wave when the Gary Kasparov from Russia, he was lost in the 1997 to the IBM supercomputer and in the chess competition. And that was the beginning that artificial intelligence, machine power can dominate over the human power. Next 2000, there are many stories. I put the two stories because shortage of time. In 2024-23, the New York mom marries a robot and even spend the night time with the robot. So question came whether in the coming days, we are all losing human power, love, sorrow, passion, empathy, all to machine. This is a very, very relevant question that is coming in one mind. The answer is not so simple. So artificial intelligence versus clinical judgment, basic thing, artificial intelligence basically based on the fixed program information, but clinical judgment that develop over our experience. Artificial intelligence lacks rapport with the patient. Artificial intelligence lacks the empathy. Artificial intelligence cannot fit for the individualistic medicine that is very much required for the clinical practice. A clinician, on the other hand, can establish rapport with the patient and have empathy and based on the patient's socio-economic condition, their psychology, their need, a good clinician can prescribe medicine that the artificial intelligence or ChatGPT cannot. That is the basic difference between the artificial intelligence and clinical judgment. So what is empathy? Just again I will tell you the one story that will say you what is empathy. That is a story from Mother Teresa. One day Dr. Devi Shetty, that time was in Calcutta, and during operation got a phone call from a house, repeated phone call. Doctor, please visit me, I am suffering for fever. His PA replied, sir is a cardiothoracic surgeon, what he will going here? But a repeated phone call came, then Shetty told, okay, I will go. So Shetty came to that house, and that lady was none other than Mother Teresa. Mother Teresa then explained why I called you. Because I need the tender, the gentle touch of a doctor in my body as I am ill. So Mother Teresa, in his biography, he has written, very important, the hands that help are holier than the lips that pray. A few days back, we have done our annual conference of API. We have given a memento, and there I have put this quotation, very important quotation, and that is the ultimate word for what is called empathy. The McMaster Book of Internal Medicine, we have made the Southeast Asian edition that is considered the birthplace of evidence-based medicine. Here very important line in their preface, because McMaster University, so many evidence-based, there is a birthplace, but here they have written, medicine is a encounter between two people, patient and doctor, nobody else. The unique bond between the patient and doctor cannot be replaced by the most sophisticated technology, automatic application of scientific data or practice guideline. Who is saying? It is a McMaster University, the birthplace of practice guideline. That means clinical acumen, clinical skill, empathy, touch to the patient is supreme than any practicing guideline. So there is a conflict in our mind. Should we welcome artificial intelligence? If so, when, how much, whether in all sphere or in limited sphere. Kasparov, he lost in 1997. After 20 years, he wrote a book on deep thinking. Here he has written, a weak human with a machine working in harmony is more effective than either a strong human or a powerful machine working alone. That means artificial intelligence and clinical judgment, both are required. We have to very intelligently, human intelligence should intelligently use the artificial intelligence. I will tell you another story that will again say why the empathy, your clinical judgment, your touch with the patient is more important than the clinical judgment. The Parvati has a divine fruit. He told his two sons, Kartikeya and Ganesha, who will come first encircling the earth, I will give you the divine fruit. Then Kartikeya start moving the earth with the peacock. But Ganesh thought that mother is the earth, so moved around his mother and came faster, and Parvati given the fruit to Ganesh. So this story proved that wisdom is greater than the speed and power. So very few minutes, 2 to 3 minutes, if you 2-3 minutes extra is permitted, I will touch upon few points because we all are burnt out and that cost the patient's safety. The burnt out story very nicely in one song of Manna De, everybody is very popular, Sheyama Chotobon. That means we the service provider, sometimes we are forced to give so much service, we become fatigued. And the customer do not give us the relief. So that is the burnt out system. Burnt out system, now doctors, it is seen in the study that more than 80% doctors are burnt out. That cause the patient safety. And why you are burnt out? There are so many reasons. So definition of burnt out is basically syndrome of emotional exhaustion, depersonalization, sense of low personal accomplishment that lead to decreased effectiveness of the work. So we should not be burnt out. If that condition, our delivery will be defective and we cannot give the best delivery of the patient and sometimes at the cost of ethics. So burnt out in medical profession may be due to workload, practice setting, patient characteristic, sleep deprivation, method of dealing with the death, suffering, malpractice suite and so and so. So this is the dilemma. This is the dilemma in the doctor. Why we have a dilemma? Because in one hand we have to give to service to the society 2 minutes. Pressure from the corporates, pressure from personal and family corporate, rationing of the healthcare resources, excess patient load more than capacity, self-prescription harassment, socio-economic issue and evidence-based medicine. So sometimes we cannot balance between the evidence-based medicine, our demand from the personal and family commitment or pressure from the corporate or the resource. When we cannot balance all these factors, we do some mistakes at the cost of medical ethics. So 2-3 scenario I will put here. A junior doctors, that is a real time frequently face in the government hospital. Junior doctors do all on duty in the emergency in the ward. And one doctor, he done the whole night duty in the ward and emergency. Just before the next shift, one patient came. That many of us does. Just do some delay to push this patient in the next unit. Unfortunately, that patient died and all blame came to the doctors. This is the burnt out system. Due to the heavy duty, due to the scarcity of manpower, doctors, junior doctors were forced to shift to the timing of admission to the next unit. And ultimately, apparently it looks the lack of empathy, why there is a delay of 15 minutes. But it is basically to the burnt out system because of the lack of scarcity, lack of people, manpower, but over pressure in the emergency and hospital. There is another story. That is this is not the fault from the doctor, but there is another story. There is a fault from our part. One surgeon used to give round at the midnight because he practiced from Sonarpur to Krishnanagar, almost 150 kilometer distance in different nursing home. Patient was female and he used to come in the midnight. One day I told, don't do like this, but he has not listened to me. But he got a complaint from the doctors for the midnight visit. So doctors, we are not above the criticism. There are some unpleasant fact. The target set up by the corporate sometimes happen, not an unknown fact. Doctor-pharma relationship also not an unknown fact. Commissioning system also not an unknown fact. So this is the reason why we are losing trust between the doctor and patient, and that is why counseling is failing. There is a two aspect. Literature is considered, literature, movie considered, it is a reflection of the society's perception. So there are literature where Karl Bella, the Shamones Mojumdar, they have written, and that is a very bad perception of the doctors over the society. And there is a singer Nochiketa, very famous song. And here also he has projected doctors as on and off, take the commission and the villain of the society. But the other hand, there is a movie of Ganashatru by Satyajit Ray, when the doctor protested and became the villain of the society, ultimately proved that doctors are the real friend of the society. Thanks to Dr. Satyajit Ray, our legendary movie maker, he's made this story. And during period of COVID, we see so many doctors lost their life day and night when all the society has moved to the room. They doctors, they work for the patient and sacrifice their story. But there is no song when the young doctor in the COVID period traveled 2,000 kilometers from Pune to Kolkata during the knockdown. There is no rescue to the doctors when the mob attacked doctor in indoor while doing real duty to the COVID patient. There is no sympathy to the doctor when the landlord evicted a resident of him from his apartment. So there is a dilemma and conflict. There are two core issues. But dilemma, conflict is the core issue of the society. But how we will deal the conflict, that is your skill. So, but finally we believe there is a songs from Sholay, the ye dosti hum nahi todenge. Patient-doctor relation cannot be broken at any cost. Thank you.
Thank you, sir. Very well said. And he has started with history. I will complete with the present situation. In our time, we also felt when we were students, we lacked ethical aspect in our knowledge. But after 2019, the NMC has incorporated CBME, that is competency-based medical education, where ethics are being treated from undergraduate level. And we are being, in every subject, you must have some questions on ethical system, that is called ATCOM, Attitude, Ethics and Communication. And with this note, I will say that there are 4 main principles of ethics we must not forget: the justice, everyone is same, the beneficence, the non-beneficence, and we should know our responsibilities, whether we are lacking behind in some parts, but in future, the evidence-based medicine should be practiced, and you must be clear about what are our duties. Being a student of law also, I must tell you, every case is a potential threat in a medical legal shoot. So we must be cautious and we must know about our rights, about rights of the patients, and what is expected from a competent doctor. Thank you. Madam,
Thank you.
So we'd like to thank Dr. Jyotirmoy Pal for that excellent talk on ethics, and we'll close this session now and move on to the next.
Now may I request Professor Pal sir and the chairpersons to please move forward to the felicitation area. Now we move forward to our next session. To chair this session, may I request Dr. Madhu Chandakar Madam, Dr. Sujit Chaudhary sir, Dr. Sukrit Shute sir, Dr. Arup Chaudhary sir and Dr. Tuhin Mitro sir to please come on the stage and start the next session by introducing speaker.
So I would like to invite Dr. Sonmoon. Can you give the talk on IPMN, the understanding and management in 2026?
Okay. Thank you so much for the kind introduction, and thank you, Sanjay sir, and the organizers for inviting me here. So my talk today is on IPMN of the pancreas, current understanding and management. I'll start with the case. This is a 71-year-old male who underwent a CT abdomen for evaluation of abdominal pain and was found to have this cyst in the tail of the pancreas, which is nearly 3 centimeters with a mural nodule. So a couple of practical questions arises when we evaluate the cyst. First is, what's the diagnosis? What would be the best imaging modality? Indications of EUS, and what is the risk of malignancy in that cyst? Then management options, indication of surgery versus surveillance. So the differential diagnosis while evaluating the pancreatic cystic lesions are many, but today we're going to focus only on IPMN. So intraductal papillary mucinous neoplasms, they have 3 subtypes. First is main duct IPMN, which is defined as segmental or diffuse main duct dilatation greater than 5 millimeter without other causes of obstruction. These are the highest risk of malignancy of around 40 to 60%. Then comes to branch duct IPMN. These are the pancreas cysts greater than 5 millimeter that communicates with the main pancreatic duct. They do have around 7 to 40% lifetime risk of malignancy. Then the third type is mixed duct IPMN that involves both the main duct as well as side branches. So there are a lot of prevalence data outside of India, but I was just searching for Indian data. There is no true prevalence data that I could find, but this is a surgical series with 423 patients who were operated for pancreatic cystic neoplasm. And as you can see, the proportion of IPMN is only 8% compared to 20 to 40% in the West. Not sure whether we are missing the diagnosis or it's the real less prevalence in India. And the missing could be because we're doing less CT or MRIs. And the malignant IPMN overall was only 2.8%, and of which total, you can see that 2/3 of the patients with IPMN underwent unnecessary operation. The preoperative diagnosis was available only in 56% of the patient, and EUS performed only in 16%, which are really low, and surgery-related morbidity 30%, mortality 0.9%. So 2 questions arises that how we can fill the gaps here, how to make the preoperative diagnosis better, and how to prevent patients from undergoing unnecessary surgeries. And the data is similar outside of India also, like around the world. In this meta-analysis, including 16 studies, 5,830 dissected specimens, preoperative misclassification around 24%, and around 24% of IPMN, they underwent unnecessary surgery. And in total, 44 of the benign cystic lesions, they underwent surgery. So definitely this data warrants the need for a better preoperative diagnostic tools. Now comes to risk stratification. Like we know that they do have malignant potential, but not all of them, they get malignant. So we have to risk stratify. So there are multiple guidelines in the last 2 decades that have been published with the goal to improve the diagnosis of high-grade dysplasia. Actually, that's what we aim for in diagnosing in pancreatic cysts, whereas limiting the need for unnecessary surgeries, but we are still not there yet, and perhaps no one guideline is better than the other. But most of us, we do follow the IAP, the Kyoto or Fukuoka guidelines. Some of the caveats of these guidelines, first is the focus of each guidelines, they do vary. And they uniformly state that the grade of evidence is relatively low and the number of RCDs are extremely limited or not there, and no one is better than other. So again, the aim of the guidelines are risk stratification and timing of surveillance. Here you can see 2 contrasting cases to highlight that one would expect from these guidelines accurately risk stratify so that the cysts that have the highest risk of malignant transformation would be detected early stage, like at a point that we can intervene and perform a curative resection. So the image in the left side, obviously what we want, like the exact outcome, we're trying to prevent malignancy happening, whereas the image on the right, you can see that the initial presentation is already malignant transformation. So the patient needs surgery, chemo, and all. Coming to the imaging modality, most of us agree that a high-quality MRI and MRCP is needed as the diagnostic test for pancreatic cystic neoplasm, and then risk stratify. So the high-risk stigmata are there, like where the cancer is already present or it's on its way, whereas worrisome features that really needs additional workup to prove which side they are going, like whether more aggressive or less aggressive, and this is the category that needs additional testing. So the high-risk stigmata, they include either patient has obstructive jaundice, enhancing mural nodule, that's very important, greater than 5 millimeter, main pancreatic duct greater than 10, or suspicious or positive result on cytology. Worrisome features, of course, clinical and imaging. The main imaging diagnostic criteria are cyst diameter greater than 3 centimeter. Again, enhancing mural nodule, that's very important because sometimes the mucus plugs, they can mimic like mural nodule, less than 5 millimeter. And then the cyst growth size of greater than or equal to 2.5 millimeter per year. So that's something recently added in the Kyoto Guidelines 2024. So if you see any of the worrisome features, they definitely need additional testing. Once again, cumulative risk with multiple worrisome features, if you see, like this is a study, large surgical series with 810 resected IPMNs. The malignant rate that goes, that increases with the number of worrisome features present. So with one worrisome feature, it's only 22% compared to 4, it's kind of 100%. So the indication of EUS are any worrisome features on MR, cyst size greater than 3, thick walls, a mural nodule, abrupt change in caliber, again, cyst size or cyst growth greater than 2.5 per year millimeter, then unilocular cysts. Coming to cyst fluid analysis, the standard test that we send while doing an EUS FNA, that is the liquid biopsy, it's CEA, amylase, cytology, and glucose. So the addition of glucose, it has increases the accuracy of differentiating mucinous from non-mucinous to up to 80%. But again, not 100%. And another caveat is that they do not reliably stratify the risk of dysplasia. Again, our goal is to find high-grade dysplasia if possible, or invasive cancer. The first goal is differentiating mucinous versus non-mucinous, and then second is stratification of dysplasia. So here it comes, the advanced diagnostics. So cyst fluid and imaging, there are multiple next generation sequencing or molecular analysis paper have been recently published, who kind of added a little bit with the diagnosis, and US guided needle-based confocal endomicroscopy also has some added studies. Then tissue acquisition, either through the scope, through the needle biopsy or final biopsy. So molecular analysis, especially the KRAS and GNAS, they do have around 98% specificity of diagnosing a mucinous cystic neoplasm. That means it's good in ruling in the disease, but the sensitivity is modest. So if the test is positive, so that's good, but if the test is negative, it doesn't add much. Molecular analysis has the same study, in the same meta-analysis, they analyzed around 700 resections for identifying advanced neoplasia, and you can see that the sensitivity dropped further, but the specificity remains very high. So again, high specificity makes molecular analysis valuable for ruling in high-grade dysplasia or invasive cancer when positive. This is an exciting study, the Pancreas Sequence Genomic Classifier study from University of Pittsburgh on molecular analysis of cyst fluid. So it incorporates both the DNA as well as RNA analysis, and the results are pretty promising with a very high sensitivity, specificity, and accuracy in differentiating mucinous versus non-mucinous, as well as detecting advanced neoplasia. So hopefully this can be validated in other future studies. Coming to needle-based confocal laser, confocal endomicroscopy, so there are multiple studies from the West, of which 2 of them are single center, and the recent CLIMB study data, that's a multi-center study from the United States. They are also assessed the accuracy, the sensitivity and specificity of the test in differentiating mucinous neoplasm, and it's pretty good, 93% and 92% specificity with accuracy of 93%. So again, that's good in differentiating high-grade dysplasia also. So the results are promising, and again, these studies also need validation. They also incorporated AI and compared that with the human observer, and of course AI performed better. And through the needle biopsy, it has diagnostic yield of around 80%. However, it comes with a kind of increased adverse events, but the adverse events rates are lower in expert centers. The most common adverse events were acute pancreatitis. So last slide, management. First is accurate diagnosis, so CT, MR, US, cyst fluid analysis, molecular diagnosis, and then through the scope, through the needle biopsy, if you have it, then risk stratify the cyst, then come to treatment option. If there is high risk stigmata or greater than 4 worrisome features, then surgery. But if the surgical risk is high, and IPMN is the diagnosis, then MCN, again reconsider surgery. But if the patient is not willing or an increased surgical risk, always you can think of ablation. That's a new area that's been developed, and I'm sure Sukrit is going to speak more about it. And if the worrisome feature are less than 2, then surveillance. So back to the case, the patient underwent EUS, cyst size 3.4, 1 worrisome feature, then communicating with the main PD, thick septation, and enhancing solid component, FNB was performed, and high-grade dysplasia, and the patient sent for surgery. So in summary, differentiating between the mucinous, non-mucinous cyst guides management. MRI is the imaging modality of choice. US FNA, additional information we get. Cyst fluid analysis cytology can help decision making and have limitation. So NGS and molecular analysis likely the future in making the accurate diagnosis. Surgery for high-risk lesion, individualized surveillance program. But the dilemma in IPMN management is still balancing surgical morbidity versus missed cancer with surveillance. So we need more streamlined data and testing for this. Thank you so much.
So, great talk, Sanmun. One thing I think I would like to add to it, mean duct IPMNs, now we do pancreatoscopy very frequently to help our surgeons out.
Yes.
So I think that needs to be touched upon as well, because we can take biopsy, they can be multifocal, and that really helps them to guide their surgical, like their whole
That's
entire
right.
surgery.
Yeah, you have to do intra-op pancreatoscopy.
You can do
Right.
pre-op as well.
Yep.
We give them the entire video and then they can judge.
Yes, yes, that's right. Any other questions? Surveillance, right? Sorry, I didn't get the time to kind of get through my slide of that. So surveillance, it's pretty individualized, and it depends on the cyst size and the number of worrisome features and results of the USFNA and the diagnosis, of course. So depending on the cyst size, if there is no worrisome features at all, then if the cyst size is less than 2 centimeter, then first 6 months, and then you go to like every year. And then you can stop it if the cyst remains stable for 5 years. And if the cyst size is greater than 3, for example, then 6 months, and then you continue 6 months till the patient can tolerate and pay for it. And if that remains stable, you still continue it. You don't stop if the size is greater than 3. So it's pretty confusing, but there is guidelines on it.
Thank you, ma'am, for your excellent presentation. But as far as this new latest guideline or latest development regarding IPM, it's that it just follow the all and none law. They are giving more preference to surgery because US is not necessary, it's just optional. And they also consider a risk of needle track shading regarding this. If the patient is at all symptomatic like head lesion, obstructive jaundice, recurrent acute pancreatitis because of mucin, it is young patient willing for surgery, is sent the patient to surgery only.
Yes, so that's, they are included in the high-risk stigmata, so you can send them to the surgery directly. But again, the recent guidelines, they also says that you can do EUS if the diagnosis is not clear prior to the referral to the surgery. So, but you can send them to surgery
Even
directly.
though they don't have a high-risk stigmata, but recurrent acute pancreatitis because of mucin, young patient, that also suggests that you better send the patient for
Yes.
surgery so that he can be
So
prevented
recurrent acute pancreatitis, it's not there as the criteria for high-risk stigmata.
It's a worrisome
but-
feature.
Say it again.
It's a worrisome symptoms.
Yes, it's an worrisome symptoms, but if that's particularly because of that cyst, then makes sense.
Better to send the patient
Yeah,
to
surgery.
Thank you, ma'am.
I'm talking in an oncological perspective because I practice oncology. Last 2 patients, high risk, but anatomically not amenable to surgery. So you showed something on ablation. So can you highlight 1 or 2 words on that?
Sure. So that's again a very new branch that we're entering. So ablation is not, I think majority of the time the surgeon can resect. Like location is not a problem.
Anatomically sometimes.
So main is the whether patient is a surgical candidate, that's an issue. If the patient is elderly with a lot of comorbidities, then we can think about ablation, or even a young patient with a lot of comorbidities, not candidate for surgery, yes, we can think about ablation. And ablation, there are multiple options available in ablation, alcohol or chemoablation or RFA recently. So what we exactly do is we go in to the cyst with a needle that's kind of 19 gauge, and then we aspirate all the fluid out, and then we either insert the chemoablation treatment, or we apply RFA. So that has shown some good result in some patients with complete response. But one of the caveat is we don't have any test other than size to kind of monitor our response, because there could be a high-grade dysplasia sitting there and we haven't treated.
Thank you, ma'am. Now we will wrap up here. Thank you.
Thank you. May I request to please kindly move to the felicitation area. So now our next session is on group pancreatitis. To chair this session, may I request Dr. Devashish Datta, Dr. P.K. Shetty, Dr. Vijay Rai, and Dr. Avinash Mishra sirs to please come on the stage. May I also request Dr. Joya Ghosh Chatterjee madam to please come on the stage and start the session by introducing our speaker, Dr. Sushant Shetty, sir.
We have come to a very important topic now, groove pancreatitis, a diagnostic challenge and therapeutic dilemma. And can I request Sushant to give the talk? Thank you, Sushant.
Very good evening, all of you. At the outset, I am thankful to Kolkata Pancreas Club and Dr. Sanjay Banerjee in particular to give me an opportunity to talk on group pancreatitis, a diagnostic challenge and therapeutic dilemma. Group pancreatitis, first described by Baker and Miske, is a rare focal form of chronic pancreatitis involving the pancreatico-duodenal groove. What is the groove? The pancreatico-duodenal groove is located between pancreatic head, as the name suggests, second part of duodenum and distal common bile duct. So 1973, Baker first described the condition as renin pancreatitis. In 1982, Stolt introduced the term group pancreatitis. In 2004, Arce and Jamboni unified several related entities, namely group pancreatitis, cystic dystrophy of heterotropic pancreas, duodenal pancreatic hamartoma, paraduodenal wall cyst and myoadenomatosis under one umbrella term, paraduodenal pancreatitis, because they share clinical, pathological and some radiological common characteristics. So group pancreatitis, the prevalence is 20 to 25% among patients with chronic pancreatitis undergoing surgical or pathologic evaluation. Predominantly it affects men and peak incidence is 40 to 50 years, and there is strong association between with alcohol and smoking. So major risk factors are heavy alcohol consumption and tobacco smoking. Various studies suggested up to 95% of association with smoking and up to 90% association with alcohol. Other risk factors include pancreas division, pancreatic duct stones, annular pancreas, ectopic pancreas, duodenal wall thickening, and peptic ulcer disease. So what is the pathophysiology? The pathophysiology exactly is the cause is not known, but several postulations are there. One is the role of ectopic pancreas, which leads to pancreatic heterotropia with duodenal wall, enzyme trapping, donor gland hyperplasia, local inflammations, which leads to progressive fibrosis and cystic dystrophy of duodenal wall. Another subset of thinking is there because it is very prevalent with alcohol abuser. So alcohol causes increased viscosity of pancreatic secretions, protein plug formations, duct obstructions, which lead to recurrent pancreatitis and chronic localized inflammations and fibrosis. So pathogenesis of group pancreatitis, basically fibrous and inflammatory changes in the pancreatic groove, which leads to thickened duodenal wall with cysts. And cysts are usually maybe seen up to 60% of cases of the group pancreatitis. And microscopy reveals donor gland hyperplasia, neural proliferations, granulation tissue with foreign body, giant cell reactions, dilated ducts with intramural cysts. It may produce duodenal stenosis, thus producing features of gastric outlet obstructions. There might be CVD compressions, which leads to obstructive jaundice, and pancreatic duct narrowing, causing features of chronic pancreatitis. The types of group pancreatitis, it includes pure group pancreatitis and segmental group pancreatitis. Pure group pancreatitis is the inflammation affects the groove area only, and segmental group pancreatitis involves the groove area along with extension into head of the pancreas. And another diffuse type also has been reported in which the groove inflammation extends beyond the cephalopancreatic area and it involves the entire gland. So this is in pure form. You can see the normal appearing pancreatic head and the inflammation confined to the groove area only, but here in the groove, along with the groove, the pancreatic head is also affected. This is segmental pancreatitis, and you can see the cysts also there. Coming to presentation or frequency of symptoms, the most majority of cases they present with abdominal pain. Most of the series they present up to 90% of patients they present with abdominal pain. They do present with features of outlet obstructions like nausea, vomiting and weight loss. Sometimes they present like acute pancreatitis, and diarrhea and jaundice can be features, and sometimes dysphagia and upper GI bleed are also associated in few of the cases. So diagnostic approach includes clinical suspicion if you are suspecting group pancreatitis, and if it is supported by cross-sectional imagings, you might need EUS evaluations and histological confirmation whenever necessary to rule out pancreatic head cancer, because that's a differential diagnosis. You have to rule it out while dealing with a case of group pancreatitis. Sometimes the patient, when present with gastric outlet obstructions, you might do endoscopy first. This is one of my case, a 45-year-old male, chronic alcohol, he presented with recurrent vomiting, weight loss, and endoscopy revealed fleshy mass-like lesion suggestive of inflammatory stenosis at the level of upper duodenal genu. So it is not unusual to find this type of presentations in case of group pancreatitis if you are doing endoscopy first. So When we are evaluating the cases, radiological evaluations, because ultrasound is initially the first investigation, patient comes with pain abdomen. So you may have hypoechoic band between pancreas and duodenum. Pancreatic head enlarged with heterogeneous mass, thickened duodenal wall. However, it is highly non-specific and ultrasound is mostly done to rule out other etiology. CT scan reveals loss of fat plan, ill-defined presenting or frank soft tissue mass between head of the pancreas and duodenum, dilated pancreatic duct in body and tail in segmental type, and mass-like enlargement of pancreatic head mimics cancer. So differentiation from pancreatic cancer is challenging. You have to differentiate from pancreatic cancer because prognostically it is entirely different. And absence of retroperitoneal inflammations and features of chronic pancreatitis differentiates from acute and chronic pancreatitis respectively from group pancreatitis. Also, MLH lipase are not markedly elevated in case of group pancreatitis. So in CT scan, duodenal wall thickening with mural hyper-enhancement, as here it is seen, you can see, and paraduodenal cysts can be seen, and hyper-enhancing soft tissue between pancreatic head and duodenum can be seen. So this is the duodenal hyper-enhancement, this is a groove, and these paraduodenal cysts are also there, like this. So MRI is a better modality than CT scan. It is 87% accurate, negative predictive value to the tune of 92% for group pancreatitis diagnosis. Most characteristics of group pancreatitis in MRI is a sheet-like mass between head of the pancreas and duodenum, hyperintense to pancreatic parenchyma in T1, and iso or hyperintense on T2 images. MRI helps differentiate GP group pancreatitis from pancreatic cancer by features such as smooth ductal narrowing, Brunner's gland hyplasia, and associated findings like CBD encasement or a banana-shaped gallbladder. So this is the MRI picture where this is the duodenum and this pancreatic head, this is the groove, and this is T1 image. In T2 image, it can be iso-intense, hypo-intense, or hyperintense because it depends upon the stage of the disease. During inflammations or edema, it can be hyperintense, and when disease goes on, progression to fibrosis, it may be hypointense. This is the banana-shaped gallbladder you can see in MRCP. ERCP, the role is limited due to possible duodenal stenosis in these cases. However, it can demonstrate smooth CBD stenosis with normal MPD if cannulation is successful. US is the highly sensitive modality and mostly used for evaluating group pancreatitis. It can identify and assess the location of cyst in the muscularis propria of duodenal wall, enlargement in the minor papilla area without any communication with PD. Vascular nodal involvement can be seen, but vascular invasion is not seen in contrast to pancreatic head cancer. And nodes are also not typical of pancreatic head cancer. FN and FNH can be done, but it has its own set of limitations, and FN, FNB may not be revealing some some features if fibrosis is advanced. This is the summary of clinical performance of various imaging modalities. US and US FN and FNB leads the brigade, followed by MRI, MRCP, CT, and ultrasound. So differential diagnosis includes pancreatic duct adenocarcinoma. That is the most important thing to differentiate between pancreatic group pancreatitis. And ductal adenocarcinoma closely mimics group pancreatitis, especially in case of segmental group pancreatitis. Clinically, pancreatic ductal adenocarcinoma more often presents with jaundice and elevated tumor marker like CA19-9, which is normal in case of group pancreatitis. Radiologically, pancreatic duct adenocarcinoma shows abrupt ductal cutoff and irregular dilatation. So, and in group pancreatitis, you will see smooth dilatation only if at all that is there, whereas group pancreatitis demonstrates smooth ductal narrowing. So, group pancreatitis associated with cystic changes, patchy enhancement, cystic changes may be seen in up to 60% of cases, and periatrial fibrosis without major vessel invasion. While pancreatic ductal adenocarcinoma shows homogeneous hypointensity and vascular infiltration, especially gastroduodenal arteries. Other differential diagnosis includes duodenal adenocarcinoma, autoimmune pancreatitis, chronic pancreatitis, GIST, benign neoplasm, IPMN, and acute edematous pancreatitis. So diagnostic workup, if you are suspecting group pancreatitis in case of male patient in 4th or 5th decade, smoking, excessive history of smoking and alcohol use, and clinically you are suspecting pancreatitis, cross-sectional imaging like CT, MRI, they might be suggesting, and you have to do an endoscopic ultrasound for exclusion of malignancy in tumor-like pattern, or if needed, then you will do FNA or FNB. Similarly, if you are thinking gastric outlet obstructions, endoscopy could be done first, then you proceed to other investigations. However, in medical management includes suggestion of risk factors, assessment of exocrine and endocrine insufficiency, which is not very common in case of isolated group pancreatitis, conservative, endoscopic or surgery per phenotype. Two phenotypes are described, group pancreatitis. So one is inflammatory subtypes and is fibrotic subtypes, each requiring a tailored therapeutic approach. Conservative treatment more effective during inflammatory stage of group pancreatitis, And patients with long-standing disease and fibrotic complications they usually benefit more from interventional procedures. Conservative management includes bowel rest, evidence of alcohol, tobacco, fatty food, PPI, etc. Adequate pain control with acetaminophen, gabapentin, pregabalin, TCS can be of help. Some studies suggested mixed result with octreotide. Narcotic analgesics can be given with caution if patient is not responding to other conventional analgesics. Neurostimulation techniques, though promising, most of the data is not sufficient as of now regarding neurostimulation techniques. Coming to endoscopic management, either it could be ERCP-based therapy or US-based therapy. In ERCP, mainly for pancreatic ductal stricture with upstream dilatation and symptomatic acidosis. ERCP with pancreatic ductal stenting, minor papilla sphincterotomy, plus minus stenting, biliary ductal stenting for distal CBD stricture is usually done. And US-based therapy, drainage of symptomatic cyst or cystoduodenostomy, and sometimes in case of pain, US-guided celiac plexus block can be done, though it does also have insufficient data. Surgical management remains the therapeutic option who fail conservative or endoscopic management. In fact, in contrast to chronic pancreatitis, where there was a lot of debate regarding endoscopic therapy and versus surgery. Now, jury is clearly out. The surgical modality is far more superior than endoscopic therapy. 3 randomized controls that showed this. So, unlike that, group pancreatitis, there is no study to establish surgery is far more superior than endoscopic management. However, surgery remains the therapeutic option to fail conservative or endoscopic management. That means refractory obstruction or fibrotic strictures and suspicion of malignancy. Suspicion of malignancy is most important thing. Whipple surgery is preferred surgical technique, and group resection of pancreatic head procedure where large portion of pancreatic head, MPD, CVD and duodenum are preserved. So that can be done. It is in practice since 2017. Future directions and AI rapidly emerging as imaging-based techniques. Modalities provide far more visual information than human eye. Unnecessary interventions can be prevented if AI is used, and numerous algorithms developed to aid differentiating various pathology. Ladies and gentlemen, to conclude my talk, I would say group pancreatitis accounts for a small proportion of chronic pancreatitis cases. Most patients are middle-aged men with history of alcohol and consumption of smoking. The greatest clinical challenges in distinguish group pancreatitis from pancreatic head carcinoma, as I said, they are prognostically different. US with tissue sampling has become central to diagnosis and treatment planning. Management includes conservative or endoscopic interventions, ERCP stenting, US-guided drainage, celiac plexus block, surgery for refractory cases, and future development of AI-based diagnostic imaging looks promising as of now. Thank you for your patient listening.
Thank you, Shujan, for a wonderful talk, and you finished exactly on time. Do you have any question?
It's a very great presentation, sir. Absolutely great, sir. I have
Thank
one
you.
question, sir, about the nutrition part in this group pancreatitis. When do we decide we should go for a nasovaginal or US-guided gastrojejunostomy or fedojejunostomy? So what your take on it?
Yeah. So basically, group pancreatitis, sometimes they present with gastric outlet obstructions, like the picture I showed, gastric outlet obstruction. In that case, so you can put, if nutrition patient is presenting with weight loss, vomiting, then you can think of to take care of the nutrition by nasovaginal tube. But the only thing is that may not be suffice. So you have to have a definitive therapy for that. Initial presentation, yes, for the time to take some time, kill some time, you can give nutritional therapy, but it may not be suffice.
Just 2 quick comments. I think in my experience, the obstructive symptoms are quite often present in group pancreatitis. I think a lot of people do present with vomiting now and then. And the other thing is the confusion, as you mentioned, with the pancreatic cancer. So often there is a debate what we are dealing with. I think you will probably agree with that.
Yeah. Yes.
Any questions from the floor? Otherwise, we'll close the session. Thank you very much. Thank you, John.
Thank you. Thank you once.
May I request Speaker Sir and esteemed chairpersons to please proceed to the felicitation zone. Now we move to our next session, which is on challenging drug strictures in chronic pancreatitis. To chair this session, I request Dr. Somnath Mukherjee Sir, Dr. B.R. Medhi Sir, Dr. Soumi Ghosh Sir, Dr. Sanjeev Kaur Sir and Dr. Amitabh Roy Sir to please come on the stage and start the session.
We move on to our next topic, challenging duct strictures in chronic pancreatitis, techniques and outcome. May I welcome Dr. Abhinav Sharma for this talk, please.
Thank you, chairpersons. So at the outset, big thanks to Dr. Banerjee, sir. Every time I come to this conference, I see that bar has been raised further higher and higher, and I see big, beautiful arrangement here. So the topic given to me is challenging duct strictures in chronic pancreatitis, techniques and outcome. So the issue is real. We see it in day-to-day clinical practice. And as we see that this is a sequence, a result of necrosis, fibrosis sequence, duct get stenosed to the frequency of almost 20% cases of chronic pancreatitis. They have this. We have to rule out malignancy because significant proportion of them may go on to develop malignancy over a decade or two, more so in tropical pancreatitis kind of Indian scenario. So this is a case when I started my practice way back in 2011. I was young, budding very enthusiastic gastroenterologist. A lady with the recurrent abdominal pain presented with this kind of scenario. Lot of calcification in head. On CT, she had stricture in head, and she was getting repeatedly admitted with the pain abdomen and weight loss. So I took upon the challenge. Went ahead, I ruptured my balloon, went ahead with basket, some clearance, ductal clearance, saw an stricture, dilated it and put in the stent. Again, after 2 failed ERCPs, she underwent ESWL 3 sessions followed by complete ductal clearance. For the next 4 years, she was pain-free and then she lost to follow-up. So when we manage these strictures, what are the rules to follow? So first of all, we have to rule out malignancy. The number, size and distribution of calculi is important, and it is important to see whether stricture is single or multiple. And based on these, there are 3 commandments to follow. After ruling out malignancy, we dilate only those strictures we are in head and body. Tail strictures do not respond. And only one single strictures they do not respond. We should avoid dilating multiple stricture. So multiple strictures, extensive stone burden, malignancy goes for surgery. Single stricture in head and body, we can attempt managing endoscopically. So the technique, cannulation followed by passage of guide wire. We need to dilate the stricture. Tools are Sohindra, balloon or buji. The diameter to be achieved is minimum 6 millimeter. Then we leave the plastic stent, usually single, 7 or 10 French with side holes. Then patient goes for stent exchange for 3 to 6 months, and duration of stenting is 1 year. Then we can attempt removing the stent. So what are the results? This is a good compilation by Michael Kalale, published 2018, results of single plastic stent in this setting. So here we can see that immediate pain relief can be seen in up to 95% patient, but this pain relief is not lasting. And on subsequent follow of 24 to 69 months, the pain relief is lost, and only 32 to 68% patient continue to be pain-free. Another problem is recurrence, and by the end of 2-year follow-up, almost 40% of these patients, stricture recurrence is there. So only a portion of patients can be benefited with the single plastic stent. This is recent data. Again, the sun still sets in west. There is no difference. Almost 40% failure rate is persisting. So only a couple of patients we can offer relief with single plastic stent. Failure rates are high. And key takeaways from this slide are that if we leave stone there in situ, if there are remnant stone, then stenosis persists. It leads to restenosis. And even with first use of 10 French stent, sometimes ductal changes can happen. So don't push in too hard that I have to just place 10 French stent only against the resistance, because this will lead to further tissue damage and formation of stenosis. So idea is not to push too hard, but still, having said that, the maximum diameter which can be comfortably achieved, we should achieve. Now, what are the issues with PD stricture management endoscopically? The issues are, number one, pain is multifactorial. There is neuropathic pain, inflammatory pain, central origin pain. So there is not only single mechanism. So pain might persist because of other reasons, not only the stricture per se. Then after stent removal, on 1/4 of the patient, they recur. There is recurrence of stricture. There are issues with the stent associated stricture. And approximately 1/3 of patient can never be made stent free. So these are the issues. And that constitutes challenges in the stricture management. So these are the, I think, challenging strictures, refractory strictures, and then severe strictures where guide wire cannot be crossed across, extreme rectal tortuosity, and extensive stone burden. The other issues, associated problems like leaks, collection, and malignancy are beyond the scope of discussion in this presentation. So we'll stick to refractory stricture and failure to passage of catheter or wire across it. So how do we define refractory stricture? If management with single stent, stricture persists or relapses within 1 year after stent removal, this is refractory stricture. So the definition says that single plastic stent for 1 year. But in practice, sometimes we use multiple stent, and even with multiple stent, if a stricture recurs within 1 year, that also constitutes a refractory stricture. So options are multiple plastic stent. Again, technique is simple. We do pancreatogram, we dilate the stricture, we place side by side stent, and then we wait. So what are the results? In this study, almost 48 patients, refractory stricture, head of pancreas, they were managed with multiple pancreatic stents. And as we can see in the slide, almost 25% had recurrence of pain after stent removal, only 74% remained asymptomatic for long-term follow-up. And there was 7% stricture recurrence rate. So recurrences are there even with multiple stents. Fully covered metal stents. So this is the data. This is the meta-analysis pool of 300 patients. Mean stent duration almost 6 months. Good stent stricture resolution rate, good pain relief rate. Again, problems are de novo stricture formation, stent migration, and other problems. So this is an example of how this stent-related stricture they occur. They usually occur at the end of the metal stent. So another problem. We have removed one stricture, which we have given a second stricture. So though these strictures can be again managed with in similar manner with dilatation and stenting, but that is a problem that requires intervention. Comparison of fully covered metal stent versus multiple plastic stent. Head-to-head trials are not that much available, but this is a basically analysis of metal stent versus plastic stent. This is retrospective non-randomized data analysis. 80 patients equally divided into fully covered metal stent and multiple plastic stent groups. And as we can see here, in this data, the MPD structure resolved better with fully covered metal stent, to the tune of double, means 87% versus 42% plastic stent group. But again, migration and de novo stricture remained a problem. In plastic stent group, up to 35% of the patient, the stent could not be upsized, means it was difficult to go beyond a certain diameter. And only 25% patient we could achieve to pass 10 French stent diameter. So this highlights the fact that these strictures are very fibrotic and hard strictures, and it's difficult to achieve a stent diameter, optimal stent diameter. Now this is meta-analysis of 13 studies, almost more than 200 patients analyzed, multiple plastic stent 100, and fully covered metal stent in 192. This meta-analysis shows that fully covered metal stent and plastic stent results are comparable in terms of pain management, in terms of recurrence of pain, in terms of strictural recurrence. The only advantage of fully covered metal stent, as highlighted by this meta-analysis, was that they are associated with less number of adverse events. So it hardly makes a difference whether you place a fully covered metal stent or plastic stent. Only number of adverse events less with multiple plastic stents. So plastic stents are better according to this meta-analysis. Now this is Indian data. Data from Kolkata, Dr. Goenka group, AIG data on more than 80% its structure resolution rate. Data from the data from large data from AIG, more than 500 patient, structure patency rate of 70 to 75%. And one is an interesting study from PGI Chandigarh, where they could not pass guide wire or dilator beyond the stricture. So what they did, they used cystotome and applied endocut current, and they could pass beyond the stricture and with 100% stricture resolution rate. So an innovative technique to pass non-passable strictures. Biodegradable stent, much talked about and used not very commonly. Archimedes stent is a spiral shaped stent, and LRDV stent is a expandable stent. So Archimedes stent has been tried mostly in post PRCP pancreatitis prevention setting, but in this data, 5 patients, it was tried in pancreatic strictures also, but they didn't look at stricture resolution. They just looked at loadability, pushability, and fluoroscopic visibility of the stent. So we do not know how this stent fares well in terms of stricture resolution. There is some data with LRDV biodegradable stent in refractory pancreatic stricture setting. This is self-expanding stent made of polydioxane fibers, which are degrade with time. So 19 patient refractory PD stricture, 1 year follow-up, and almost more than half of these patients, they have stricture resolution and do not require any further treatment. So this stent works. Laser also are coming in a big way in stricture management in pancreas. So these are the equipment required. You need a laser generator, you need a spyglass cholangiopancreatoscope, you need laser fiber, and what you can do, you just put your cholangioscope after dilatation of PD into the pancreatic duct, and you can give 3 radial incision to the stricture. And these radial cut are of sufficient depth, followed by balloon dilation, so that you can pass the stricture. And after that, you put in the stent, and these are the results. Technical success more than 88% on a median follow-up of 12%, and there was no recurrence of stricture. And this is long-term data of this technique. This technique is called laser stricturoplasty. Technical results, overall success rate 95%, 61% complete resolution, and 83% of these patients were attempted stent-free trial after median follow-up for 6 months and 4 ERCPs. Half of them didn't require any further intervention, but half of them had strictural recurrence and required additional intervention. So laser structuroplasty can be a way to go for those patients with refractory stricture where other measures fail. Now this is simple clinical algorithm: single stricture in head, single plastic stent for 1 year, no response, multiple plastic stents or fully covered metal stent. Those who fail go for surgery. Now, I found a very interesting study. Is there a way to predict which strictures, which patient are going to have pain after stent removal? So this study was published last year, retrospective data, 95 patients, single pancreatic stent for pain was placed, and once patient had pain relief, attempt was made to stent removal. 73 patient stent could be removed, and they were followed up. So total follow-up available for 69 patients for 6 months, and more than half of these patients remained pain-free. 42% had pain recurrence. Then they went on to look at the factor. What are the factors which are related to pain recurrence? They looked at serum lipase, pancreatic thickness, and age, and then they did multivariate analysis. On multivariate analysis, they found that serum lipase more than 44, and pancreatic thickness, which is defined as thickness of pancreas minus duct minus vessel on MRI. So if this pancreatic thickness was more than 14.2, these two parameters have highest correlation coefficient for pain recurrence, and they assigned it 1 point each. And then they subdivided their subset according to stricture recurrences, pain recurrences, and those patients where a mileage level of more than 44, pancreatic thickness in more than 14.2 millimeter, means both of the risk factors present, they had 93% chance of having pain recurrence. So high risk. Those patients who had only one risk factor present, 44%, and zero risk factor, 19%. So based on these two things, my lipase level at baseline or pancreatic thickness, we can predict whether patient is going to have pain after stent removal or not. So they propose this simple algorithm. In case if after stenting we are not able to achieve complete stricture resolution, there is obstruction remaining. In that case, we have to look at lipase and pancreatic thickness. According to that, we can stratify these patients in low risk, intermediate, high risk. Low risk, we can remove stent. Intermediate, high risk would go for either continued stenting or surgery. If we have resolved the stricture, then all risk stent can be removed. So lipase and pancreatic thickness are important. Other challenges, failure to cross guide wire, we have minor papilla to go by. In case if minor papilla is not available, then EUS is the way to go. We can place plastic stent, we can place metal stent. These are the situations. In normal anatomy, if there is failure to calibration or papilla is not reachable or surgically modified anatomy, we can go antegrade, we can go rendezvous. So this is the data on successful PD drainage. Mind it, this is not stricture data. This is success of pancreatic duct drainage, more than 90% VUS, but complication rates are high, so should be done only with experienced operator. And this is my last slide. So management of duct stricture in chronic pancreatitis is challenging because of the reasons we already discussed. Single stricture in pancreatic head or body can be addressed endoscopically. Endoscopic treatment is after ruling out malignancy, single plastic stent, 8.5 to 10 French diameter, should have side holes, 3 to 6 monthly exchange, and then it left for 1 year, and then we have to follow the patient. Refractory strictures, options are plastic stent multiple, covered metal stents, stricturoplasty by laser or cystotome or surgery. Cannulation failure, minor papilla route or USPD, and patient selection again is needless to highlight that this is the key to success for endoscopic approach. Thank you.
Thank you, Abhinav. Excellent talk. One question is how you will differentiate between benign and malignant stricture?
Benign versus malignant.
Yes.
So benign versus malignant, you can look at exact stricture morphology on cross-sectional imaging, whether there is associated thickening and enhancement of the wall, whether there is an associated mass lesion, whether there is displaced vessels, whether there is abrupt cutoff of the pancreatic duct. So these are the situations. Plus you can take help of tumor marker. In case of doubt, you can go ahead with US guided FNA or FNB.
Thank you.
For the really difficult and the challenging strictures that you are highlighting, would it be fair to say that you would offer the surgical option a little bit earlier than going through 5 sessions, 4 sessions? I mean, thinking from your patient's perspective.
Option of?
Surgery.
Option of surgery. So indication of surgeries are clear. If there is extensive stone burden, if there is a structure in tail of the pancreas. So obviously this is if there is associated malignancy, no doubt these patients would go for surgery. But other patient, single stricture, dominant stricture in head region with not that great tumor burden, stone size less than 5 millimeter, smaller stone, then we can go ahead with the endoscopic treatment, because we've seen that endoscopic treatment is not total failure. You can provide pain relief, long-term pain relief in up to 85 to 90% cases. In that case, 9.5-year follow-up study, significant proportion didn't require any reintervention. So endoscopic treatment is available to those smaller stones, stricture in head and single stricture.
Thank you.
Yeah.
If there are no further questions, we have a question.
Sir, first. Yeah.
It's
working. Hello. So I have a very basic question, Abhinav. We have been taught over, at least to me, 4 decades, Dr. Nagi is sitting here, maybe 5 decades plus, that lipase value is nothing to do with the parenchymal inflammation or even the fibrosis. Till now, I was not aware of these studies and the details. Now, if you start taking 44 is very important to us, then I think corporate world will always, and you yourself will always start doing every time a lipase level and try to see. So are we going to take the message from this all that we are going to do a lipase every time we dilate a pancreatic stricture and doing follow-up every 3 months, 6 months? what we are going to get from this hall today, not about the number of strictures, dilatation, what we do a biodegradable, we do a different type of metal stands or plastics, but are we going to do a lipase? What message we are going to take away?
So this is a nice question. This is one odd study. More data needs to come, number one. Number two, every time we dilate the structure, we're not going to do lipase. This is to be done at the time of removal of the stent to predict whether patient is going to have or not. In my mind, what I think sir might comment on this, I would like him to comment, but probably this study is based on the fact if pancreatic thickness is less, means pancreatic atrophy, or if lipase level is less than 44, means pancreatic reserve is not there. Most of the pancreas is fibrotic, and fibrotic pancreas does not pain. So probably those subset of patients who have lipase less than 44 and pancreatic parenchymal thickness is less than 14.2, their pancreas is already burnt out, hardly any parenchyma left. This is fibrotic pancreas. This will probably not pain. Sir.
You can come here. This is working.
Thank you, Abhinav. That was a nice talk. Regarding this particular study, this is a Japanese study published last year in Pancreas. It had a lot of methodological problems in terms of statistics and so on. But ultimately, the outcome is, I think, like you said, lipase itself should not be a guide for us whether should remove the stent or not, because pain, relief of pain after stenting and recurrence of pain after removal of the stent is a very complex phenomenon, not just based on one factor. So this just took these two factors and their statistical analysis had issues. So I think, like Abhinav said, the pancreatic tissue presence gives an indication that if you remove the stent too early, initially before Costa Magna's prediction came that I should put it for 1 year, we used to remove the stents after 3 months. And then these people used to get back their pain very rapidly. So the ultimate purpose was to dilate the stricture to such an extent that decompression is occurring, because in at least 50% of the patients, the cause of pain is because of pancreatic secretions accumulating and producing this. But now we know this is not the full factor. There is also neuropathic pain and all. So I think that's the reason why this study, we should not take it as a whole, but probably look at only the functioning parenchyma. So it's totally atrophic, thin wall, then there's no problem, you don't get back pain. But I think if it's functioning thing, I think we should depend on other factors, and this is just one parameter that they've focused on.
Yeah, Abhinav.
Thank you, sir.
Abhinav, excellent talk.
Yeah.
2-3 questions. See, related to the study. See, what we need to look at conventionally, etiology of chronic pancreatitis, degree of upstream ductal dilatation, degree of parenchymal calcification. These are the factors which indirect tell you that the gland is fibrosed. Chances of pain relief with interductal stenting may not work. Number one. Number two, you talked about algorithm. Why should we follow a single stent for 1 year? If the duct can accommodate more than one stent, wait for 1 year. See, you are trying to dilate the duct. You place as many stents as possible which the duct can accommodate. So the algorithm need to change. Depending on the duct morphology, you take a call, you want to place a 1 stent, 7 friends, 10 friends, multiple, and then try to speed up the process. Why wait for 1 year with a single stent, where the recurrence rate is more than 38%?
Yeah, so this recommendation come from ASGE recommendation. You can put in multiple stents, but only caveat is don't push too hard, because pushing too hard will lead to ductal injury and further fibrosis. Probably that is the caveat. And another caveat is don't just pass the stricture. Don't put stent too deep into the parenchyma so that impedes normal parenchyma. So those two caveats are there. If you can, without any pushing, you can put multiple stents, that can be done.
Since we are running short of time, if there are no further questions, we'd like to wind up this session. Thanks again to Dr. Sharma for an excellent talk.
Now may I request esteemed speaker and chairpersons to please proceed to the felicitation area. We move to our next session, which is on alcohol and pancreas, the toxic trail. To chair, may I request Dr. Sushant Shetty sir, Dr. Swayambhu Banerjee sir, Dr. Shubhadeep Lashkar sir and Dr. Pradipta Guho sir to please come on the stage and start the session introducing our speaker.
Good evening, everyone. So it's our pleasure to welcome Dr. Sunil Dadij for this talk, Alcohol and Pancreas, the Toxic Trail. Dr. Sunil Dadij, please.
Yes, thank you. At the outset, let me thank Dr. Sanjay and the whole organizing committee to give me this opportunity. And I'll take you back to the basics after learning a lot of clinical aspect on how to treat the pancreatic strictures and other. The relationship between alcohol and pancreas is as long as 1978, where it has been first recognized that the alcohol can cause the pancreatic damage. And as we all know, globally the intake of pancreas, the prevalence of taking the alcohol intake is increasing in all over the world, including in our country. The alcohol can cause 4 types of pancreatic disease. One is acute pancreatitis, we all know about. One is chronic pancreatitis. It can also cause pancreatic cancer as well as the diabetes mellitus. So one by one we'll know how it causes the acute pancreatitis. Alcohol-related acute pancreatitis, the prevalence varies from 17 to 25% based on a very large meta-analysis of 46 studies, including 200 and more than 2 million people from 26 countries. In an apprentice trial, which is the alcohol patient registry trial, the India prevalence is reported to be 45%. Among the etiology as acute pancreatitis, alcohol as the etiology of acute pancreatitis, which is highest in the world. I think this study included the 3 Indian centers, AIG, Kolkata, and the PGI, Chandigarh. Only 5% of people who drink alcohol develop the acute pancreatitis. Why? We'll know that. The risk increases with every drink, so there is no safe limit of alcohol intake. It is more with beer and spirits, less with the wine, and smoking is a strong cofactor for causing the acute pancreatitis. Chronic pancreatitis, alcohol is implicated in around 40% of patients with chronic pancreatitis, and high doses of alcohol means the higher risk of chronic pancreatitis. It is a dose dependent. And in a meta-analysis revealed that more than 4 drinks a day for 6 to 12 years have an increased risk of pancreatitis. If you are smoking as well as drinking for a long period, the risk increases by 5-fold. For pancreatic cancers, less than 10% are attributed to the genetic factors. Around 90% of pancreatic cancers are caused by the environmental or the lifestyle-related factors. In a meta-analysis, alcohol is responsible for around 20% risk of causing pancreatic cancer in a patient who drinks at least more than 3 drinks per day for 5 days a week. And there is a linear dose-dependent relationship in men. And this increases by 5% if you are increasing the alcohol intake by 12 grams per day. Diabetes, pancreatogenic diabetes now has become the second most common cause of diabetes mellitus in adults, surpassing the type 1 diabetes mellitus. And it is again a dose dependent. Higher the amount of alcohol, you have a higher chance of developing the diabetes mellitus. And incidence of diabetes after acute pancreatitis is with alcohol as etiology is higher than the biliary causes. And a person with type 1 diabetes, if he drinks alcohol, he is at high risk of developing hypoglycemia and diabetes ketoacidosis. So only 5% of drinkers develop acute pancreatitis with alcohol because alcohol need 2 hits as a model. With first stage is alcohol itself, which sensitizes the pancreas to develop the disease, and there has to be a cofactor, which may be smoking, genetic, diet, or endotoxins, which causes the disease occurrence. So if you know the modifiable risk factors, then you can prognosticate the patient accordingly. The associated cofactors has been many, but the smoking has been the commonest cofactor causing the occurrence of acute pancreatitis and its progression to chronic pancreatitis. Tobacco toxins bioaccumulates in the pancreatic tissue, so even if they stop taking tobacco, there is an ongoing increase in the pancreas and it can lead to chronic inflammation. A person who drinks alcohol
and smoke, the risk of causing acute pancreatitis, chronic pancreatitis, and the pancreatic cancer is higher compared when the person is doing only alcohol or is only smoking. Coming to the mechanisms, before understanding how alcohol produces the damage to the pancreas, we need to know how alcohol is metabolized in the body. Although alcohol is predominantly metabolized in the liver, but it has also been metabolized in pancreas through two different pathways. One is oxidative pathway, other is non-oxidative pathway. With oxidative pathway, there is generation of reactive oxygen species through acetaldehyde and then acetate. And through non-oxidative pathways, there is formation of esters, alcohol, fatty acid esters with the adduct of alcohol and the fatty acids. Alcohol damages all the 4 types of cells present in the pancreas, including acinar cells, ductal cells, beta cells, and the stellate cells. In these acinar cells, alcohol is predominantly metabolized through the non-oxidative pathway, and there are generation of fatty acid ethyl esters. These fatty acid ethyl esters are generated from the conjugation of ethanol with the endogenous fatty acids. They accumulate within the acinar cells and they persist within the acinar cells and causes injury in the form of a premature activation of enzymes and the mitochondrial injury. If you go through the cascade of events, there is generation of fatty acid ethyl esters and the reduction of the redox ratio, generation of oxidative stress that leads to calcium overload, loss of MPTP protein, and the ATP loss leading to cell injury and the premature activation of pancreatic enzymes and the cell death. So there is accumulation of these esters, ATP loss, mitochondrial injury, and the cell loss. Another very important is the co-localization of lysosomes with the zymogen granules. When they co-localize, there is an increased accumulation of activated enzymes within the parenchyma, and there is parenchymal injury. So if I summarize the acinar injuries with alcohol, there is exposure, there is accumulation of these metabolites, and abnormal acinar cell response leading to sustained increase intracellular calcium, co-localization of zymogens with the lysosomes, cathepsin activates the trypsin, and there is amplification and the cell death. In ductal injury, again the pancreas, pancreatic duct manifest alcohol dehydrogenase as well as acetaldehyde dehydrogenase, and there is generation of reactive oxygen species. The normal function of pancreatic duct is to secrete bicarbonate, which neutralizes the pancreatic enzymes and prevent the premature activation of pancreatic enzymes within the ducts. And the injury, there are 3 types of injury: loss of barrier function, loss of cells through the apoptotic loss, and there is a secretory dysfunction by the loss of CFTR, and there is a decreased secretion of bicarbonate within the duct. And that leads to the ductal toxicity, loss of cells, and the impaired bicarbonate secretion, and the outcome is the obstructive pancreatic injury. Beta cells, again, because of excessive alcohol intake, leads to apoptotic injury. They are sensitive to reactive oxygen toxicity as well as hydrogen peroxide. And injury leads to, is mediated by the mitochondrial dysfunction, ER stress, and the acute alcohol intake leads to direct loss of function of beta cells. Effect on alpha cell is not very clear, and the ultimate effect is loss of beta cell mass, dysfunction, and the development of diabetes mellitus and others. The parenchymal pancreatic stellate cell activation and the downstream fibrosis is another very important mechanism leading to the pancreatic fibrosis. With alcohol intake, generation of fatty acid ethyl esters, there is a prefibrotic signaling going to pancreatic stellate cells which become activated, and the activated cell produces the extracellular matrix and lay down the fibers. There are 2 types of injuries. In an activated cell, it will make it immortal and increases the fibrosis, whereas the quiescent cells they die. And the ultimate result is the laying down of fibrosis and the pancreatic fibrosis leading to chronic pancreatitis. So
Once a person develops alcohol-induced acute pancreatitis, a repeated pancreatic exposure, repeated alcohol exposure leads to chronic pancreatitis through the sentinel acute pancreatitis event model, which has got 3 stages: pre-acute phase with risk factors of alcohol, smoking, genetic, and there is a sentinel acute pancreatitis episode, and that progresses on to develop the sustained immune activation, fibrosis, and chronic pancreatitis, and which results in progression from AP to recurrent AP to chronic pancreatitis, and eventually the pancreatic cancer. How alcohol as the etiology is different from the other types of alcohol. From biliary pancreatitis, alcohol causes more severe disease, less number of mild acute attack, higher acute pseudocyst, higher pancreatic necrosis, but there is no difference between ICU and ventilatory care and the circulatory dysfunction. Compared to the severity of disease caused by the hypertriglyceridemia-induced acute pancreatitis, alcohol is the second common cause, and it is higher than biliary but less than the hyper-TG-induced acute pancreatitis. So hyper-TG will cause severe disease, more necrosis, and the recurrence again is similar in both the cases. And the recurrence after treating the etiology with alcohol, it is less, but in hyper-TG it is more. Radiologically, since alcohol causes the severe disease, it will cause more severe damage in the radiology, and it will cause higher grades of injury with more local complications, and the progression to chronic pancreatitis and presence of calcific stones. Compared to idiopathic chronic pancreatitis, alcohol produces higher stones and more calcific disease. Again, when you compare it with idiopathic chronic pancreatitis, alcohol produces higher diabetes mellitus, higher pancreatic stones, higher biliary stricture, but the pancreatic cancer risk is higher with idiopathic acute pancreatitis. So whatever understanding we have on the basic aspects of alcohol and pancreas, do we have any therapeutic potential of these strategies? Yes, we do have. We can target these factors and we can develop the therapeutics. The first is we can target the oxidative stress, and by giving antioxidants, we can prevent the severity of acute pancreatitis, or we can prevent the progression of chronic pancreatitis. Again, we can target the toxic metabolites, we can target the lysosomal impairment, and also we can target the pancreatic stellate cell activation by various ways and means. What is the best way of treating this? First is the best way is to abstain from the alcohol, and others, as we have discussed, we can give antioxidants, anti-inflammatory, calcium channel blockers, and mitochondrial protection. Are there any studies available? Can we prevent alcohol causing the acute pancreatic injury? If you go through the cascade, there are multiple factors, and at each step, we have the experiments going on regarding what kind of therapy will work in that particular step. Similarly, for inflammation amplification, like start from the activating the inflammatory injury and causing the inflammatory response and causing multi-organ failure. There are many number of studies going on in this field. Similarly, for pancreatic stellate cell activation and its progression to fibrosis and development of chronic pancreatitis, there are many steps in that process, and there are many studies going on to prevent the activation of pancreatic stellate cells, laying down of fibrosis, and the development of chronic pancreatitis. I'm summarizing few of them. Like in acute pancreatitis, we have studies going on targeting the inflammation, TNF-alpha, calcium release activating calcium channels. I think the study Indians were one of the centers. And this drug is used for hypercholesterolemia, has been tried for acute pancreatitis, prevention of injury. COX inhibitor, we all know about it. And the pancreatic lipase also being studied for the prevention of acute pancreatitis. Similarly, for chronic pancreatitis, for blocking IL-6, we have a tocilizumab study going on. The circulatory inflammatory mediators using the dietary soy isoflavins going on. And then we can target the oxidative stress to prevent the progression of chronic pancreatitis. So, ladies and gentlemen, alcohol is the most important contributor of pancreatitis-related diseases. Only minority of heavy alcoholics develop the disease because of, and it needs a second head to develop the disease. And alcohol, its metabolites, they damage the pancreatic acinar cell, ductal cell, islet cells, and with the activation of stellate cell, which play a major role in development of chronic pancreatitis. And alcoholic pancreatitis fares worse than other causes of acute pancreatitis in terms of recurrent, short and long-term complications. And we do have potential therapeutic strategies in many forms to reduce the occurrence of the pancreatic inflammation, its progression, and further complications. Thank you very much. Mike.
At the outset, I'd like to thank you for the excellent delivery of this difficult topic. I would just ask one question to you. What is the interplay of different factors? Is the type of alcohol important, or it's the genetic component, or what is most important in the development of alcoholic acute or chronic pancreatitis? Because as you said, there is no definite relation with the dose of alcohol.
Yes. No, with dose of the alcohol, I have already said. So there are three types of things. One is the type of alcohol. So beer and spirit cause more damage than the wine. That is number one. Second, alcohol injury is dose dependent. Higher the amount of alcohol, higher the duration of alcohol, there is more damage. Two. Three, alcohol alone does not cause the disease, because out of 100 people drinking alcohol, only 5% will develop injury. And so it needs a cofactor. That cofactor may be in the diet, maybe in the genetics, or maybe in the form of smoking. And smoking is the commonest cofactor with alcohol. If you have both smoking and alcohol, the risk increases by 5-fold.
Yes.
It alone cannot. It
Yes.
needs a gene.
Yes.
Likewise, in alcohol also.
Yes, there are many studies. I think,
Uniformly, gene is also studied.
yes, there are many studies. And like, I'll tell you typical
So,
clinical...
whether it is gene causing or alcohol is causing pancreatitis? Or both causing?
I'll tell you typical clinical phenotype. A 25-year-old male comes to you with acute pancreatitis. He has a history of alcohol intake, only social drinking, only for last 2-3 years. And he is developing repeatedly acute pancreatitis following the alcohol intake, or even after stopping the alcohol intake. So you cannot make alcohol as the causative factor in that particular patient. And when you do genetic analysis, so this patient has got a genetic mutation which make him prone to develop pancreatitis following alcohol intake. So,
Thank
so
you.
there is
Doctor,
alcohol
to check
and there
genes
is-
before drinking alcohol.
Yes, yes, yes.
Do you suggest to check the gene before drinking alcohol?
Before drinking, I don't
Before drinking alcohol.
Sir, I think there are mutations or polymorphism in the NADPH oxidase or oxidative enzymes,
Yes.
which are responsible for predisposition to alcoholic pancreatitis.
Yes, yeah, there are many mutations which are responsible.
So it's a combination of both. Thank you, Dr. Sunil. Dr. Sanjay is asking to stop. And thank you, my co-chairpersons and audience for introduction. Thank you, everyone.
Speakers and chairpersons to kindly proceed to the felicitation zone. Now we move forward to the next session, which is on pancreatic cyst. To chair this session, may I request Dr. P.P. Bose sir, Dr. N.P. Bohidar sir, Dr. Avinav Sharma sir, Dr. Devottam Bandyopadhyay sir, and Dr. Deepak Shah sir to please come on the stage and start the session by introducing the speaker.
Yes, so I welcome Dr. Sukrit Sood for his presentation. He is working in Medanta and he's an experienced endoscopist and academically oriented orator.
Thank you for the kind introduction, Dr. Sharma. So today I'll be going through the role of EOS in pancreatic cystic lesions. I'll be omitting the role in pseudocysts because that's a whole different topic. A little bit has been touched upon by Sonmoon, so there might be some repetition, excuse me for the same. So we know PCLs are detected in around 14 to 50% of adult patients across different databases. Problems we have already discussed, unnecessary surgery and missing malignancy where we need to operate. So the progression of pancreatic cyst to cancer, we understand they might be all pancreatic cysts, out of which 2/3 you see may be cystic neoplasms, and 90% would fall under these four categories: IPMN, mucinous cystic neoplasm, serous cystic adenomas, and SPEN. A 0.25% only will have invasive cancer upon diagnosis, and the same percentile of invasive cancer per year will increase in these pancreatic cysts during annual follow-up. So across the different guidelines, with the recent one being IAP in Kyoto 2024, the indications are pretty straightforward for putting an US scope when they are referred to you. A size of the cyst upwards of 3 centimeters, dilated MPD that is at least 5 millimeters, or an abrupt change in MPD caliber with upstream atrophy, or solid component or mural nodule. So all these guidelines have shown that an increase in size, you can take it at anywhere between 3 to 5 millimeters per year is adequate to put in an US scope for the same. And clinical features are most important when a patient presents with extrahepatic jaundice, pancreatitis, significant lymphadenopathy, and increased CA19-9 levels. What are the main questions? Is your cyst that you're seeing malignant? What type of cyst are you dealing with, broadly mucinous or non-mucinous? What is the risk of future malignancy on follow-up? So EUS morphology is pretty thought to be pretty accurate, still fails you half of the time. There's very low inter-observer agreement for diagnosing different types of cysts when you see them on EUS. Based on EUS, there are worrisome features which have been defined in these guidelines. So it means a size of more than 3 centimeters has an odds ratio on 62. Mural nodules, odds ratio is very low. MPD dilation, again, odds ratio is low. But a septal thickness of 2.5 is the lowest. So how do we find a mural nodule? How good are we in detecting these? We are not good at all. We'll miss 50% of them or we'll misclassify them. Sensitivity is around 75%, specificity is around 80%. On US, CT is poorer still, sensitivity of 47%, specificity is in the higher 80s. So common problem that endocrinologists face when they think it's a mural nodule is to separate it from what is a mucus plug or a mucus globule. A mucus globule by nature will be hyperechoic in the center, smooth edged and with a classical hyperechoic rim. A mural nodule will be merged to the wall, will not be smooth edged, will not move with gravity change, and there will be no hyperechoic rim. So can we detect these better? Of course we can. When we start using contrast enhanced US, using SonoView, which runs in short supply in India sometimes, but when we start doing these, we find that you're able to inject contrast in vivo on the table, and the vascularity of the nodule will be seen, the septa, the cyst wall, everything will light up, and this will certainly differentiate it from a mucus plug. So US FNA pretty straightforward. Always we try to drain the entire cyst with a 19G or a 22G needle. Ideally 19G is preferred. Target the nodule or the solid component once, either when you're able to avoid the cystic fluid or you have drained the cyst completely. Assess for string sign on the slide. Do a cyst fluid glucometry on table. This is pretty accurate. I'll be coming to this later. Send it for CA level, amylase level, and potentially if available, KRAS and GNAS should be sent as well. Always give a single shot of prophylactic antibiotic when you're doing this procedure. So this is the table we are all pretty familiar with, separating mucinous versus non-mucinous. We know the morphological criteria. Usually mucinous are single. IPMNs can be multiloculated. And location, again, body tail is usually MCN, should be operated straight away. And the others can be anywhere. Viscosity by the string sign should be assessed. CA levels, a cutoff 192 has been shown to be pretty specific. Glucose are below 50 in mucinous and around similar to the serum levels in others. And again, cytology should be sent. Usually we don't aspirate a lot of fluid from a lot of these relatively smaller cysts. So malignant cytology should be sent where available. So again, these cyst fluid analysis separately, they don't do much. Morphology is only 50% in accuracy. String sign, again, very specific. Cytology, again, 63% sensitive. Cyst wall cytology has only 30% improvement in diagnostic yield. But a CA cutoff of 192 has shown to be pretty sensitive and specific as well. But CA does not distinguish between what is malignant and what is benign among mucinous cyst. So this was a study done in 2005 where they studied cyst fluid analysis of CA level. A higher cutoff was proposed after this, will improve your specificity but further decreasing sensitivity as expected. Then came with simplifying things. A cyst fluid table glucose would found to be much more accurate than CA to achieve this. And cyst fluid glucose of below 50 compared to a CA cutoff 192. We have also in publication a similar study currently from our unit, but no benefit to CA plus glucose versus glucose alone was found. So glucose alone does the job pretty well, as shown by this data. So this 50 cutoff came from this study where it showed a 93% sensitivity and 76% of specificity. So what is the impact of this data? We know IPMNs are 53 to 70% will have low-grade dysplasia, and 22% of all these that we find will be benign. So we can obviously avoid unnecessary surgery where possible. And identifying these mucinous variants, these genetic analysis, the molecular markers, GNAS, KRAS, and BRAF have shown to be very sensitive and specific. Specificity is 100%. So where available, this is now the standard of care. For serous cystadenoma, again, we don't send these in our unit, but VHL has shown to be low sensitivity but high specificity for determining serous nature. So this we have already gone through earlier, the worrisome features, the high-risk stigmata and as per the Fukuoka criteria, slight modification as per the Kyoto consensus a couple of years ago. And the US criteria, again, cyst wall thickness of more than 3 millimeters, enhancement of the septa, interductal filling defect, vascular nodule, CA more than 800, KRAS positive or P53 mutation, and a CA showing an increasing higher trend. So these earlier guidelines recommended US when at least one worrisome feature is present, but whenever there is a high-risk stigmata, please send the patient to the surgeons there and then. So I think I can skip through the data. This is basically showing across different guidelines their particular high-grade dysplasia and cancer detection rates have been comparable, but IAP actually outperforms. And now with molecular markers, with SMAD4, P53, mTOR gene et al., this has now all the guidelines take a back seat. This will be the most likely to make a positive diagnosis. So beyond this, now we know that IPM and MCN will have commonality of KRAS, BRAF, GNAS, and P53. Others are still experimental as of today. And when we move beyond just the cyst size, we are now entering the level where we are studying telomerase levels, the MUC proteins, and aneuploidy in these patients, and the cyst fluid. Then came the era of using through the needle microbiopsy forceps, the More's forceps. It has issues like causing pancreatitis more frequently. The basic role is to go through the cyst and sample the cyst wall. Sample adequacy across data is around 85% with diagnostic accuracy around 80%. Sensitivity in the lower 80s and specificity in the higher 90s could be found. Then we have touched upon something called the confocal laser endomicroscopy, again through the US 19G needle. So these are the kind of images that you see. You get a superficial vascular network, and akin to how NBI shows us images on endoscopy. And again, very high specificity, but sensitivity is again relatively low. And IPMN though, this outperforms other ways of other imaging modalities with a very high sensitivity as well. Then the therapeutic part of US. We can now ablate a lot of these cysts. These are usually not very old patients who can't even undergo surgery, because in those patients the risk of malignancy over the remaining survival period may not be very high to merit any therapy whatsoever. These are relatively younger patients who have other comorbidities and may not be fit for surgery. So the basic rationale, as like other ablation procedures, to destroy the cyst columnar epithelium to prevent malignant transformation in the future. Patients should be selected as solitary MCNs or branch duct IPMN. Which are unfit for surgery. Usually cyst size should be less than 3 centimeters, but with other worrisome features. Technique, either we earlier used to only ethanol, now we combine ethanol with paclitaxel, this is called the ELP, and we aspirate the cyst fluid completely via 19G US needle, inject about 90% ethanol and irrigate 3 to 5 minutes, and then re-aspirate all the ethanol and then inject paclitaxel 3 mg per ml and leave that in situ. Outcomes have been found to be an ablation rate anywhere from 50 to 80%. Then came the US RFA needle. Currently India with the StarMed needle for this. Again, for cystic NETs, we have data emerging. We have to again aspirate all the cyst fluid and ablate only the cyst wall to get better response. Problem is visualization on active RFA. You may not be able to totally visualize adequacy of ablation, which has to be then followed up after a month with the dynamic MRI pancreas. And incomplete ablation is a major problem with these complex cysts and need follow-up. It's not yet the standard of care, but can be an option in the future. So again, Sonmoon has gone through the guidelines. Basic concept we should remember when we follow up these patients, if they are symptomatic, be it for jaundice, be it for recurrent pancreatitis, I think surgery should be strongly considered. If there is associated mass, again, the surgeon should come into the picture pretty early. Consider surveillance also over a long term, because it's a pretty money intensive process over the years and time intensive as well. If the patient is a surgical candidate to begin with and is also willing for surgery, and if the patient willing to undergo any systemic therapy found to have a malignancy. So across the different guidelines, the indication of surgery is similar, but the basic outline is that if these the high risk stigmata is present, and then the patient should be sent for surgery. When you're not operating, you want to do surveillance. So previously, MRI, MRCP was the only thing which was recommended in the earlier guideline. Now EUS or MRI is being told to have a role in lesions which are between 2 to 3 centimeters, which have to be seen 3 to 6 monthly. And those which are more than 3 centimeters, again, US is the preferred modality, again, every 3 to 6 months. So basic limitations of US we have discussed, that where the observers, the experience is not great, again MRI would be the way to go. Do not undergo surveillance for all your patients, especially if they are not surgical candidates. If you are planning a surgery already or any systemic therapy, or the cyst has been stable for at least 5 years, then they can stop surveillance, or the patient life expectancy is not more than 10 years as per the other comorbidities, and the cyst is confirmed as a serous cyst, then please do not even do an US again. Despite differences, basic approach is quite similar. Evaluate them for surgery if there's a dilated duct, there's an enhancing nodule more than 5 mm, there's a mass, or you have a positive tissue or fluid. So thank you everyone for your patient listening. I'll be open to any questions from the house.
So cystic lesion you've diagnosed, you've ablated, patient is unfit for surgery. So how to follow it up? What are the recurrence rates, what are response rates, and how to follow?
Ablation still, be it chemical ablation, that is chemotherapy, paclitaxel based, or RFA, ablation rates are not up more than 80% in the data that's been reviewed till now. So I cannot say it's the way to go yet at all, but if you have ablated, then I think the follow-up should be similar to any other patient who has had a more than 3 centimeter cyst to begin with. So I would say 3 to 6 monthly.
Excellent talk. If there are no questions, in that case, since we are short of time, we would like to wind up.
Thank you.
So thank you, respected speaker and chairpersons, for the excellent session. So we move forward to our next session, which is a panel discussion on pre-operative and post-operative optimization of pancreatic cancer patients. To moderate this session, may I request Dr. Sandeep Pal sir to please come on the stage. Our esteemed panelists for this session are Dr. Kunal Das, Dr. Pankaj Singh, Dr. Nikhil Sonthalia, and Dr. Kishalaya. Requesting all the esteemed panelists to please come on the stage, and over to moderator Dr. Sandeep Pal sir.
So good evening. First of all, I would like to thank Sanjay Da for the invitation. So this is a surgical topic. The topic is pre-operative and post-operative care of pancreatic cancer patients. So unfortunately, we don't have any surgeons on the panel. So all are gastroenterologists. And Nikhil is sick. So we have 3 panelists for this discussion. So these are my esteemed panelists. So we know the clinical reality of pancreatic ductal adenocarcinoma. The prognosis is very dismal, and unfortunately only less than 20% of the cases are diagnosed early. So most of the cases that we diagnose pancreatic cancers are all diagnosed late. And around 50 to 55% of the patients are diagnosed when they have already a metastatic disease. So care for pancreatic cancer patient is highly multifaceted due to the aggressive nature of the disease and invasive surgeries involved. So while preparing this topic, I have come across this ERAS protocol. So this ERAS protocol has been published in 2019, and this shows for all abdominal surgeries, this protocol is followed, and this has got a 27-item clinical pathway for enhanced recovery. And this has really brought a change in the care of these patients, any patients who undergo surgery, and also pancreatic surgery. So if we follow the curve, the physiological stress, if you see in the curve, so whenever we implement this ERAS protocol, there is quite a decrease in the level of physiological stress, both preoperatively, intraoperatively, and postoperatively. And it has got a proven efficacy. The systemic implementation of this ERAS protocol, it reduces the medical complications, it shortens the hospital stay, and decreases overall healthcare costs. So this has got, as I said, some 27 items. So here today we will discuss about the pre-operative optimization and the post-operative recovery. We won't discuss the intra-operative defense because that is up to the completely a surgeon's domain. So I'm not going into that. So first my question would be, Nikhil is not there, so I think Dr. Kunal will take this question. So how do you optimize your patients pre-operatively? Whenever you see a patient and diagnose a patient of pancreatic cancer, and if the patient is if surgery is possible, how do you counsel these patients and how do you rehabilitate these patients?
This is a very important topic. So the first important is the brain. So we have to use a pre-operative counseling medication. We have to do a muscular rehabilitation and also look at the lungs and the liver item toxin cessation, which means that patient has to stop smoking at least 4 weeks, as well as the high alcohol intake patient should also abstain from alcohol. So these are the more important points.
So exactly. So because this is a big surgery, like whenever Whipple surgery or whatever the pancreatic surgeries the patient undergoes, so it is very important to counsel the patients pre-operatively, as well as to reduce the stress. You can use some medicines for them like stress, some anxiolytics, and also this patient should be advised to stop alcohol as well as smoking. And this is one most important pertinent as a gastroenterologist and as we do ERCP. Whenever we get a patient of obstructive jaundice, we have a tendency to do ERCP. So these patients who are operable, should we do ERCP? So Dr. Pankaj, what do you think?
I think pre-biliary drainage is not required in all cases. For this, I would like to quote a very landmark trial, DROP trial published in NEGM 2010. In that, they have clearly shown and compared the early surgery group versus pre-op biliary drainage, and they have concluded that pre-op drainage is only required if the bilirubin level is more than 15, if there is acute cholangitis, if the patient is contemplated for neoadjuvant chemotherapy, or if there is intractable pruritus. So these are the indications only when you need to go ahead with pre-op drainage. Otherwise, if the surgery can be done within 1 week, and if there is no cholangitis, no bilirubin higher than 15, you can go ahead with surgery directly. And regarding the method of drainage, still I believe that ERCP is the first line of method which can be used for pre-op drainage, and when feasible, if there is some technical challenge or there is altered anatomy, then obviously yes, we can choose between PTBD versus US guided drainage. There is always a debate between the two. But if technical expertise is available, I think in centers where we have expertise, US guided biliary drainage can be a second line option. And if that is not feasible, then PTBD can be the alternate option for that.
Exactly. And the other thing that is important is what is the stent type. So whenever we do biliary drainage, should we put plastic stents or metal stents?
So we can choose between plastic versus metal. Of lately, the latest retrospective studies by Adam and Tamura et al., they have shown that metal stent is slightly better. But yes,
short metal stent.
Short metal stent, fully covered short metal stent is slightly better in terms of decreased stent blockage related complication. Decrease hospital stay and overall and with overall surgical outcomes stays the same as the plastic stent.
Yeah, and always we should remember to take bile cultures in this patient. So whenever we do ERCP as a pre-operative drainage, always we should take bile cultures. And this is the study which you have spoken of. This was published in NEGM. Landmark trial was published by the Dutch Pancreatitis Study Group in 2002-03, where they have shown that if you do pre-operative biliary drainage, then the complications are more rather than doing an upfront surgery. And these are through other Cochrane reviews which also showed the same thing. There is no that explored RCTs on percutaneous transhepatic biliary drainage and 2 on endoscopic stenting. There is no difference in post-operative mortality, but morbidity rates were higher in pre-operative biliary drainage. So we should not do it. So this is one takeaway from this discussion. Like all patients that we get, unless the bilirubin is more than 15, we should not do ERCP in this group of patients. And this is also Pankaj had spoken of about the type by which you want to do preoperative biliary drainage. If ERCP is feasible, that is the best. But if ERCP is not feasible for some reason, you can do PTBD or US guided drainage. Now coming to the next question, which is another very important aspect of these patients, is how do you nutritionally optimize your patients preoperatively? Dr. Kunal?
Yeah, I think this is very important. We all know that pancreatic cancer patients, they have cachexia, they have low appetite. So we have to, lot of nutrition factor should be there. So severe weight loss nutrition has to be there, and we must load them with carbohydrates and also have a shortened fasting, especially limited to 6 hours for solids and 2 hours for clear liquids. Also, it is important that routine use of immunonutrition should be avoided. In fact, arginine, glutamine or omega-3 is not recommended due to high study heterogeneity and bias. And routine nutrition not warranted for patients without severe weight loss. So if the weight loss is there, then you should load the carbohydrate, shorten the fasting issues.
So exactly. So these patients, if the patients are like nutritionally deprived, then you can give them preoperative nutrition to increase their weight. But this routine immunonutrition and all this has got no role. Then coming to Dr. Kishalaya, like preoperative medications, like this group of patients, because as you know, they are sick, they are on one hand, they are maybe jaundice, they have pain. So what are the routine pre-anesthetic medications you would like to advise these patients?
So because of the known side effects of opioids, which can impair the post-operative recovery, the pre-operative period and the post-operative period, we should always have an opioid sparing approach. All of these patients should be started on thromboprophylaxis with either unfractioned or low molecular weight heparin, which should start at least 12 hours before surgery and for up to 4 weeks post-operatively. Antimicrobial prophylaxis is indicated in all. The first dose should be within 60 minutes of incision. The choice of antibiotics should be as per the antibiogram. Further doses can be given depending upon the half-life of the drug and the surgical duration. And as I said, for pain control, intraoperatively and postoperatively, the mid-thoracic epidural anesthesia should be the procedure of choice because of its inherent benefits, which I think we'll discuss later.
So this is about pre-operative. Now coming to the post-operative care, as Nikhil is not there, I think Pankaj will take the question. Like in the immediate post-operative care, what analgesics should you prefer for immediate post-operative care?
Still, I believe thoracic epidural is the first line of analgesia, but there are other options like continuous wound infiltration catheter, PCA drip, which is a patient-controlled intravenous infusion, and intrathecal morphine can also be used. So these are the methods with which we can control the pain, in addition to intravenous paracetamol plus minus NSAIDs as and when required. But there are latest studies which says that continuous wound infiltration is not inferior to thoracic epidural as of now, and there's a Pacman trial who also says that PCA drip is also not inferior to thoracic epidural. This is the latest changes that has been happening of lately.
So another important thing is, along with pain control, you should also give importance to the post like nausea and vomiting, because this group of patients, because of continuous infusion of opiates or other analgesics, they usually have a post-operative nausea and vomiting. For this, prophylaxis has to be given. So either, so there are certain risk factors, like if the patient is a female non-smoker or motion sickness history or history of opioid use. So any patients who have more than 2 or more risk factors, they usually require more than 2 antiemetics. So if the antiemetics also don't work, sometimes there is a role for dexamethasone also in this group of patients. So yes, because they usually have a severe pain, this group of patients after surgery, thoracic epidural analgesia is the way to go, but there are other options also like continuous wound infiltration and intravenous opioids. And about this continuous wound infiltration, these are the 2 studies which have shown that this is even maybe better than thoracic epidural analgesia. And these are the 2 trials that I got while going through the literature. This is the Pacman trial, which showed that the gastrointestinal complications after pancreatoduodenectomy with epidural versus patient-controlled intravenous analgesia. So all throughout this, we have known that these patients are always on thoracic epidural analgesia, but even patient-controlled intravenous analgesia is not inferior to thoracic epidural analgesia, if not better. So all 30-day mortality, post-operative pain, or intraoperative and post-operative fluid requirement, all these have been shown, these parameters were studied, and that has shown that these are all equal. And these patients who were in this PACMAN trial, they have been followed up, and this trial was published in 2025, which showed that the long-term follow-up of these patients also showed that PCIA, that is patient control intravenous analgesia, has got equal efficacy as of epidural analgesia. So these are the two things. This already we have discussed. One is epidural analgesia, this wound, continuous wound infiltration, and all these patients should be on post-operative nausea and vomiting prophylaxis. So this is the ladder which we can follow while treating these patients of pancreatic cancer patients. If there is mild pain, moderate pain, and severe pain accordingly. Mild pain, usually paracetamol post-operatively, paracetamol or ibuprofen can take care. If there is moderate pain, you go to the weaker opioids, and if there is a strong, like severe pain, then the stronger opioids are required. Now, another important thing is these patients, because they undergo a long surgery, there is a chance of development of post-operative ileus. So my question to Dr. Kunal is, how do you manage these patients? Like how do you manage post-op ileus in this group of patients?
This is a big problem and we have actually avumopan, which is not available in India, but we can use the methyl naltrexone component, which can be useful. And sometimes it has been shown that chewing gum can use, but so we can use mozapride and also disopride, which has weak evidence, but potentially it can be useful. But the other things which are ineffective are metoclopramide, bromopromide, or erythromycin and neostigmine are not useful.
So yes, levosulfide, etopride can be used, or we can use this methyl naltrexone, which is a peripherally acting mu receptor antagonist that helps in increasing the bowel, like decreasing the bowel ileus. So now again, this group of patients, they have a lot of, after the surgery, they have some post-operative tubes and drain placed. So how do you manage? Sometimes when there is and continuous output, so there are certain like guidelines what to follow. Dr. Pankaj, would you like to take?
I think all of these patients, they will have intra-abdominal drain, and the concern is regarding the fistula. So we need to see the fluid amylase level on day 1. If the amylase level is less than 5,000, it is a low risk case and we can remove the drain as early as post-operative day 3. If the amylase level is more than 5,000, we need to keep the drain, and we need to keep on monitoring the fluid amylase level on day 3, day 5, day 7. And if it is still persistent, then we may have to consider the possibility of post-operative pancreatic fistula. Regarding nasogastric tube, now the recommendation is that we need to remove it as early as possible, and preferably on post-operative day 0 or 1. And regarding the Foley's catheter also, we need to remove as early as possible, day 0 or day 1, or as soon as the patient is ambulant. Regarding the IV fluids, we need to maintain a tight glycemic control and also the fluid balance, which is very important, and avoid overloading the patient also.
Exactly. So these are the like post-operatively, you have to take care of this. Coming to the next question, like again, what can we do to enhance or get back the gastrointestinal function after surgery? This is partially, this was, Dr. Kunal has answered this. So is there any other thing which you can do?
Sir, I think the key is to mobilize the patient early, to start enteral feeding as early as possible, and third is to be vigilant about delayed gastric emptying. If the patient is continuously vomiting for more than 3 days, or if he cannot take out the tube Ryle's tube for more than 3 days, it indicates underlying delayed emptying. And most of these are due to leaks and abdominal infections. So we should be vigilant for that and treat them, because unless we treat them, the emptying is not going to improve.
Exactly. So, and another important thing, till now we see that these patients who have this persistent pancreatic fistula or drainage, somatostatin analogs, and these things have been used. So these guidelines say that somatostatin analogs, they don't have any use in these patients who have persistent drain. So we should avoid using this. And regarding this also, we have touched upon, see, those post-operative artificial nutrition. So as early as possible, the patient should be started if the patient is awake, and should be started orally. And patient also should be advised for scheduled mobilization as early as possible. And the laparoscopic pancreaticoduodenectomy only in highly experienced high volume centers and certain centers which are doing robot assisted pancreaticoduodenectomy. We don't have much data in this group of patients, but whatever this ERAS protocol says, that as early as possible post-operative nutrition and early mobilization should be done. Now this question is like open to all the panelists about the long-term recovery and the quality of life, because you know these patients, they undergo pancreatic resection, they are prone to develop certain complications like pancreatic exocrine insufficiency and as well as pancreatic endocrine insufficiency. So So what do you, like, how do you diagnose this, and do you start all patients on PERT, pancreatic enzyme replacement therapy, or do you test and then you start?
Those are patients who have undergone pancreaticoduodectomy, they should be started on pancreatic enzyme because there are multiple factors by which this occurs, loss of functioning parenchyma and loss of endopancreatic.
Do you like to
reflex.
test for anything, or you just start these patients on?
I think so. We should start these patients on pancreatic enzyme because most of the prevalence of PEI is very high in these groups of patients. And the tests that we have at our hands are most of the tests for secretory function, not the digestive capability of the pancreas. So they should be started on PERT.
So if you see this table shows all the studies that have been published till date. So the post-operative incidence of PEI, this pancreatic exocrine insufficiency, ranges from around 50% to 80%, and a few studies around 100%. So since more than 80% of these patients develop pancreatic exocrine insufficiency, I think it's a good idea to start these patients on pancreatic enzyme replacement therapy. And the dose, we know, you can start at 40,000 for thrice daily, and even if the patient is still symptomatic, we can start with snacks also around 10 to 15,000 units. And also, along with this pancreatic exocrine insufficiency, of course, these patients will have diabetes also, the type 3C diabetes that develops in this group of patients. So this group of patients require insulin therapy, and also some pancreatic patients, like because they undergo pancreatic cancer surgery, in consultation with the medical oncologist, these patients might require adjuvant chemotherapy also. So this also comes under routine post-operative care. So this is the last slide, I think. So, so what we knew, there are some historical things that we have been continuing. Like any patient we get jaundice, even the patient is operable. Usually, it's like in many units we still do ERCP. So that we should not do. We should avoid ERCP in any patients who present with jaundice unless the bilirubin is more than 15. This is the key takeaway from this panel discussion. And this nasogastric tubes also, you remove it as soon as possible. Routine maintenance until bowel function returns. If the patient bowel function returns and the patient is awake, it is a good idea to remove the nasogastric tubes. Routine administration of oral immunonutrition is also not required. You have to stop. No proven benefit in this group of patients who undergo pancreaticoduodenectomy. And somatostatin analogs, the systemic used to prevent fistulas, this is still being practiced. So this also has to stop. There is no evidence to suggest that these somatostatin analogs, they are of any help in this group of patients. So a well-implemented ERAS protocol with good compliance is associated with a reduction in medical complications and length of hospital stay in this group of patients who undergo pancreatic surgery for pancreatic cancer. Thank you. Now I would like to get opinion from sir and other about is there anything, if there is anything other thing we can do in this group of patients, and especially if there are any surgeons here, because we are all medical gastroenterologists and we discussed a surgical topic. So if there are any surgeons, if you would differ or make some newer comments. Thank you.
Okay, thank you.
Thank you, esteemed speaker and honorable chairpersons. Now I request all of you to please move to the felicitation area. Now our next session will be on endoscopy in management of pancreatic cancer, the expanding role. To chair this session, may I request Dr. D. Nageshwar Reddy sir, Dr. Mallika Bhattacharya madam, Dr. C.R. Panda sir, Dr. Shurmul Mohapatra madam, and Dr. Sunil Davij sir to please come on the stage and start the session. The speaker for this session is Dr. Mahesh Kumar Goenka sir. He needs no introduction, requesting sir to please come on the stage, requesting the chairperson to please start with the session.
Okay, I think Mahesh, of course, doesn't require any introduction to the audience. He's done pioneering work in all areas in gastroenterology, especially GI endoscopy. And I think this is a very important area because the role of endoscopy in pancreatic cancer is rapidly expanding. So Mahesh?
So I'm happy that the talk is now only for 15 minutes and I'll try to finish it in fast because we have another very important talk by Nagi after this. So I think the role of endoscopy in pancreatic cancer is expanding, often at the expense of intervention radiologist and the surgeon, but also within the platform of endoscopy, I think it's moving from the conventional endoscopy to EUS. So I think I'm not the best person to talk about it. I can see a number of experts of EUS on the dais as well as in the hall. So I'm not going to get into technologies, and I'll just talk about some of the concepts. So I think endoscopy in pancreatic cancer is important for diagnosis to the extent of local spread, as well as for histology, which we can achieve at EUS, ERCP, and cholangioscopy. But I'm not going to talk about the diagnosis at all today because of the shortage of time, but I'll talk primarily about the treatment aspects, where I think the endoscopist plays a role in the management of jaundice, for the pain relief, for gastric outlet obstruction, and some emerging role in local endotherapy. So jaundice due to the bile duct obstruction is the very important component of the management of CA pancreas, and the two main endoscopic platform are ERCP and EUS. So ERCP we've been doing conventionally for a very, very long time, 4 to 5 decades, and there's nothing new about it, that you get the guide wire into it and then put a stent. But what is now decided for certain that plastic stent has no place in the management of carcinoma pancreas, and whether for whatever indications we are doing, we usually prefer a metal stent, and we decide whether it will be fully covered stent or uncovered stent. So EUS BD is now there. There's no doubt about this, and it is increasingly being used in all centers, including our own center. We have a very active EUS program, and this you can see one of the cases where there is infiltration of the first part of the duodenum, and so we went ahead and did an EUS guided colorectal which is the commonest way in which we do the biliary drainage at EUS, and you can see lamp being placed here, and then it will be opened up, and then the drainage is achieved. Now, the other technique of doing EUS biliary drainage are EUS integrate stenting. This is less commonly done at our center, but this is another technique in which you approach, again in this case there was infiltration in the first part of duodenum. We could not do an ERCP, as you can see there was complete narrowing there. And so what we did is that we passed a guide wire through the segment 2 on the left lobe of the liver, and then approached and put a stent through the integrate route. As you can see, the other ways of doing biliary drainages are hepaticogastrostomy, where you achieve a drainage between the stomach and the left hepatic duct. And some cases we do rendezvous technique, as was in this patient with large periampullary diverticulum. In spite of my best attempt and doing everything possible, I could not achieve cannulation, and then a guide wire was passed to the bile duct, and it was retrieved in the duodenum, and then rendezvous technique was done. A technique which we do not use routinely but is emerging as an important technique is the EDGE technique, or US directed transgastric ERCP after a bariatric surgery and a gastric pouch. You can re-establish the connection between the pouch and the remnant stomach by the EDGE technique, and then you complete the procedure by establishing the contact between the communication, and then dilating that by balloon, and then either in the same sitting or usually in the subsequent sitting you pass the ERCP scope and then complete the ERCP. And this has been found to be better than laparoscopy assisted ERCP. So the stents for the EUS BD, when you are using CDS, we mostly use either a fully covered stent or more commonly a lamp stent. But for HGS, it's partially covered stent with a length of 8 to 10 centimeters. Some part is uncovered and some is covered. So between the US and ERCP, the factors to be considered is of course cost and expertise, but more important is whether you're doing it for palliative technique or a preoperative technique, or whether the papilla is accessible or non-accessible. In a case like this, when you are doing a preoperative biliary drainage, and we just talked about it, as in cholangitis, intes pruritus, delayed surgery, I think a preoperative biliary drainage is still being done. And a real-time scenario, whatever we may talk within the hall, is that more than 50% of the patients in US database received preoperative drainage before a definitive surgery was done. In this case, with cholangitis, will definitely benefit from a preoperative drainage. Till today, there is no role for US BD in a preoperative drainage. Is not established and not supported by any strong evidence. So when you are doing a preoperative biliary drainage, it's ERCP first. What about accessibility to the papilla? Very clear, if there's a non-accessible papilla for whatever reason, EUS today is the modality of choice, and only if it fails or it's not possible, you can go for enteroscopy or EDGE technique. The main debate is accessible papilla, and I know Dr. Praveer Rai is here in the hall. Then the debate is between EUS and ERCP, which should be the first one. Now, so the debate continues, and there were two meta-analyses published about 1.5 years back in two prominent journals, Endoscopy and GI Endoscopy. This is an endoscopy journal which had 4 studies, five randomized controlled trials, and the main difference was re-intervention rate. With EUS, it was 11% as compared to 17% with ERCP. Now, this was another meta-analysis, included one more trial from China, and the results showed that when you look at various parameters, technical success, clinical success, overall adverse effect, severe adverse effect, or 1-year patency, the two were comparable. However, the re-intervention rate, as in the other meta-analysis, was less with EUS CDS compared to ERCP. So what about the complications? I think pancreatitis is something which you avoid when you do the EUS technique, but at some expense of increasing cholangitis. If you look at these meta-analyses, I'm not going into the details of this, but there are a lot of limitations of those meta-analyses. So for jaundice and pancreatic cancer, for non-accessible papilla, EUSBD is preferred modality today, no doubt about it. For accessible papilla, ERCP continues to be globally the standard of care as of today. However, EUSBD, mainly CDS, is emerging as a primary alternative intervention where tertiary level expertise is available. And this is an emerging transitional zone where we are. Pancreatitis with ERCP and biliary leak and cholangitis with EUSBD continues to be the challenge. What about pain relief? Till about 20 years back, all my patients for pain relief will go to the intervention radiologist, and he or she would do it CT guided. So CT guided celiac block was the technique at that time. However, we have completely moved today from celiac axis block by CT scan or by X-ray to EUS guided celiac block. We know that celiac axis is located at that site, and there's a ganglion and there are splanchnic nerves, and then below that there's superior mesenteric artery and the broad plexus which is around this. If one has to learn an EUS intervention, I think celiac axis block or celiac neurolysis is the first one to do, because getting this anatomy of aorta, celiac axis uptake is usually very simple. And as you can see, that celiac artery is seen, supramesenteric artery is seen, and you go into the area between the aorta and the celiac axis. Now, there are certain modifications. We don't have time to talk about them, but central approach is the commonest approach. However, one can go bilateral on both the sides. One can approach the celiac ganglion, which can be visualized in about 70 to 80% of the cases. Some people have tried both ganglion as celiac plexus as well, and some people prefer to do a broad plexus neurolysis where you hit around the superior mesenteric artery with somewhat better results. Now, the overall meta-analysis shows that whatever technique you use, the results are almost similar, and the complications is also similar. The diarrhea in about 9%, temporary pain exacerbation 8%, and temporary hypotension in 6%. So you need to watch them for at least 24 hours after the procedure is done. RFA-guided celiac axis block is another thing which is coming, and maybe will be a way forward. Now, let me move to gastric outlet obstruction. Here again, there is a sea change which has happened. We were doing surgery maybe 20 years back, gastrojejunostomy. For the last 25 to 30 years, we have been doing duodenal stenting. But I think we have moved completely now again from duodenal stenting to EUSGJ, and we do on an average 1 case a week of EUSGJ in our unit. There are two major techniques. One is EPAS, where you use double balloon occluded technique. This is the one in which you use a double balloon technique, and this is what Itoi has been doing, but however, this is commercially not yet available. And so in our unit, we primarily puncture after putting an NBD, and this is how the steps are done, and you can achieve success in majority of cases. Now, we must not forget that these techniques come with complications. We also have our share of complications. Fortunately, the type 1 complication, there are 4 types of complication. Type 1 complication is that you have released the distal flange, not in the jejunum, but in the peritoneal cavity. This can be rectified. You can remove this and try once again, and we have done it a couple of cases. But other types of complications are more difficult to manage endoscopically, and you may end up doing a surgery in about 5% of these patients. So this is the data which was published from our center, including centers from other parts of the country, and this included about 71 gastrojejunostomies which were done. Symptom-free survival was 237 days. 2 years back, there was a meta-analysis which included about 8 or 9 papers which looked at all the parameters, comparing EUSJJ with duodenal stent, and look at the comparison. Most of the time, EUSGJ was better than duodenal stent. So in our unit, we use duodenal stent now only in 2 or 3 situations. One, when we have to go rapid in and out. When we have to complete the technique in 5 minutes, we still prefer endoscopic duodenal stenting. And second, when there is a significant ascites. then we prefer a duodenal stent. Otherwise, our first preference now is EUSGJ. The local endotherapy of pancreatic tumors, I think this is a list. Injection therapy, viral immunological vectors, ablation therapy, radiofrequency ablation and cryotherapy, helping the radiotherapy by fiducial marker insertion. Brachytherapy is coming in a reasonably big way. So what are the indications for EUS ablation? Predominantly neuroendocrine tumor, and the maximum data is on neuroendocrine tumor, though there are small series of pancreatic adenocarcinoma where EUS ablation has been done. We just heard about pancreatic cystic tumor. So this may be alternative surgery, but sometimes, or as a palliative surgery, alternative surgery, we do. So the techniques are either you inject alcohol, there are some data to say paclitaxel does better than alcohol, and of course RFA is there using the StarMint machine. When you talk of pancreatic neuroendocrine tumor, for functional neuroendocrine tumor, there's not much of a controversy because you don't need to achieve a complete cure in these cases, so you just remove the functional component of it, and even if you achieve about 80% success, this is the treatment of choice. But for non-functional neuroendocrine tumor, radiofrequency ablation is still controversial, but can be tried in single lesion less than 15 to 20 millimeter, no lymph nodes, and for grade 1 tumors. The technique is same as approaching any of the lesions. So overall, 6 months follow-up shows 71% response, disappearance of necrosis is 64%, decrease in the diameter in significant proportion, but about 25% failed. Now, as I said, EUS RFA has also been used in pancreatic adenocarcinomas, but in smaller series when the tumor is not resectable at all, then you can try RFA in this situation. Fiducial we don't do very regularly, but this can help us in getting a focused radiotherapy. Now, US-guided injection of anti-tumor agents for pancreatic cancer has been tried for quite some time, almost for the last 2 decades. However, they have never become very popular. This can include very engineered viruses, immunotherapy, and so on. But I just wanted to end with talking about Oncosil, which is again started by Dr. Bhutani in USA, and this is an Australian product now, Oncosil. This is actually a phosphorus-32 radioactive substance. It has been shown that if you inject locally and combine with chemotherapy, the results are much better than chemotherapy itself. So I think this is something which we are going to hear more and more in the coming days. So to save the time, if I have to give you a take-home message, endoscopy plays a pivotal role in the diagnosis of pancreatic cancer. I'm not touched upon that. ERCP is still used in the majority of cases to relieve biliary obstruction. USBD is an alternative if ERCP fails or the papilla is not accessible. For other complications, USM is emerging as a good alternative. USGJ for gastric outlet obstruction, celiac axis block for pain relief, RFA tumor ablation for neuroendocrine tumor, and sometimes for adenocarcinoma. Newer techniques are expanding the role of endoscopies in pancreatic cancer. Thank you very much.
Thank you, Mahesh, for that fantastic summary of a very, actually, a lot of data-driven data is there in this area, but you summarized it very nicely for the general audience. Any comments from our panelists?
That's a great presentation, sir, as usual. So my question to you is, what's your thoughts about RFA in this pancreatic ductal adenocarcinoma? Like, do you think that that makes sense?
I would reserve it for very, very sick patients who have locally advanced disease and who cannot be offered anything else. But I am not very much in favor of that. I think for neuroendocrine tumor,
Yes.
particularly functional neuroendocrine tumor, I think this is a way forward, provided the tumor is not too big.
Right. Do you have any thoughts on that, sir?
Actually, we published one of the first articles with Dongwan Seo on this, and like Mahesh says, the value is very uncertain. So the 2 main reasons why we used it was to downgrade the cancer, and when you downgrade and then chemotherapy, we are hoping that it prolongs survival. The short study showed it did, but we don't have longer studies. The second indication was pain. When everything else failed for pain in patients with this, when you do, because it hits the neuropathic on top of the tumor. So maybe, but we have to watch. We have very small series now.
Yes.
One more mechanism, it stimulates metabolism in the tumor and chemotherapy works better. That is also putative proposed mechanism.
But I don't think that last series which are available, Dr. Abhinav. Yes.
On the question of US gastrojejunostomy, jejunum being a very mobile structure, do you think that is the real life rate of complications are probably higher.
There are people who have done much more USGJ than I have been involved with, but I think that happens only in less than 5% of the cases. Usually you're able to distend and get a particular segment close to the stomach to do a gastrojejunostomy. You need a diameter and the length, and you need a particular way in which the segment should be there. So EPAS is not available with us, but most of the time with putting an NBD catheter and insufflating has done that way. Praveen, you want to add to that? And what percentage you fail to approximate stomach with the jejunum? I quoted less than 5%.
Yeah, I think that's correct. See, the whole point is one should not be desperate that if you're not getting a good window, if you're not getting a good distension of the bowel, then one should not attempt it. So I think once everything is as one requires, adequately distended bowel loop and the distance is adequate, so the chance of complication is quite less. Yeah.
Do you miss the EPAS in your practice?
No. Sorry? Yeah, but I think if we look at the evidence that we have that sir has shown, clearly now USGJ will be the way forward. Yeah.
I think Dr. Ongaya, excellent talk as usual. I just am interested about the injection therapy in locally advanced tumors. Can it be used as a palliation for pain relief?
Injection inside the tumor?
Inside, intralesional.
So I think for that, for the pain relief, the celiac axis neurolysis is the way forward. You don't inject inside the tumor to relieve pain for the celiac axis block. Would be
These
a better
ablation methods, so, microwave or other things.
Yeah, I think
also
most of the time the alcohol or paclitaxel, which I have talked about, has been used more in cystic tumors than in solid tumors.
Sir, again, in patients who are resectable, like surgically resectable, you have a curative intent or so. Even then it is less, around 12 to 25% they get cured. So this, the intralesional chemotherapy or biologically agents and all, do they show, I mean, even if you are, giving it to appropriate patients, do they show curative intent or what is basically there?
I won't suggest that somebody who is resectable tumor today should be subjected to any methodology which will delay the procedure. So I think only for borderline resection, one may try all these techniques and then they will filter themselves. Some will become unresectable over a period of time and few will become resectable. So I will never do these for getting better results out of resectable tumor.
So there are few reports regarding placing a PD stent in a patient who has got PDAC. And then there are reports that it improve the pain as well as the nutritional aspect of the patient in unresectable cases.
I would like to know the opinion of other experts, but I don't do that for relieving pain in adenocarcinoma, which is called ductal obstruction.
No more questions. If you should.
Thank you.
Excellent talk, Mahesh. Thank you.
May I request Dr. Mahesh Kumar Goenka sir and Dr. D. Nageshwar Reddy sir to please stay back. Meanwhile, I request other chairpersons to please move to the felicitation area. I now request Dr. Sanjay Banerjee sir to kindly declare the results of the competitive sessions.
So here is the result for today's abstract and video presentation. We had total 15 abstracts presented from all across the country, and our judges, Professor C.R. Panda and Professor Mollika Bhattacharya, took all the pain to adjudicate them for those papers for nearly 2 hours. And here are the winners. I would request Professor Reddy and Professor Goenka sir to come here to hand over the checks to the winners. The winner for the abstract is Dr. Akash Goel from Max Hospital, Delhi. His award is 20,000. He has presented a paper, Endoscopic Ultrasound Guided Lamps for Pancreatic Collections, Clinical Outcomes and Predictors of Necrosectomy. His mentor is Dr. Pankaj Singh. Next, the second award for abstract, which is rupees 10,000, and this goes to Dr. Abdul Rashid from AIG. Dr. Abdul Rashid, please come to the dais. He got the second award, and his topic was pain in chronic pancreatitis, multidimensional association with neuropsychological factors, neurometabolic alterations, and cortico-limbic connectivity. Now the best award for video presentation, and that award goes to Dr. Shashwati Kaur from AIIMS, Bhubaneswar. And Dr. Shashwati has presented a video, US-guided pancreatico-pleural fistulogastrostomy at salvage therapy in pancreatico-pleural fistula. And the award is rupees 20,000. So big hand for Shashwati. Now we move on to the next session, talk by Professor Reddy.
To chair this session, may I request Dr. Mohesh Kumar Goenka sir to please stay back. I also request Dr. Ashokananda Konar sir, Professor Dr. Anita Datta madam, Dr. Mridul Tatia sir and Dr. Shambho Samrat Samazda sir to please come on the stage and start the session. This is a very interesting session, artificial intelligence in pancreatic diseases.
So I think we always leave the best for the last. So Nagi, we are all waiting here to listen to you about artificial intelligence. AIG must be one of the rarest centers in the world where there is a department of artificial intelligence. And I'm sure what we are going to hear today will be some of the output from the department.
Thank you, Mahesh. Again, I'd like to thank the organizers for this opportunity to talk about artificial intelligence in pancreatic disease. If you look at what is happening in the field of artificial intelligence everywhere so much of noise. Newspapers every day carry stories about AI. In the medical field, every journal has got, and if you look at pancreatic and endoscopy journals, so many papers are there, especially in endoscopy journals. This is unfortunate because artificial intelligence means so many other things, and what happened in gastroenterology 10 years back was that artificial intelligence using in endoscopes picked up colonic polyps much better than regular individuals. And the commercial companies came up with this saying that okay, artificial intelligence is so good, so they started making artificial intelligence boxes and putting them to endoscopes, and they made a huge business out of it. And now 10 years later we realize that all that is a waste, that actually for polyps artificial intelligence has no role at all. So we got into a problem, and slowly other aspects of artificial intelligence in other diseases of the GI tract got neglected. Only now we are trying to sort it out. And my talk is going to be predominantly in the pancreatic disease. I want to start with a disclaimer that I'm not an expert in this area, that my expertise is using ChatGPT every day like all of you would do. And of course, I'm trying to explore this area more and more. So what I did was when I was asked to give this talk, I went into ChatGPT and put in it saying that I want to give a talk on artificial intelligence pancreas, and a fantastic summary it gave me. So most of this talk is partly based on that, so I'm biased in that way. And then it also asked me, shall I make the slides for you? I said, no, I'll make the slides myself. So this is the power of artificial intelligence now that we have. So just to give you a brief background of how it started, it was in 1950, actually it was Alan Turing who created this concept of artificial intelligence when he was trying to decipher messages that were going on in the World War II in German ships. He managed to do it, and he became famous because of that. During his time, he was not recognized as the father of artificial intelligence, but now he is recognized as that. And the word artificial intelligence was actually created in 1956 in a conference, and that time it was, in fact, they didn't know what it was. Even now we don't know what it is, the definition actually. It just means that artificial intelligence is a machine has an intelligence like a human being. Very simple. A machine has an intelligence like a human being. For several years after this was coined, artificial intelligence went into a winter period where nothing happened, 50s up to 1980s when machine learning came. And that's how it started picking up, and it was only in 2010 that when deep learning came, that artificial intelligence actually got into the picture. Now, for many years, I didn't know anything about artificial intelligence. About 3 or 4 years back, we hired a group of 40 Google scientists, engineers to come and work with us. And like Mahesh said, started this Institute of Artificial Intelligence at the AIG hospital. Over the next years, we became educated. And of course, what I'm going to do over the next 2 slides is to show you, give a basic education on that. This is what I learned. I'm sure many of you would want to know about what artificial, because the term is very attractive, but when you, what does it actually mean? So I'll just start with those 2 slides before I go into what's. So artificial intelligence is all about machine learning. And what we do in machine learning is very simple. We have these 4 things. You have variables, which means all the parameters, clinical parameters, radiological, whatever the parameters we have in medicine are called variables. These are put into a module called SHAP module, which analyzes the variables based upon its intensity. And we take this and put it into an algorithm. There are several algorithms, but the most commonly used one is the XGBoost in between. This is the whole framework of artificial. So what do? We take these variables, it can be bilirubin, SGOT, SGPT. It's put into the SHAP module, which actually prioritizes which is important, which is not important. We take the first 5 or 6 and put into this algorithm, which is, then the final result comes out under ROC, area under the curve. So this is all about what is done to create algorithms in artificial intelligence. And there are 2 types of algorithms. They are called foundational modules. One is called the large language models, and second is the computer vision. So just remember these 2 things. For medicine, this is enough. You don't have to know anything else about artificial intelligence. The example of large language model is ChatGPT. So what does it mean? ChatGPT goes and collects information from all the search engines. So if you ask a question to ChatGPT, in few seconds, it's able to get all the data from all the search engines and give you the answer. So this is classic example of chat. So the example of what we use for ChatGPT is, that is, for example, if you want to predict severe acute pancreatitis, if you want to predict which patients with walled off necrosis is going to get infected, this is where we use large language module algorithms. I told you earlier how they created the engineers. The second component of foundation model is computer vision. Computer vision module actually goes a little different pathway, but ultimately what it does is, it's a vision. It recognizes polyps, malignant polyp, benign polyp, early gastric cancer, CT scan. And in the pancreas, it's predominantly used for pancreatic cancer and pancreatic cystic lesions. Both these together can be combined, and what we have is a multimodal models. So what we use now in artificial intelligence in pancreas is predominantly multimodal models, where clinical data, the laboratory data, and the radiology is combined together to give you a final picture. So this is all about artificial intelligence that you should know about. Subsequently, I'm going to give you examples of how it's used in different aspects: pancreatic cancer, cystic lesion, US, acute pancreatitis, and so on. So let's look at each of this very briefly. And this is just to summarize the current knowledge. There's a lot of data in each. I don't want to confuse you, but I'll go very simple. In 2019, this patient came to me with little dyspepsia, starting to slightly lose weight. I investigated thoroughly, did all the scans, including a CT scan, which you can see the pancreas, in fact, looked a little atrophic, normal. Patient was on follow-up. Later on, I didn't do much. And in 2022, when he came again with severe pain increasing, now developed new onset diabetes, a CT scan showed this large mass in the pancreatic head region. Inoperable, only palliative therapy could be given. I felt very guilty because I thought maybe in 2019, if I could have identified something there, I would have very early stage prevented this going to cancer. So I actually asked my radiologist, a very good radiologist we have, an abdominal radiologist, to look into this. She saw this and said, nothing is there, I can't see anything in the pancreas. We have a tie-up with Mayo Clinic, so I sent it to the pancreatic department, the radiologist there. He looked at this and said, no, nothing is there, it's normal pancreas. We then gave it to our artificial intelligence engineers who work in our department. They put this into AI algorithm, and AI said there's a potential of this patient developing a pancreatic cancer. There was something in this CT scan which we all missed, which the AI picked up. What was that? And now we know that AI has the capacity to pick up what are called PANN-3 lesions. PANN-3 lesions are the earliest lesions of pancreatic cancer, and it takes 3 to 4 years for cancer to develop after PANN lesion come. So AI is now picking up PANN-3 lesions. And now in our hospital, we have a more policy, more and more to use this with all CTs suspected. So if we have a clinical suspicion CT, even if it looks normal, send it to AI, and they have capacity to actually now diagnose early. And this was illustrated in this very large study that came in Lancet Oncology a few months back, where they showed this panorama study, it's called, how you can actually pick up pancreatic cancers very early, even before the naked eye. So this is one example. Not only can you pick up pancreatic cancer, but also, as you can see from this, you can actually differentiate between ARP, chronic pancreatic inflammatory mass. One of the commonest problems we have in clinical practice is patient who comes with a pancreatic mass. Is it autoimmune pancreatitis? Is it inflammatory mass, chronic pancreatitis? You do USFNAs, still not very sure. The pathologist is not very sure. In this type of situation, again, we have found, we are now doing a prospective study. We found that AI can, for some reason, differentiate between these three lesions very easily. So, and look at this, how AI is, we are looking at radiology residents we looked at, and you can see AI can dramatically increase a novice endosonologist from actually picking up a lesion. They increases 20% chance of better lesion. So this is very important. The other important thing is in patients who have a pancreatic mass, we actually ask our pathologist to come. She has a microscope there, sits and does a ROSE, looks at it and says. But this is not always easy, difficult to get a very expert pathologist, takes some time, and even she can be wrong. But now we have AI, this is something we just started recently, AI ROSE now. In AI ROSE, what happens is, you just make a slide at the US, make the slide, put it under a microscope, and then the AI will read the slide for you and say that this is the probability of pancreatic cancer is so much. So it becomes very easy then for us as endoscopists in the US room, we just take this FNS, put it there, and the AI will tell us probability of pancreatic CA so much. So this is now again going to become a routine practice once these algorithms develop. So come to second, this is pancreatic cystic lesions. And pancreatic cystic lesions, we heard a lot, very nice talks now. This, I think, Sun Moon and Sukrit and all have talked to us. What we require mainly in pancreatic cystic lesion, we want to know whether it's mucinous, non-mucinous. Because mucinous is dangerous, non-mucinous is not dangerous, you can observe, that's all. It's so easy. So, but we have been struggling, struggling for many reasons to differentiate. And then we have all these worrisome features, then we have high-risk stigmata. All this confuses me, as I'm getting old, I can't remember many of these things. So can it be easier for me? So that's what we're looking at. So now there is deep learning algorithms which you don't have anything, do an EUS, and on EUS you can immediately know whether this is a mucinous or serious condition, non-serious condition, right? And going further, IPMNs are the commonest lesions that we see. And you have branch chain, main duct, and one of the problems with IPMS is the limited sensitivity of USFNA, and again, you add these algorithms of worrisome lesions and all. Is there any way of making it easier? And this is a paper which was published, actually was an abstract this year at DDW. Very easy. All you have to do in IPMS is high-grade dysplasia, or is it low-grade dysplasia? And actually, you can stratify this by putting in certain, again, you can see that we are putting inputs here, and finally it comes out saying whether it's high-grade or low-grade just based on the lesion. And this is extremely very high sensitivity and specificity. Almost you can see 0.9. So therefore, it becomes very easy. You don't have to go through all. So my belief is that in the next 4 or 5 years, all these pathways for IPMNs are going to go off. No, we are not going to go through all this high-risk criteria, worrisome and all that. AI is going to take over in this area completely. So you can see now again many papers are coming up this because in US with cystic lesions, there's operator dependency, subjective interpretation is very time consuming. So this was a study which actually looked at using CNN. CNN is a type of AI we used for computer vision. Looked at a large number of, you can see 3,000 versus 1,000 mucinous, non-mucinous, and with a very, very high accuracy it could differentiate. So this is becoming standard now. For our AI engineers, it's extremely easy now to differentiate using this algorithm because it's very simple algorithm they're using now. So I think this is again going to be in practice. Now coming to US and pancreas, I think endoscopic ultrasound has a huge implication like CT scan where you can apply. And one of the first areas where this has been done is training. So when you train for endoscopic ultrasound, you have 6 stations, 1, 2, 3, 4. We tell our trainees, you go to station 1, station 2, station 3. This is what you see in station 1, this is what you see in station 2. So we do that. But very often, the novice who's just learning misses 1 station, 2 stations, misses the finding station. All this can now be corrected using AI, and the trainee can be told, look, you 62% only, you missed 90%, and using AI, he can better it and make it 90% accuracy. So you can see this is going to be very important. The second area is US mass detection, and this is a very nice paper which came from Shyam Bardaraju's unit in Orlando, where they actually used US and a system. They now have this system where it's a pancreatic US AI system, and they found that actually, you see there, using this system, the red one is the tumor, the green is the normal area. And what they found was, when they find this tumor, they take biopsies from this. And in this particular case, they actually found a small additional lesion which was missed by standard US. And biopsies from this showed it to be a pancreatic cancer. So you can now combine US, contrast enhanced elastography, and patient clinical data in so-called multi-modal model to get your accuracy jumps from 70% to 94%, 20%. This is huge in terms of what you're doing. So I think this is something that's going to come up. There are, of course, certain problems that you have to feed in the right data to get the right output. In gastroenterology, this is very important because otherwise you can get a wrong diagnosis. Now coming to another area, and this is an acute pancreatitis risk and one infections. This is a very difficult area for us as gastroenterologists. For example, how can we predict which patients have adverse clinical outcome? This is based on, again, multimodal, the CT scan pictures and clinical variables, WBC count, albumin, and so on. We can now very accurately predict in the ICU which patients of acute pancreatitis who are admitted in the ICU can go into serious cases or those who, so you can triage very easily. So this is the app that's available now for many of you. You can start using this app. It's called the Easy app. Peter Hage from Hungary actually made this app, and we are actually using it also, sort of refining it further. So you can see that this app uses acute pancreatitis clinical data. It can predict which patient is likely to go into severity and which patient. So you can download this app and start using it in your, it becomes very easy. You just have to put in certain parameters there. So this is the sharp diagram I'm talking to you about. This sharp value, actually, we take 1, 2, 3, 4, 5, 6, put it into the system, and then you can get a score to say which patient can develop acute necrotizing pancreatitis, because ultimately the prognosis depends upon whether the patient develops necrosis or not. And this necrosis can be predicted very easily using this system. In fact, this is again a system which predicted which patient with necrosis can get infected. So see that which patient is going to become serious, which patient is going to develop necrosis, and which patient is going to develop infection in the necrosis. For all this, we have models now. Very easy. You don't have to keep all the scores, Apache scores, all this, and try and remember. With AI, it becomes very easy. So this is again a large study which came from China, which actually showed that you can now predict necrosis, and of course you can predict further prognosis based upon a model which uses all these multiple data. This is a multimodal. We know that about 10% of patients with acute pancreatitis are going to die, and again we can't predict. This is again very surprising that using these models and using a variety of techniques, again you can see the sharp diagram here, using various parameters. Here is respiratory rate. Earlier it was hematocrit. Using these parameters, the first 6 parameters you feed into these algorithms, you will immediately tell you this patient is likely to develop problems and have a high mortality. Again, very, very useful for us. Post-CRCP pancreatitis is a problem, again, sometimes difficult to predict. In fact, working with one of my colleagues, we made this algorithm. This is an app that can be also downloaded, and you can actually put in this and it gives you a 25% negative predictive value. This is mainly what we developed so that patients after ERCP can be sent home. Sometimes you send them home and they come back with severe pancreatitis after 6 hours. We don't want that to happen. So with this app, using AI, you can predict which patients are likely to develop pancreatitis. And even now, very interesting, this is a Chinese study which looked at just the papilla. You capture the papillary picture and artificial intelligence will tell you which patients are likely to develop post-CRCP pancreatitis. In fact, several years back, when somebody asked Guido Costamagna what causes post-CRCP pancreatitis, he said nobody knows. Sometimes one of his friend, even if he looks at the papilla through the endoscope, he develops post-CRCP pancreatitis. No need of touching it. So this is an example of how AI can determine which patient likely to develop. So if you see this type of papilla, don't touch it. And the other thing is, AI can also help us to predict compliance to pancreatic enzymes. And this is a study that my colleague Roop had done. In fact, using this, again, the SHAP diagram, he showed that those who are graduates, undergraduates, had a better compliance than those in the rural areas. And he made this into a graph which you can use in clinical practice and then plot out and say which patients are likely to be non-compliant or compliant. And finally, the last is predicting pain relief in chronic pancreatitis. We had a lot of discussion in this. We don't know which patients are going to get relieved, which patients are not going to be difficult sometimes. Again, using this, we have a technique. We can actually say that after you clear the pancreatic duct, either endoscopically or surgically, there are certain parameters which will result in pain. And based on this SHAP diagram, we can do this very easily. And we just published this where we showed that what can predict pain relief in these patients. So finally, I think then a lot of people tell me all this AI stuff is getting a problematic. Are doctors going to lose their jobs and all? No, doctors are not going to lose. Pancreatologists are not going to lose jobs. What is going to happen? That doctor who knows AI is going to replace doctors who don't know AI. Believe me, even at the age of nearing 70, I want to know about AI because next 5 or 6 years, I don't want to lose my job because only doctors who know and practice AI are going to survive in future. As Charles Darwin famously said, it's not the strongest of the species that survives, not the most intelligent, but the one most responsive to change. And I found that in our institute, the most responsive to change were not doctors. They were actually the nursing staff, the lower clerical staff who wanted to change. For the doctors, it takes a lot of time, lot of resistance. Unless they know the importance, they don't change. So I think it's time that all of you here, doctors in clinical practice, should start thinking about AI, read basics of AI, and it's going to, over the next 5 years, going to make a very important impact in our medical practice. Thank you.
Any quick comments from anybody? Nagi, can we call it AIG as Asian Institute or AI in gastroenterology?
We named it, I think rightly it's, now everybody is getting into the bandwagon, everybody is very enthusiastic and we have, I think it's important that we start from maybe now MBBS curriculum itself to incorporate AI into that. Otherwise, all these mathematical things look very complex for us as doctors and unless a lot of effort, we can't get.
Sanjay, should we conclude or you have to make any comment?
So, regarding the device, we know that we have a very strong regulation device, like to do some trial. So when you are using certain AI app, so whether you think that we also need to validate, especially when we are depending on our Western population-based algorithms.
Yeah. So I think this is a very important question. There's a fortunate side about it, unfortunate side. The fortunate is the government still doesn't anything what is happening. So there's no regulations. Otherwise, if we give them the chance, they'll regulate everything and bureaucracy will start. So they don't know what these algorithms are, how they're trying to study, they don't understand. Hopefully by that time we'll get a mastery over this. So the unfortunate thing is because they're not properly regulated, suppose you try and adapt Western algorithms, it's totally different. It doesn't. All these algorithms have to be built by us, the large language module algorithms. The government of India has now allotted 10,000 crores and large part of it is for health, some for agriculture, some for education. We can apply for that. They want to develop large language model algorithms of different areas in our country. And there's a great opportunity for all of us to utilize that. We have to develop our algorithm because there's a huge demographic, genetic variations, geographic variations in different regions, and what algorithm in Western world does not apply to us. We have to make our own algorithm.
Sir, I don't know how to express my gratitude hearing your speech or lecture. Sir, I actually want to know whether it is really helpful for us, for the clinicians, but in particular, because it, in many times, it actually minimizes the time to the clinical diagnosis.
No, it's extremely helpful. The reason why we are hesitating, we don't understand it. We think it's engineering, we don't understand it, but when you start applying it and using it in situations for prediction, for example, it's extremely useful. And for example, of course, this is out of pancreas, drug discovery, Recently, a vaccine for pan-virus vaccine was, because of using AI, they could develop it in 1 year. It would have taken 40 years to develop. So there's a huge usefulness. We doctors, especially after a certain age, are reluctant to go into this. That's the reason, but believe me, it's extremely useful.
Thank you, sir.
Thank you, everybody, and thank you, Nagi, for this talk. And with that, we close this meeting.
Now, may I request Dr. Sanjay Banerjee, sir, to kindly felicitate our esteemed speakers and chairpersons. Now may I request Dr. Sanjay Banerjee, sir, to give the final vote of thanks.
As we come to the conclusion of this scientific session, it's my privilege to offer a few words of gratitude and reflection. Over the past few hours, we have witnessed stimulating discussions, insightful lectures, thought-provoking debates, and valuable exchange of ideas. The meeting has successfully fulfilled its objective of advancing our understanding of pancreatology and fostering academic interaction. I express my sincere gratitude to all our esteemed speakers, moderators, panelists, who generously shared their expertise, experience, and wisdom. Their contributions have enriched the scientific content of this meeting immensely, and this hall full of attendees is a testament that their effort has been successful. My heartfelt thanks go to all delegates, all participants. Your active engagement and enthusiasm transformed this meeting from a series of lectures into a vibrant academic dialogue. I congratulate the organizing committee, the scientific committee, all the volunteers whose dedication and hard work made this meeting possible. I acknowledge the support of our sponsors, our industry partners, administrative staff, audiovisual team, and the venue personnel at Taj Talkutir. Their cooperation ensured the smooth conduct of the program. Now finally, science advances through collaboration, curiosity, and continuous learning. I hope the ideas generated here will stimulate further research, improve patient care, strengthen our professional relationship, and next year we'll come up with a bigger show. Thank you very much. Please, all of you, join us in dinner. Just two announcements. There is a QR code on the back of your badge. We will be uploading all the photos tonight. From tomorrow morning, please don't throw it away. From tomorrow morning, you scan this code, you will get all your pictures with AI recognition of your face. And number two is the CME credit of 4.5 hours, so we'll be sending to your respective numbers. Those who have entered their attendance, we'll be sending to them. You have got it? Those who have not got it, we'll be sending to them. It's available in the registration desk, you can take. Okay, thank you all.